Hello, hello.
Oh, what is the... why?
Hello, hello.
ஆமா.
The only question I want to know. But that is normal. Is my centration right?
Okay. So I had to visualize here. So they have to shift to, yeah. So now it's central, visible, sir.
Bring it.
It's fine, madam, don't worry.
Central screen is
Is everybody able to see on the
Hello?
live over there?
Sir, yes, sir. In the side screen, we are able to see.
Please, when we talk, please answer from there. Otherwise, you may not know whether you are listening or not.
What I'm
Showing, sir.
Lovely. So what I'm showing you is how to make the flaps in the fastest way possible using the glue dial marker. This was designed by Epsilon.
Why there is a line on the screen?
So the main screen is yet to come, sir. Side screen it has come.
But side screen, grains are there, no? Why?
No, sir. The side screen it's very clear.
Very clear, okay.
Any main screen is yet to come.
Okay, fine, no problem.
So if you can see here, what I've done here is I've made the flaps using a glue dial marker. This is made by a company called Epsilon. I have no financial interest with them. And once I've made the flap, this is by a 2 by 2 millimeter size. Once I've made the flaps, what I'm doing is used a partial thickness flap using a crescent blade. Normal crescent blade, how I do a trabeculectomy, probably the size of the trabeculectomy is larger. In this one it's smaller, and made it 180 degrees apart. Then I placed a trocar AC maintainer going through the sclera. If you can see here, it's about 0.75 to 1 millimeter behind the limbus, and going valvular approach into the anterior chamber. This gives me continuous infusion inside the eye and also keeps a taut eyeball. I think that's the most important. I have chosen this case for two reasons. One, because it's a smaller pupil, and it shows the difficulty as well as the advantage of having a smaller pupil in these glue dial cases. So I'll tell you about the advantages later. So what I'm doing now is lifting the flap and showing you a sclerotomy that is being done about 0.75 millimeters behind the limbus. Direction of the needle is behind, directly to the center of the eye. Increase the pressure of this thing. So center of the eye, gone behind the iris, you can see the needle come out, and that's it. That's my sclerotomy that I need to make in these cases. Second sclerotomy being done is a little more difficult, because if you're a right-handed person, then the non-dominant hand obviously becomes a little more challenging. But again, your direction is very, very critical in these cases.
What is it you're using? You're using a...
This is a 23 gauge needle.
23 gauge needle.
This is a 23 gauge needle.
Not a merigotomy knife.
No.
Okay.
You can use an MVR blade, but I like to use this because it closes the wound faster, better, and also allows the traction of the glue dial forceps inside. What I'm doing now is making my side port entry. I just need a side port entry on this side and a main port on the other side. After I've made these two, all my incisions are ready. So the incisions in these cases are two sclerotomies, one trocar AC maintainer and main incision and a side port. That's all I need for any glue dial case. That is a pure glue dial case without any other combination procedures.
Ashwin,
So,
just give me a minute. Good morning, friends. Good morning.
Good morning, sir. Good morning, sir.
Welcome to the 8th edition of the Surgical Strikes, and we have the opening batsman as usual, Ashwin Agarwal. He is going to demonstrate to us a glue dial. Already he has taken the flaps. We are looking forward to a great surgery from him. And the panelists are Dr. Lalit and Dr. Srinivas Rao. And
morning,
what about the other?
They are on their way, sir.
On their way.
Lalit here.
Yeah. Thank you Lalit for being here. Srinivas Rao, thank you. And over to Ashwin, and then after we finish the surgery, we can ask some questions. During that also, you can any questions from that side, you can do that. And after this surgery, we'll tell you the sequence. Aditya Varman will be doing a signature pro with phaco with high hands, and then subsequently I'll be doing a femto. We'll tell you, but I think more people are coming in. And Ashwin, thank you very much for the wonderful demonstration of these flaps and the glue dial technique, which has been popularized by Amar and your group. And over to you, Ashwin.
Thank you very much, sir. Honestly, we can ask questions even in the middle, no problem. I'm happy to answer them. So what I've done is just taken off the epithelium so that the visualization for you guys is improving. Obviously, I would have loved a little bit better red glow so that you could see what's happening. But let's see. This is a 25 gauge vitrectomy cutter. And what I'm doing is doing an anterior vitrectomy. It is already done anterior vitrectomy before. Needle. So sometimes this can happen. Huh?
Sir, are you using that anterior chamber AC maintainer? So?
Yeah.
So that is an anterior chamber
This
maintainer.
is a PACM. Okay. Trocar anterior chamber maintainer.
This is 23 gauge needle.
Yeah, 23 gauge.
It's a good improvement.
So as you can see, I don't actually need to do this because this is already vitrectomized eye.
Yeah.
But I am showing you what we need to do in these cases is basically ensure that you
So you
visualize.
don't use tricot, is it? You use a tricot or? you don't?
I usually do, but
Yeah.
only in cases where there is already no vitrectomy done. So
Sir,
what
it's visible in both the screens, sir.
lovely.
Thank you very much. Very nice, very nice.
Clarity is outstanding.
Yeah.
I think we cannot expect anything better than this. It's
Fantastic, fantastic. Thanks a lot. I wish
So what I'm doing now-
the audience.
What I'm doing now is actually just showing you how I do an anterior vitrectomy in these cases. You have to visualize. Although I like to put iris hooks in these cases, but sometimes, you know, when it's a small pupil, that has great advantage in not doing a SFT at the end. So that's why, no. Yeah.
So, do you use tricot for these cases, sir?
Usually I do, but this is an already vitrectomized eye. If you can see, this is already an aphakic eye from long before. Vitrectomy is already been done.
The problem sometimes when you use tricot, that
Your vision
you may lose the red glow also. But
No,
do you think it's necessary for a glued IOL?
it is necessary in case you have vitreous from before. For example,
I'm talking about the red glow. Is it necessary? I'm asking.
in a glued IOL, you can get away without
Get
the
away,
red glow, but it's always nice.
Can descend into the vitreous.
Yeah, it definitely hampers the view, not just from the vitreous body, even from the anterior chamber.
Yes, that's what I'm asking. Yes.
Yeah, definitely has a hampering effect.
Since already it's a vitrectomized.
But you see now, the advantage of using the trocar is my one hand is completely free and it's away from my sight of wherever I'm going to implant this lens. So what I'm doing now is inserting my glued IOL forceps, opening the jaws and keeping it ready. This is what I do in all my cases. Nothing changes. The steps don't change.
What is the lens you're using?
This is a Sensor 15 power lens. So this
15
is a
power.
myopic patient to an extent. You can see that with the deep chamber. And now my assistant here is going to help rotate that sensor because it is a rotating and not a plunger system. Once I have the haptic tip in my view, I grab it as close as possible to the tip, and while she's inserting, I am externalizing this haptic. Although this looks to be rather simple when I'm doing it, but it's actually a lot of coordination work, like you're releasing the clutch and pressing the accelerator. So it's almost on the same lines of that. So see, the advantage of doing it without iris hooks is that I still have a small pupil at the end of the case. I do go behind.
This is handshake technique. Yeah.
This is the handshake technique. I've inserted my second haptic inside the eye, handing it over to my left hand, going through the sclerotomy on the opposite side, ensure I can see the jaws opening, grab the tip of the haptic and just bring it out.
Sir, excellent coordination. It looks very
Beautiful, beautiful, beautiful.
Once you're done with the haptic externalization, it takes a minute once you've gone through the procedure many times. I usually close the wound because in some cases I do have a scleral wound versus a wound like this. And once that is there, I close this wound. Forceps change, not working. Once that is there, I make sure that I can suture this up and get a taut eyeball again. Why do I do this? Now the question is, why do you close before you...
Don't put the slide now, please.
The reason you close before you...
Ravi,
Yes, sir, yes, sir.
remove that slide.
We're taking care, sir. Just a minute. You carry on with the surgery, sir.
When I'm making... Why am I closing this?
Why are you putting that slide?
Suture.
No. Putting that logo. Side. Side la varthu. Yeah. No. Why are you putting only for the main port you're putting, no?
Only for the main port. Side port is not required.
No, two sutures you put, no?
One suture is all I need, honestly. In fact, even this suture is only a stay suture. I don't actually need it. The reason I do it is only so that I can make the tucking of this easier. The tunnel creation over here can depress the eyeball and that releases some fluid. That's the only reason you actually put the suture in place. Otherwise, I usually even sometimes do a wong in these cases. And what I'm doing now is lifting the flap. Now this is very important to understand how to make this tunnel. You go alongside the haptic at the base of the flap. You find the base and go at the base. Intrascleral tunnel is what we want to create. Once we have created, bleeding from the site is a good sign. That means it will fibrose well and it will hold that haptic in place. And you can blanch this and see the depth of how far you have gone. That shows a pretty deep, nice.
Do you put just trypan blue in that needle so that you can know where the tunnel is?
No, immediately
Saline.
is inserting.
Okay, immediately it's inserted.
Welcome Dr. Meena Lakshmipati from Shankar Netralaya, our panelist for the day in the cataract session. Welcome Dr.
Welcome, welcome Meena, welcome all other panelists as well.
You go ahead.
Yeah, go ahead.
So what I'm doing here is again on the opposite tract.
I think this is the most difficult.
This is a quite a challenging one and more confusing as well. So what I do is I first ensure that I can release a little bit from here. So I get enough. So here's the trick. People will try to hold this flap in this direction, but in fact you should go in the opposite direction. So while you're holding, you can also pull and expose the sclera a lot more.
Sponge panuma.
And once you have this, now you can hold this like this, you can hold it like this, but those are both wrong. Hold it in a perpendicular.
Yeah,
It's
correct.
completely in the opposite. So what happens when you go back, it goes down into the tract.
Excellent.
Beautiful, very nice.
And it goes smooth. So you can now swap hands and smoothly transition that into the tract. Once that is done, you're pretty much done with the case. You don't need anything anymore. The advantage of using a trocar, now you will understand the advantage of using a trocar AC maintainer in a valvular fashion is this. Give me the bud. So here what I'm doing now is taking this off, and you can see that the eye maintains its rigidity or its tautness. I also do a tract fill just once to ensure that my eyeball is taut.
What is that?
So I go through the scleral wound
Yeah.
just to hydrate just a bit.
Okay,
So it hydrates the tract. This is basically a stromal for the tract.
okay.
You don't need to do too much because then you can have chances of overfilling this anterior chamber. See like what is happening right now, especially in these myopic patients.
Yes.
This can happen a lot more. You don't want to have too much of filling in the anterior chamber. So what I do is go in posteriorly, push some fluid in the posterior. So that gives the tautness of the eyeball. And my eyeball is really taut.
You don't put an air bubble there?
I don't put an air bubble, sir. Sometimes it's air bubbles-
Our puts no normally.
Yeah.
Yeah,
Different
that's what I
circles,
asked.
sir.
Dr. Ashwin, Dr. Lalit here, I just had one question. Which lens, according to you, is the best for this kind of a procedure? Sensor is one option.
Yeah, sensor is probably in the market availability wise, definitely that's the number one. I would also choose Zeiss sometimes, Zeiss 603, but they're not available.
What about the MA60 of Alcon?
Yeah, that's
Horrible lens.
Horrible lens.
Sorry, I like Alcon as a company, but that lens
Sujatha
for
uses
this
that.
procedure is not great.
And what about the Orolab 3-piece? We use it
The-
once in a while.
Yeah, Orolab is not bad, at all, and we can use it.
What about Bausch and Lomb, the soft port?
I think it's a good lens, but it has one issue.
Polyamide haptics, no?
Yeah, the haptics are not great, and the injector system comes out too fast sometimes. That's the only difference.
Well, why don't you like MA60?
Sensor most of the time. is
The
available.
haptics are very brittle. It breaks in pieces, and you can't do anything once it's.
So sensor is the best.
Sensor is best in terms of availability and in terms of strength.
The only thing is I find that sensor is the overall diameter is less. So vertical fixation is probably what we have to do all the time. So using an MA60, even horizontal fixation is okay. Isn't it?
I don't agree with that completely because I only use sensor in horizontal.
But most of the times you're doing vertical fixation.
Okay, one question, Ashwin, beautiful demonstration. Since it's a myopic,
Yes, sir.
do you think you should go a little anterior?
I would
Talk
have.
to me.
It's a very good question.
Yeah.
I would have gone anterior.
Yeah.
The only thing in this case was it is 11 millimeter white to white.
Okay.
So in a case where I saw, I can show you again, give me caliper. So in a case where you have a white to white more than 12 is
Yes.
when I like to go that anterior.
Anterior.
So this
Or
is
do you do
11.
vertical? When do you do vertical?
I do vertical if it is above 12 or if there has been a dislocation from before.
Yeah.
So if there is a history of dislocation from
Now, how do you avoid this pupillary capture when you go anterior?
So the way to avoid pupillary capture is by
So, Ashwin, one last question before we go on to the next case and probably the thing. And I just want to know well, suppose you have a PCR on the table. Yeah. Do you will do a procedure or you would like to wait after a couple of weeks and do it? I would like to do it immediately. If you do, not giving a day. If you give a dose, we can do it. Yeah. But if you do on immediate on table get a PCR, please go ahead and do a fluoride immediately. It's much better, much faster to resolve than to go delay reading the high female and whatnot. It's better on the do. Welcome, Kiranjit. We all know is from America, Existing Eye Hospital, and he is a big proponent of iris claw lenses. So, suppose I know you do an iris claw lens. Which is easier to do? Is it easier to use now or fluoride?
I have a PCR. First, I try to put the lens in the sulcus. Even if that is not possible, then I'll do a RF fixated, retro RF fixated lens. Yeah. That takes hardly 1 minute or so. Yeah. And it does not invite any complication. Dr. Ashwin, Dr. Amar Agarwal, they are two people in their technique. But for common ophthalmologists, they encounter problems. So, one of the problems quite common which I have heard is suprachoroidal hemorrhage, which happens when you give a stab. And very lately, as of I'm concerned, I am doing a interior fixated lens, iris claw lens. Yeah, today I'm going to demonstrate. And in a case, the kilo below 300 or 400, and the patient has got a job fully done, and the pupil is thick mid-passage pupil, roaming around in the interior chamber. In the specific lens, which makes our defect has been much more comfortable when he's doing a defect. Yeah. Because for temporal, you have to have a lens in the pupillary area. Ashwin has to leave. Absolutely. What are you saying?
No, I'm coming here. Yeah. All the way from Bilaspur, and Sendil Nathan, our oculoplastic surgeon, please come forward. Kiranjit Singh, and we go on to the, Ashwin, you say a few words.
I just want to say thank you so much, Rajan sir and madam. This surgical strike or conferences like this are so critically important that people sitting at home, sitting in their houses also can view this online through their YouTube channel, and people sitting in the audience can ask questions. There is such depth of surgical procedures that have come into the ophthalmology space that everything shown under one day is critically important, and such a beautiful way that you've been doing it for the past 8 years. It's amazing. Thank you so much, man. Thank you, sir.
Thank you once again for being a part of this.
Yes.
You've done an excellent job.
Excellent
Amazing,
job, as
amazing.
usual. It is great. It's
It's
been
really very beautifully handled.
Great
Danny.
opening start, and we go on to the next surgery by Aditya Varman.
You just were answering this question Ms. Venkatesh sir asked. So if it is, sir, I would put it this way, if it is a very dense nucleus drop, the nucleus is very dense, I would avoid putting the lens on the same day, because sometimes the VR surgeon would not be able to remove the lens using the cutter or phacophragomatome. In such situations I have to make a big
Introduce.
Next.
Let me introduce Dr. Aditya Varma. It doesn't require any introduction because he is better than the best. As you all know, the best is already there. Arul is there. Arul's son Aditya Varman is for the second time. Last year also he did a fantastic surgery. Today also he is going to do a fantastic surgery, I'm sure. And he is going to demonstrate phaco with Signature Pro machine and Hyan's lens.
Right.
Over to Aditya.
Morning, sir.
No?
Yeah.
Okay.
Am I audible?
You're
So I'm going to start my case here by making a mark for my incision. This is a specialized incision marker that I place here. Next 2 marks in the cornea, one on the limbus, 1.25 millimeters.
Doctor, can you bit focus more?
Am I audible here? Am I audible?
But
Hello?
screen, the focus
Hello?
is a bit more.
Hello?
You have to just find.
Yes, sir, the focus required.
No. Is he audible?
Very much audible, sir, very clear.
Ravi, I request you to keep talking from there.
Yeah.
Because
The
otherwise we will
panelists
not
are talking
cover
here,
your-
sir, don't worry, it's everything clear.
Yeah, please,
Dr. Aditya can
keep
proceed to the
telling-
surgery.
From
Yeah.
talking from there, and even the panelists and the moderators
a
can do.
little bit of fine focusing, sir. That is
Yeah,
what we were
fine,
requesting.
please
Yeah.
tell us, otherwise we will not know.
Yeah, so I'm just making my first mark here on the incision marker. Make a groove, and I follow the mark made in the 1.25 millimeters in the clear cornea. So we can just enter, go open the cornea, tip down,
What is the incision size? 2.2 or 2.8?
2.4.
2.4.
So,
Yeah.
the audience, that was a Thornton fixation ring that you used to take fixation.
So I'm using some dye here just to ensure I have better visualization of my rexes.
What was the instrument that he used to make that incision?
It's a customized instrument, ma'am. So this is something we've designed, made by Biotech. Viscopa.
Is that for you to
Side
make a
port?
square edge incision?
Right. So I like to use MVR blades to make my side ports. So I just make them in a place where it's comfortable for me. No real clock hours. Yes, sir.
Little louder, please.
Yeah.
Aditya, what is the side port instrument you used?
MVR blades, sir. It's an MVR blade.
23 gauge?
Yes.
You do bimanual or coaxial?
No, sir.
And
Coaxial.
also, we'd like to know about that keratome, like, if you when
So I like to fix my eye here before I do the rexes. And just focusing here now again.
Dr. Ravi, are they able to hear us there?
But is it a myopic eye? Looks pretty deep, is he?
What is the power of the lens now? Normal eye.
Normal eye, is it?
20.5.
So
doctor,
again-
you always take a limbal incision or a clear corneal incision in all your cases?
Clear corneal, sir. So the first mark starts at the limbus, and then the second mark goes 1.25 millimeters in the clear cornea.
Yeah.
So you get a nice square shaped incision there.
Srinivas,
Yes, sir.
actually you start the incision from the anterior limbal vascular arcade. Mild oozing is there.
Okay, sir.
That actually aids the vascularization of the wound instead of being a perfectly clear corneal. Okay?
Okay, sir.
So this actually is a good incision to make. Only sometimes, if a little posterior, sometimes there can be ballooning of the conjunctiva.
So what viscoelastic you have used for
HPMC, ma'am. Just HPMC.
2% HPMC that you
So much.
Beautiful rexes are there.
Thank you.
Very nice rexes.
So this letting out some visco before you do the hydro.
So beautiful, well-centered round rexes.
So again, the trick in hydro is not to involve any cortex. Just slip under the rexes, lift up the rexes, then do the hydro. You see a nice wave go behind. That's all.
Yeah, beautiful. Cortical cleaving hydro.
Dissection, yeah. Again, this is using HPMC again here. You can use sodium hyaluronate also if you want to, but I'm quite comfortable just using HPMC.
How do you size your rexes? Because when you use the Utrata,
Yeah.
you have markings on the Utrata where you can size your rexes. When you
Right.
use the needle, you have any technique where you size your rexes, different sizes?
Honestly, no, sir.
No, so it's more of experience.
Correct, yeah. So again, I'm using the Signature Pro machine here. It's a specialized tip I'm using. It's called the EDM tip. I'd like you to pay attention to the shape of the tip. You see, it's kind of shaped like a bulldozer. So this actually helps you in creating a trench if that's the technique that you would like to use. So what I like to do is I usually clear out that first superficial cortex.
What chopper are you using, Aditya?
This is also again a customized chopper, sir.
What
So
chopper is
it's-
different from the regular sharp chopper?
So basically it has a sharp cutting edge here in this part. So
Yeah.
when you chop, no, kind of cleaves the cataract.
Does it cut on the sides as well?
Exactly, that's the whole point.
So it also
Yeah.
sharp on the sides and the
Yes. Podva.
It almost looks like a bent 26 gauge needle, sir, from here.
What is it?
It looks like a bent 26 gauge needle, the
bent
chopper.
26
Yeah.
per needle, yeah.
So I'm creating a small trench here for my direct job. So now what I do is bury into the trench, hold on 3, chopper goes down.
A beautiful chop. Fantastic chop. He's doing a direct vertical chop.
It's a fantastic chop. But I've seen a lot of surgeons actually making a small trench before they do the direct chop. The advantage I feel is you can actually assess the depth
Exactly.
of your chop. So that is the, so it's a personal choice, but if you actually make a small trench and then start your chop, you can actually, even in denser cataracts, you can actually go deeper and you know which plane you are in actually.
So
I think
Yeah.
he's made multiple chops now.
I like to make,
Aditya, what are the settings you're using for this?
yeah, so I want 500 vacuum, 40 flow rate and 50 phaco power.
In
so-
which mode?
It's all linear.
Linear mode, sir.
Linear mode.
Is it
Okay.
a micropulse or?
Yes, sir. Pulse mode.
I can see this phaco tip is I think a 30 degree bevel tip.
Yes, sir.
Any advantage of using a 30 degree, or do you prefer a 0 or 15 degree?
I prefer a 30, sir.
30 is it?
Yeah.
Because when you want to trench, you have a 30 degree or 45 degree. You want to do a chop, direct chop especially, lesser the bevel, better the grip you get.
Correct.
Could you achieve the same thing with a normal chopper with this technique, or is it that you need this chopper?
So, this chopper, it's easier to make your vertical chops. That's the reason why it goes quite deep. It goes about 1.25 millimeter into the nucleus.
So the tip is 1.5 mm, is it?
Yes, sir.
1.5.
1.5.
Dr. Mohan Rajan, what do you have as a chopper? How different is your chopper from
Yeah,
this?
I think Dr. Mohan Rajan chopper, it comes in 3 different sizes. It's 1, 1.5 and 2 mm. And it has a very sharp tip, but the sides are not sharp. Whereas this chopper, even the sides are very sharp. I think can do a side cut as well if you want.
Just ensuring all the pieces are separate here so I can take them out of the bag safely.
So do you change your phaco settings when you're doing quadrant removal, or is it the same?
Same, sir.
Same
But it
settings.
depends. If I feel I'm having surge anywhere, I will reduce my settings.
And I think since you're using linear mode, I think you can
Yeah.
customize your
Exactly.
vacuum and very beautiful surgery.
Thank you, sir.
You can see he's doing phaco in the safe zone, right in the center of the pupil. He's not chasing the pieces.
It's all in the foot control. You don't have to chase after the piece. It's safer that way.
So keep your phaco tip right in the middle of the pupillary zone, just in the center of your axis.
You can chop here if you want to, but again, I think you can just finish it off.
Yeah.
Just so that
That's
it's
the last piece, and that's the most important step. Some surgeons prefer to take off the side port so that the AC is more well formed.
Yeah.
There's no leak.
I think I can reduce my parameters here.
Parameters also.
Reduce
So
Panaba.
when you take the last piece, are you changing the setting in
I am, because I am showing some surge here, so just to be on the safer side.
Making it around 300.
400, 300 Nanapa, 400 Pinpa.
435.
Reduce the flow rate also.
Flow rate also is reduced to
36.
26. So that's the last bits of epinucleus coming out.
Did you change the bottle height also?
No, bottle is still same, sir. It's only my flow rate and my vacuum that's being changed. Power stays the same.
Can you preset all this in the Signature Pro? Do you have epinucleus mode, quadrant mode?
You do have some, but I don't.
You can change it from your foot.
Yeah, you do have that, but I don't bother with it, sir. I just keep in one mode and change as and required.
Aston changes the setting.
Exactly, yeah. Lens port lampa.
That
We'll
was
do the eye
nicely
later.
managed. Nucleus management
Thank
was
you, sir.
really very good.
Thank you, sir. I'll do the eye later after lens is placed because the cortex is only peripheral, just to save time. So I'm implanting the eye lens here today. So as we know, the eye lens needs no introduction. It's called an enhanced monofocal lens.
You can see the leading haptic is turning a lot.
Yeah.
Does it always happen like this? You can see the leading haptic coming out like a hook there.
Exactly, but you just have to manage it, so the way it comes out.
Yeah.
Turn it.
Does it always come like
correct?
this?
Not really.
Usually the other lenses they
Yeah.
come folded so that
With this injector, you kind of have to turn it around to ensure it comes out the correct
So,
way.
Aditya, you're using a bimanual injector mode, the screw type.
Yeah, screw type. Yes, sir, exactly.
Well, they have the injector type also, which is you can do it with one hand.
Usually
And
the
in
injector
those
type,
cases
many
you can
people
use
don't
the
prefer,
side port
sir, because
instrument to
the
stabilize
lens
the eye.
comes out abruptly. So
Ah, yeah.
many surgeons usually prefer the screwing type where it is more controlled release of the IOL is there inside the AC.
So this is again, this tip is a hybrid tip. It's made of polymer, so it's actually safer for the bag. Blue chopper
Come
kodpa.
with
Blue chopper.
AMO pack or you need to
Oh, again, we can customize, sir.
Customize.
Customize.
From that side, the volume is bit low.
you can't hear the surgeon?
We can hear, but it is
A bit low, yeah.
very low.
The audio output from the
No,
operation
just the
theatre
nucleus
to
piece,
be,
I'm just taking it off.
increased. We are able to hear, but not that clearly.
Dr. Mohan, can you please tell us what is the IA tip having?
It's a polymer tip, sir.
It's a polymer tip, and I think the tip is sort of it's got a very soft covering so that doesn't damage the PC or the capsule.
It's more friendly on the capsule. If you grab it, it's probably not going to split.
And is it a part of a
Yeah.
signature company or is it your?
Again, customized from Asiko, ma'am.
Asico.
Actually, a
Asico.
lot of companies have this polymer tip. Even Alcon has one. I think it's a silicone or something. So everybody has their own tip. The advantage with this is it is, as Sir said, it is very PC friendly. So when you're doing the capsular polishing, you can actually,
So again, it's
put the
important to go
capsule
behind the
Yeah.
and
lens also to remove any visco,
So you ask
especially
the
important in a toric lens.
yeah, you can
You
ask,
ask
for
the company
ask the
to give
company.
it.
Is this a toric, non-toric?
This is not toric, sir.
Actually, one question.
Yeah.
இல்ல பரவாயில்ல அது கட் பண்ணா போறோம் இது எல்லாத்தையும் காமிக்க வேண்டாம் சின்ன கட் பண்ணிட்டு ஆன் பண்ண சொல்லு
Yes, sir, we can cut it, sir. You can go to the next surgery.
Hello, Ravi.
Yes, sir.
Are you able to hear me?
Definitely, sir. We are able to
Very,
see
very
you and hear you.
I'm going to demonstrate the catalyst now. The femtocataract, a patient with a type 1 intumescent mature cataract. Okay, I'm just putting the speculum. ரெண்டு கண்ணு நான் தரங்கம்மா. Okay, you're able to see that?
Yeah, we are able to see it very clearly,
Very
sir.
clearly. Now, what is important is in catalyst, unlike the lensex, this is the liquid optic interface. Near on the light parangama. So I'm putting the liquid optic interface there, then creating a vacuum. The vacuum doesn't go very high. about 12 millimeters of mercury. So even in glaucoma patients you can use this. And once I see this, you can see here, please let me know if you are able to see clearly.
Very, very clearly, sir.
Okay. I am going to log this system, this liquid optic interface, into the system. And as you can see on the screen, the pupil is fairly well dilated. I am centering this ring there. Now I am capturing and locking the system. So now everything is in one single piece. The eye, the suction, that is the liquid optic interface, and the console. And you can see that automatically there is a 3D OCT which recognizes the capsule. You can see the vacuoles in the anterior capsule. Are you able to see that?
Yes, sir.
Okay. And we change the offset a little for capsular axis. It is recognizing the posterior. See, that's what I am telling everybody. Don't underestimate this catalyst. Even in a mature cataract, you'll be able to recognize. You see the thickness of the nucleus. It's quite thick as well. The lens thickness is almost 5.2. Okay. Yeah. You can see that these are parameters: central corneal thickness, the aqueous depth, anterior chamber depth, lens meridian position, lens thickness, pupillary diameter, white to white, everything is available on the screen. Okay. By default it goes, you approve it, I can see the center, I am doing a 5.1 capsular axis, pupil maximized, you can see that, or a scan capsule, whatever you want you can choose. I am having an offset of about 500 micron, but I am going to increase it a little because we do not know, sometimes there can be an underlying posterior polar element as well. So just keep it a little high, about 900 microns, approve that, and you can see that there is a center skipping this thing also, but being hard cataract, I am doing octants, that is 8 quadrants in this. You able to see the screen, I suppose?
Yes,
very much, sir.
As I press the foot switch now, and the
So one question I had
was, is over. Being a very thick cataract, it takes about 70 seconds. So it's now fragmenting the nucleus.
Sir, you generally don't make...
So in cases like this, wherein you have a little hypermature hard cataracts with the vacuole shown, have you ever experienced rexis, gone out with femto?
No, normally it's not there, and it's almost a foolproof method. And because the rexis is done so fast, you can even make it even faster than 4 seconds. But because the offset, I have kept it a little high, and the energy also a little high. And you can see it's about 25 seconds more to fragment the nucleus.
I had one question.
So unlike the normal thing, it can penetrate even a mature cataract. So don't underestimate this catalyst. You can see that it's fragmenting the nucleus very well.
Yes, sir. Sir, I had one question.
You can see it on the screen.
I have stopped doing incisions with my...
I'm not...
Sir, can you hear me? Sir, can you hear me?
Little louder, please.
Sir, I had stopped doing incisions with my Lensex femtosecond laser because I generally feel either it is too corneal or it's too scleral. What is your opinion on that?
Yeah, we also stopped doing incisions.
Okay, okay.
Younger people I'm doing still.
Okay, okay, okay.
You can make it about 0.2, 0.3 millimeter from the limbus.
Okay.
But if you have a dense arcus in this, it's not possible.
Any other tips, sir? Because I've seen a few surgeons making a small mark at the limbus using a usual marker. Or this
patient, actually I'm going for a synergy toric lens. We can even mark the axis of the toric lens, the 6.0 software which is available now with the catalyst. I have not done this in this case, but since I got Callisto available, I will show that. Now Sujatha will go on for the case. Any questions from the thing, we can take it later. Okay. Thank you very much.
Thank you, sir. That was a good demonstration. Professor Dr. Venkatesh, you would like to comment something?
Dr. Mohan, do you do LRIs with catalyst?
Wait. Hello?
Dr. Mohan,
Sir, are you audible? Professor Dr. Venkatesh has a question.
yeah.
I think he's en route from the Femto theatre to the main theatre, sir. We'll ask him later.
Good morning, Sujatha madam. We can see you. A little louder, but I think you're.
Yeah.
Yeah.
Now the next case, Dr. SUJATHA Mohan going to do a phaco with Bosch & Lomb Stellaris Elite machine. This is a very new machine.
Good morning, Lalit and everybody. I see Meena, Venkatesh, and anybody else I'm missing. Good morning. Srinivas, okay.
Ravi, is the audio clear there?
Everything clear, so don't worry about it. We are just taking care. Audio clear, video clear, excellent transmission.
Okay.
Thank you so much.
So this case is a PSC with a grade 2 nucleus sclerosis in about 50-year-old man. So my preference is always to do topical. So one of the tricks of topical is maybe you should talk to the patient a little bit more. So I'd like to use some topical drops in the area where I'm going to touch. So just give some compression.
Do you use a fixation ring like some surgeons do, no? Or
No.
a cotton bud or a
I use a cotton bud or a closed forceps. I don't pinch on the
I also saw madam using that 1 millimeter side port, which is pink in color. I am also using this. It's made by Oro Lab. Now the advantage is it is very good for people who use bimanual because the incision size is perfect if you use the bimanual, a 23 gauge bimanual.
Okay.
So that is a beautiful blade.
By Oro Lab, is
So a bit more centration is required, madam. Madam, bit more centration is required.
Why not by MBR?
Yeah. So I'm going to start the surgery now.
You know, you have
Valina
a fish
தெரியாது.
mouth thing. Here it is not much.
It's almost like a keratome.
It is
So
almost
I'm
like a
using a
keratome,
depth
exactly.
knife to make about a 300-degree
So she's using a
incision.
300 micron guard knife to make the initial vertical incision, following which she's going to enter the eye using a 2.2 or 2.8 incision.
2.8.
2.8.
Madam, you always prefer to sit temporal?
Pardon?
You have to be a little louder, I can't hear you clearly.
Is it your preference to be always temporal clear corneal?
Yeah, always. It's very difficult to do topical otherwise.
And when you start teaching a person phaco, at that time also do you teach them temporal or do you feel that it is first initially superior and then they become?
No, only temporal. We start with temporal because the exposure to the eye is better. Is better. And once they get used to this superior, they'll never come back to temporal. It takes a long time for them to graduate to temporal. So,
Madam, any reason you're doing your exercise through the main port? Because I'm just curious about it.
yeah, because I was a surgeon trained in 1993. That's the reason.
Because I see the chamber collapse is a little less when you do it through the side port.
I know that, but you know that's for the young surgeons.
So you can see the speed with which the Rex was so fast.
You can
the time is, if you take too much time to do your exercise, you get AC collapse. But you can see madam took hardly hardly 10 or 15 seconds to do it. And if you are very fast, I think many surgeons they avoid doing a second side port because they're going to use a coaxial IA.
Yeah.
You don't need to do a second side port. You AC or
absolutely right. Absolutely right.
Two steps that you did demonstrate now, I don't know if people notice, is to compress the center of the nucleus.
Yeah, absolutely.
When you do the hydrodissection.
Yeah, correct.
So that you release the fluid.
Yeah, you have to be a little slow so that people can also.
So I want to ask, do people have done away with hydrodissection? Do you actually do hydrodissection?
Ravi, the audio from the other side is not that loud.
Okay, now can you hear us?
Now it's better. Now it's
Yeah,
better.
okay.
We can see it very clearly.
Okay, now what I'm doing is, like Dr. Meena said, you have to compress a little bit in the center so that you don't overhydrate and cause an hydro rupture. So that's what I've done, and I'm going to start with the scalp.
Madam is using a new machine. It's called Bosch & Lomb Stellaris Elite. Can you talk about the machine a little bit?
Yeah, you know, it is probably a direct competition for Alcon's Centurion. So this also has got active fluidics, and the advantage is the vacuum is based on the vacuum, the amount of infusion comes in. So the bottle height is maintained at a very low area, and the pressure is also maintained very low. And otherwise, I think if you have used a venturing machine before, I think more or less it works the same way in increase production.
So she is doing almost a direct chop. She's made a small groove for limit. She's doing the direct chop.
Yeah.
Settings are, the vacuum is 550 and the ultrasound power is 60. Venturi, so you have only power and vacuum, that's all.
So Madam is demonstrating the vertical chop here, very beautiful demonstration. You can see that the chopper which is used is the slightly sharp chopper. So basically what I'm trying to tell you is, if you're going to do a vertical chop, use a sharp chopper, and if you're going to use a horizontal chop, yes sir.
Madam is using the Mohan Rajan chopper.
Yeah, that is a sharp chopper, sir.
Yeah, invented by Dr. Mohan Rajan, and it is 1.5 mm or 2 mm? 1.75.
This is what you have to use for a vertical chop.
Yeah.
And if you're going to do a horizontal chop, then you have to use the blunt chopper, the ball tip chopper. So that is the point which I wanted to highlight.
Actually, the Mohan Rajan chopper comes in 3 different sizes. It is 1.5, 1.75 and 2. So depending on the grade of the cataract, very dense, you need to use a longer chopper, 2 mm chopper. For regular cataracts, you can use the 1.5 or 1.75.
1.75 is the one which regularly used.
Yeah.
I would like to know if, ma'am, hello?
Yes.
Ma'am, are you using the dual linear foot pedal?
Yes, I'm using the dual linear foot pedal.
So
that's again another advantage of Stellaris that we have already been enjoying. And now what I find is in this is active fluidics, the chamber is so stable, which is really unbelievable. You can see that.
Really fantastic AC stability.
Yeah.
No surge at all. Beautiful.
The other important thing that I find is in Venturi you don't have to chase the pieces. You just have to stay in the center and the pieces will come towards you.
Yeah.
So solubility is very good.
Solubility is excellent. So now I'm going to do the IA. So I Lalit asked me, I prefer a coaxial. So again trained before the 2000.
So this is why she does not do the second side port to do the rexus, because you can avoid making one more entry into the eye, which will be inferior if you're doing the right eye. So it makes sense to avoid the second side port, I guess.
Madam, what is your preference of phaco tip? I think Stellaris has the 19 gauge, 20 gauge and 21 gauge tips.
I'm not able to hear you.
What is the gauge of phaco tip you're using? Is it a 20 gauge or 19?
15 degree tip we are using. 19 gauge.
15 degree, 19 gauge is what she's using. Do you have any other tips available?
I use the 20 gauge.
1.8 mm also. 1.8 mm. They are the what gauge? 19 gauge, 20 gauge.
CP.
21, 19 and 21.
CP.
You have different 0 degree, 15 degree, 30 degree, all that? Bevel. So they have 0, 15 and 30.
They were the Stellaris mix, what we started, we are the Asia's first mission, 2005.
That is 1.8.
Can you tell us something about the Stellaris tip you are telling, 19 and 20 gauge?
So now what I'm doing is what is called as a power wash. Once you've finished it, just flush the PC and remove as much of the fibers as possible. I don't know whether you're able to see it.
Yes, ma'am. Very clearly able to see, ma'am.
And you can also see she switched to coaxial illumination and she did almost the phaco on the rexus. Do you do it throughout with coaxial? Right?
Yeah, I do throughout with coaxial.
Coaxial.
Yeah.
You can see the excellent red glow, which you can see, beautiful red glow.
So I'm going to put an N-Vista lens. So again, I think the advantage of...
Can you talk about the lens, madam? N-Vista lens.
So this is a it's lower, it's a hydrated, they call it hydrated equilibrium. So there are some advantages to this lens. The slow unfolding is actually an advantage, I find, because what happens is we can call it controlled unfolding, because the advantage is you can remove the viscoelastic before completely the lens unfolds.
Beautiful.
And it very slowly it delivers beautifully, very nicely, very controlled, and it's got a step vaulted haptic. So there is increased bio addition. That's what we want, because we don't want the PCO to come, and
It also has zero glistenings, right?
yeah, it's supposed to be zero glistenings. Yes, absolutely.
Excellent.
See, you can see, yeah, you can see how this lens is still not unfolded. But then it's a great advantage for me, because I can easily unfold it once I remove all the viscoelastic from the chamber, from underneath. Particularly in okay, my husband says done, so I have to.
Thank you, madam. Thank you for the excellent demonstration.
Excellent, madam.
Thank you so much.
Excellent
Thank you.
surgery, Dr. Sujatha. Pleased to watch.
Thank you. Thank you. Thank you.
Please give madam a big hand, please. Fantastic demonstration. Thank you.
Thank you.
Now we'll go to Dr. Mohan sir's case. Sir, can you talk about the case, sir?
No, actually, Saurabh was there when I did the Femto.
Kuchi.
I told you it's a hypermature type 1 intumescent cataract. Can see that?
Sir, we cannot see. Can you switch over, please? Can you switch over?
So 1 minute, sir. Just switch the camera.
Okay. Are you able to see the Callisto image?
Not yet. We are not able to see madam's surgery. Kindly switch over, audiovisual team. You need to switch over to the other surgery.
Audiovisual team, konja paathukonga, please. Tak shoot pannunga.
Microscope shoot pannunga.
Ready, ma?
Are you able to see your external camera, sir?
Okay, ma. You are able to see internal camera?
No, not yet.
We'll be seeing soon.
Not yet, sir, not yet.
Yeah.
This is the mature cataract.
I did the Femto, no?
Yeah.
So I'm going to do this
Microscope.
Yeah,
Phaco
now we have the view, sir.
Okay.
Oh.
You're able to see the Callisto?
Yeah. No, not the Callisto, sir. We're able to see the.
Okay, Callisto will be available only on the side screen, whatever it is. I'm putting a trying to put a synergy toric lens for this patient. And what is important is, please don't, of course, most of the cases are free floating.
Loud, sir. Yeah.
You want me to be louder?
Yes, sir. Loud. Now it's fine.
Yeah. Always put Blu-rays, because please understand that in an immature cataract, if you do a robotic, mostly it is free floating. In a mature cataract, it can be free floating, but sometimes or many times there can be skip areas. So you have to be very careful.
Tags.
Yes, the tags will be there. I know, I'm sure Lalit you will know, because you are doing this lensex also very frequently. So, and I keep the Blu-rays for some time.
Do you put an air bubble in the AC before you stain the capsule?
No.
You don't.
Sir, how much pupillary dilatation you need to do femto cataract?
Very good question.
So how much pupillary dilatation do you need to do a femto cataract is the question.
Minimum 6 millimeter.
Yeah, because
What do you use for dilatation, sir?
Less than 6 we can plan, because we need at least about 500 microns difference between the.
So now the Callisto is also seen on the.
Callisto is seen, okay. I do minimum 6 millimeter, sometimes I have done 5.5, because you need to get about 500 microns difference between the pupil and the rexis. So if it's about 5.5, we can probably manage about 4.8 or something like that.
Yeah, now we can see the Callisto image also, sir.
What is the incision size? What size are you doing?
I'm doing up 2.8 here. I'm using a Signature Pro.
So you just push
Any
the
reason why
capsule
you
with the
don't
visco, sir?
Did you
Sir
intentionally
is just
push the
using some
capsule with the
sub-tenons
visco
now.
or,
No, what, when I put the side port, you can see that rexis started folding up there. Viscoat ma.
Was it intentional?
என்னம்மா பண்றீங்க அப்படி அசையாதீங்க. Yeah. Rexis forceps. Rajan.
So any reason why you prefer a 2.8 over a 2.2?
We are doing now regularly 2.2 even with the Centurion. We find that pushing a lens through a 2.2, anyway we have to enlarge that.
is a little cumbersome. You can see here what I am trying to do is, yeah, can you switch off the Callisto please? So I think it's very important. See this, do it like a regular Lexus, though it's almost a free floating. Can you see that I'm trying to pull that?
Wow, wonderful sir, wonderful.
Yeah, don't pull it off. Sometimes you can have tags and the tags can extend. Do a very gentle hydro dissection because already some, I'll come back to your questions in the later.
Yes. Sir, do you use Visco before doing hydro in a mature cataract, sir?
Visco?
Yeah, under the capsule? No.
No. No Visco at that time. Callisto to be switched off please. I told you, no, Callisto. This is a Signature Pro machine. You can go, the advantage of Signature Pro, I think Aditya Varman has spoken about it, is that you can switch over from the peristaltic to the Venturi system as well. So what I am using is a peristaltic.
What is the...
See what is important, you can see the fragmentation of the nucleus as well. Can you see that?
Yes, sir. We can clearly see, sir.
So this is a 1.75 millimeter chopper. So what I am doing is I am just going inside and creating a good vacuum seal there and opening up the areas. Can you see that I am opening up the areas already which are opened up, fragmented by the femto. It's called a pre-chop.
Sir, your Callisto has already done the 8 quadrants, and just before that you need to do a little bit hydro.
Not Callisto, catalyst.
Sorry, the
You can see that.
So how safe it is to do hydro after that?
Very gently you have to do, because already some limo dissection will be there. Especially in a mature cataract, I am not sure whether it's sometimes it can be a posterior polar also, because you do not know how much the wave is going behind. See what is important is already the cleavage plane is there. I am trying to open it up there. Can you see the cleavage plane? Very fact that gas bubbles are coming out, it means that it's gone all the way down to the posterior nuclear plate.
Yeah, it's very clearly visible, and you will be saving on a lot of phaco energy.
Yes, can you see that? See, already I am doing this. Now, see, the advantage of this machine is that it's a seriously fantastic, it's like a workhorse. I just have to stay in the center. You can see the fallability. You saw it in Aditya's case as well. You can see the vacuum I'm using is almost 450, 500, and the flow rate is about almost 60, no?
70.
Flow rate?
60, yeah.
60. I think 60 is the maximum in this.
Sorry.
So what is the maximum flow rate in this machine?
It's 60, sir.
60.
60. Wow.
Sir is using a 50 flow
And
rate.
what is the maximum vacuum?
Vacuum you can go up to 600, 650.
So I think we can work with such high flow rates and vacuum mostly because of the tubing, the compliance and...
Compliance, everything, the stability, the sensor is so good. Yeah.
And that goes the last piece.
Wonderful. That was
Great job.
beautiful
Fantastic.
demonstration. Amazing.
See, actually the machine does everything. So, it's nothing. I have done the catalyst. You can see the beautiful rexes. See, if you touch this cataract, there's a possibility of Argentina flag sign. Okay? Almost 50-60% of the time you will have got it. Otherwise, we can do puncture rexes or aspirate, but all these are not 100% foolproof. What I do is I use a coaxial curve. I always remove the subincisional cortex first. Removing the cortex in a robotic, that is a catalyst, is a little tricky because you don't have this cornea please.
We don't have the cortical tags because it is...
Yes, you need to go underneath, underneath all the way up till the equator and pull it.
Sir, one thing which I noticed was you had excellent dilatation even after the femto.
Yeah, because I didn't wait for long, no?
Okay, and one way to maintain that is you can use either phenocan when you start, just before you start, or you can use FLUR, NSAID drops.
No, I use this Megabrome. Megabrome and I put T-Med Plus.
Yeah. So that is just after your femto part.
Yes. Yeah.
You can
get
use
the lens ready, ma.
NSAID drops and T-Med Plus just one drop.
We use phenocan regularly. It does a really
I use
great
phenocan
job.
for all my patients nowadays. It reduces the floppiness of the iris also. That's something which I've...
All your patients use it?
Yes,
Lalit.
because the reason is, not for femto, for all cataracts, the reason is it makes the iris also taut. So the floppiness of the iris also comes down. That is one reason why I've started using phenocan a little bit, just a little, after the rexis.
So this is Callisto on. Okay. Callisto on the external camera. Okay, this see this J&J guys are constantly inventing and innovating, I would say. So they brought in the Synergy toric. The Synergy was available for all of us, which is a continuous range of vision lens. It is a combination of Symphony and thickness multifocal, and the Synergy toric gives the advantage of continuous range starting from 35 centimeters through 60, 90 centimeters to 2 feet, 3 feet and even infinity. And we have the advantage of the Synergy toric also. We are going to launch today the high-hands toric also. So Kumar doctor will be demonstrating that a little later. High-hands toric also, I always make sure that the continuous on please. I remove the viscoelastic from behind the lens. Very important, especially in all lenses, more importantly in a toric lens like this, multifocal toric.
Sir, with the newer generation of trifocals here, like Synergy, so how do you say the halo glare has gone down? I mean, these patients do still complain, or this complaint has also gone down?
No, it's much less the glare halos because of the technology which is available now, and the aspheric technology also gives them better contrast vision, and even in the PanOptics, I think glare halos are much less. But still we need to make sure that the patients are not very regular night drivers. That's what I do. And those patients I can go in for a EDOF lens without rings. So we can see that the blue lines are coinciding with the mark there.
We can't, yes sir.
You're able to see that? The advantage of this Callisto. The Callisto is with the Lumira 700 microscope, and it is compatible with the IOL Master. Virion is the Alcon, and compatible with any microscope, but you need to use LensStar for that.
Sir, how large can your corneal main incision be if you're going to put a toric lens? What is the cutoff? 2.8?
You see, please understand this. These incisions are all astigmatic free or astigmatic neutral, I would say, because you are far away from the visual axis. And it doesn't make an impact whether you are 2.2, 2.4 or 2.8. So you can see that it's well centered. Look at the third and fourth Purkinje images right in the center. Okay. So that's the end of the case, and we'll go on to the next case by Kiranjit Singh. He's going to demonstrate to us.
Sir, wonderful demonstration of a mature cataract using the catalyst system.
Thank you very much. Thank you very much. We go on to 10 to 2, please. Sendil.
Yes, sir.
I will take the questions later, after that.
Yeah, we are able to see you, Dr. Kiranjit, sir. We are able to see you. Sir, you can start talking, sir, as you're doing.
Yeah, but it's not. No, 2.8. Good morning, Dr.
Good morning, everyone.
Hi, Manoj. Good morning.
Once again.
See if it's audible.
Hello, கேக்குது சார்.
அது
Dr. Kiranjit Singh will be demonstrating the iris claw lens.
Yes, Dr. Ravishankar, can you hear us from OTT?
Very much, we are able to see the internal camera.
Dr. Kiranjit Singh, sir, is here with us from all the way from Amritsar. As we all know, he is a master of secondary intraocular lenses and they have pioneered many techniques. This is a case of aphakia. ऐसा बोलो? अच्छा ठीक है नहीं उतने से नहीं आना चाहिए. So this patient had high myopia and retinal detachment. The retinal detachment was successfully treated and then the subsequent follow-ups visit was fine, but the patient had dislocated intraocular lens along with the posterior capsular bag. The bag and intraocular lens have been reviewed few days back. The retina is attached and now sir is going to do secondary iris claw lens. Over to you, Dr. Kiranjit sir.
My mic is working? Yes, sir.
Anji sir.
Actually, a very simple case has been selected for me. Okay, and its adequate count is not even possible.
What did you do first? Multiple increase, no?
Were you making multiple incisions?
Oh, okay.
Kiranjit sir, we are not able to hear you. Can you just keep talking as you are doing the case?
Yeah, you please speak as you do it. They want you to speak.
Because we just want to know what you are doing.
Is my mic working?
Mic.
So what was the size of incision you made, sir? Is it
The
5
question
mm?
is, what is the size of the incision?
5 millimeters.
5 millimeters.
5 millimeter incision. And the two side port incisions are to aid the enclavation. I think.
Anyway, welcome to Kiranjit Singh, the superstar from North India, from Amritsar, as you all know. Huge volume of surgeries they do, Daljit Singh Eye Hospital. I had the wonderful opportunity of interacting with Daljit Singh several times. A doyen, I would say. Kiranjit, Seema, Indu and Ravijit are all doing fantastic job there. And the iris claw is done so many innovations and inventions on this iris claw, which is really a fantastic. Today he is going to demonstrate a very new lens, which not only takes care of the aphakic component, but also taking care of the glaucoma. It pulls the pupil just like the SFT or the pinhole pupilloplasty.
So pre-operatively, what would you see the iris before you put an iris claw lens? What are the do's and don'ts? When do you not put an iris claw lens?
Your mic is on, no?
Yeah. The iris should be strong enough to handle the iris claw lens. But in this case, I think the iris is weak, on the weak floppy iris. But you know, my claws are even so big in size that while enclaving, I will probably not injure the iris anymore. So
Is it going to be retro iris fixation?
no, it is going to be interior. I need vision blue.
Anterior.
Yeah.
Why do you require vision blue?
Because I want to locate where my stab incisions are.
Okay.
जल्दी दे दो.
When you put the lens, you'll be explaining about the lens, no?
Yeah.
Okay.
Yeah.
Who's the next case there, ma'am? Arrange Shetty.
You put an infusion
This is sodium hyaluronate. So when you have to do such a case, never use methyl cellulose.
Correct. I think that's a very important message for all of us. Not to use HPMC. The HPMC can mix with the vitreous, can cause severe inflammation as well.
नीचे देखना.
So even if you have a PCR, please don't use HPMC. Helon or Viscoat is better.
Sir, is this blocked or is it under topical, sir?
It's blocked. What is the size of the incision, Kiran?
5 millimeter.
5 millimeter, okay. So you go corneal, is it?
Yep.
Because that will be scleral.
Because too much has happened on this place.
Yes, okay.
Because the IOL has been removed.
Otherwise you would have done scleral.
No,
not necessary.
I have forgotten how to do a scleral.
Yeah, all of us have forgotten.
IOL दे दो. ये नहीं चाहिए. IOL दे दो.
Dr. Mohan,
Yeah.
is it better to use an infusion like anterior chamber maintainer instead of?
No, it's all a personal choice of the surgeon. Whatever he is comfortable with. You can use an infusion. For glued IOL, use an infusion. Because the maneuvering here with iris claw lens.
I think it will be difficult.
Leave it.
Yes.
With the lens, can you talk a little about it?
Because, yeah, please talk about the lens.
Sir, can you just talk about the lens?
Yeah, he's going to talk. He's going to talk.
And
Beautiful it is.
something which we have never seen.
Kiran, your hand is coming in the way.
Okay.
Fine.
I think I need to extend the incision a little bit more.
A little more, yes.
Yeah. Just picture करना.
Can you? It's
Before
more.
incision, can you talk about the lens, sir?
I am just about to talk.
No. He will put the lens and he will talk about the lens. Just give one more minute. He's going to extend the incision. Yeah.
देना. बस ठीक है.
Yes. Do you use pilocarpine?
Yeah, I used it.
Used it, okay.
Needle चाहिए मेरे. या cannula चाहिए मेरे. You know the older version of the iris claw lens had pseudophecodinasis. That was the only drawback it had. But that drawback has been fixed, and there is no question of.
No, it's something went wrong with the illumination. Can you put coaxial illumination, ma? Wait, it's not very clear. Kiran, wait 1 minute.
Okay.
Yeah, it's not very clear.
The thing is that.
Now it's better. Your hand is coming in the way.
Wait.
No.
Needle देना.
It's a beautiful lens, yeah.
Wait. Just give me the needle, straight needle. Because the eye is soft from behind, when I try to tuck it, it goes back. So I am going to use a needle for that. Yeah.
26 kg.
Yeah.
There is specific lens holding force that.
You know this iris is very fragile. Give me the cannula only. No, cannula with the syringe.
Ama.
So,
now how do you know it's stuck properly?
Yeah. The iris has gone in the claw.
Okay.
So, abhi cannula और देना.
Usually we'll see a dimpling in the eye.
Yeah, okay.
Dimpling see when it is retrofixated, not interiorly fixated.
Anterior, how do you, you can straight away see it, how the iris getting clogged, yes.
मिथाइल सेलुलोज आंख के ऊपर डालनी है. 4 places.
4 places,
Yeah.
okay. So actually the 4-point fixation pulls the iris from the angle, am I right?
Yeah, it you know, it deepens the interior chamber. Let me first.
You're holding the iris and then.
We're holding the lens, tucking the iris with the cannula.
Oh.
He's bringing the iris from the back into the claw.
You know the iris is very fragile.
Can you explain the technique?
Kiran, can you just explain how you are doing that?
If I talk, then
the focus is gone.
Talk, no, yeah, we have time, yeah.
Okay. Normally I use with a 26 gauge needle. I wrap the iris around the needle and pull it through the claw. But in this case, the eye is soft, the iris is fragile. So if I use a needle, it is going to puncture the iris, make it.
So you're using something like a Sinsky hook?
No, I'm using a 26 gauge cannula.
Cannula,
Yeah.
okay.
So basically this is an anterior chamber fake lens, not retrofixation.
No, this anterior chamber, the only difference, Lalit, is that
Yes, sir.
is a 4-point fixation.
Okay.
Normally the anterior chamber and the retro is a 2-point.
Okay.
This 4-point, this is a new invention by Kiranjit.
Okay.
And he got the best this thing in the World Glaucoma Conference in Melbourne last year.
Okay.
Yeah, for this invention, best video. And you can see that the advantage of this is that not only the aphakic rehabilitation, but also it pulls the iris just like a SFT, it's pulling the iris.
Okay.
And releasing the angle, opening the angle.
Okay.
Yeah. Can you remove the air bubble there?
I'll remove. Air bubble निकालना है. Air bubble निकालना. Simple करना चाहिए. ये दे दो.
I think putting too much of heel on also will push the iris away. That is why if you put too much of heel on also, you'll push the iris away. So then you can't tuck the.
Yeah, because the chamber was very shallow. But your point is correct, I think.
Yeah, actually because it's also a myopic eye.
Needle देना, needle.
What is the name of that forceps you are holding that?
This is a Clayman forceps by Epsilon people.
Clayman forceps, okay.
Yeah.
Can you retrofixate the same lens?
I have done in one case.
Yes.
Very good.
Yes. That's a.
But how do you retrofix 4 points?
2 claws, I just do it inferiorly. Then I make a iridectomy and hold the lens through the iridectomy.
Amazing.
How is it different from the regular iris claw lens which Freedom makes?
I think.
Because it's 4 point.
Because it's pulling the iris. There's some glaucoma effect also, anti-glaucoma effect.
Yeah.
Just like SFT, it pulls the iris in the angle.
But what is the risk of CME when you do this?
No, nothing. No CME will never happen with
chronic iris irritation.
Yeah, you could do now.
Nothing happens, is it?
No, the question what Sendil is asking, Kiran, because it is producing it's tucked to the iris, whether it can have something like a UGH syndrome.
Never. Needle order there. Angle spotted lens. Angle spotted lens, if put without interior vitrectomy, will cause CME. Iris claw never causes CME. It will cause only if the patient has diabetes or something like that. So one of the claws, I think the iris has gone out. So I'll not be talking now because.
No problem. I will talk. I'm known for talking.
Yeah.
No. He said he will not talk.
Because the eye is soft, no?
Yeah.
Very
You want
high
to-
of 6 diopter lens.
Yes. You want to put some heel on there?
Yeah.
Heel on Kudma. Pupil dilates very well. That's what he is telling, Kiran. Pupil dilates very well. No problem at all. Yes. Pupil dilates very well. Whereas with the pinopupiloplasty and sometimes SFT it doesn't dilate so well. Pupil dilates very well in this. Am I right, Kiran?
Yeah, it dilates. If the claw is optic is 5 millimeters, it will dilate till 5 millimeters. If it is more than that,
and
the problem is with the soft eye. Now it is fixed.
Fixed now beautifully. All the 4 are fixed?
No, not 4, just 2.
Two. Okay.
needle देना. Yeah, I'll zoom.
Sir, do you do any
देखो blade
spectra
देना.
count or
ये
anything
blade
for
देना
placing
है.
this lens, sir?
Blade देना, blade. ये forceps.
So I feel this is a modified iris claw lens with 4-point fixation, and what we understand is this 4-point fixation is going to reduce the pseudophacodonosis that is sometimes occurs with 2-point fixation, and hence it will reduce the incidence of post-op cystoid macular edema.
We were not able to share what
Sir, I have a question. Do you prefer to measure the pupillary size in this?
No, because the 4-point fixation, unlike the 2-point, there can be some pseudophacodonosis.
Needle.
The 4th point, it doesn't move at all because it's 4-point. And that is the reason why I think the CME is also very, very less or negligible.
मिथाइल डालना.
Sir, does it come in different sizes, sir? According to
Sizes, yeah, Kiran will talk about the sizes.
I have got 4 millimeters, 5 millimeters and 6 millimeters depending upon the eye.
4 millimeter, 5 millimeter, 6 millimeter. That is the overall, no?
And the overall.
And the same lens can be retrofixated also.
Yeah, with little bit of difficulty.
Retrofixation can be done, but 4-point fixation he needs to do an iodectomy. That's what he was telling.
Hold the lens through the iodectomy.
Yeah. So I think 3 have been fixed now.
Yeah.
So using the 26 gauge needle, you are pulling the iris and going ahead.
26 gauge cannula, Meena.
Okay, he's pulling the iris in front of the
Claw.
behind or in front of the claw, sir?
In front of the claw.
In front of the claw.
Yeah. In front of the claw, because normally he uses the 26 gauge needle,
I
but
thought
since the
that-
iris is a little floppy, he doesn't want to injure it. So it's being a little, that's why it's taking a little more time, because using that cannula, blunt cannula, and is engaging that cannula into the, bringing it up and engaging it into the claw of the iris.
So why
claw.
not we use some micro forceps to pull up the iris and put it in front if that was the possibility?
It is done. We can do that also. Fine, all the 4 have been fixed. Can you see that?
So I'll just.
It's a beautiful. Oh, so all the 4 have been fixed. Very nice. Yeah, can you zoom it up a little and show it?
I want to zoom. It is not zooming. No, it is zooming.
Just one quick question, sir. What about the endothelial health in these patients, sir? Any studies or
See, normally, Kiran,
I'll answer.
Yeah, please. Your mic is on.
Okay, my mic is on?
Yeah, on.
Yeah. You see, I used to get endothelial decompensated patients, which my dad had done, I think, 30 years back, with a superiorly fixated IOL. So, unlike Janmer's design, it had pseudophacodonosis, which caused endothelial decompensation in many patients. Many means 5 to 10% means 5,000 to 10,000 patients in total. So what I
out of the several lakhs, million.
Yeah. So initially he used to tell me do a PKP, but you all know PKP is a difficult job, and the most difficult thing is patients they stopped using steroids. So one day I thought, why not exchange the lens with a smaller version? And I started to change the lens from bigger version to a smaller version, and the patients they got clear corneas after 3-4 months, of course with the help of hypersol and glycerin drops.
Okay.
And they remained clear throughout. And you see, this lens will open up the angle, it will do pupilloplasty, but still let the pupil dilate.
Same.
It will treat glaucoma or help treat glaucoma, and it will cure aphakia. Last point. Now when this patient goes to Dr. Fogla, he will just need to put a lenticule, endothelial lenticule.
Because there is already a tamponade there.
Yeah, tamponade is there.
Okay.
So it is superior to any scleral fixated lens. I need irrigation from that machine. I don't want.
Dr. Mohan, how did he have the IOL power done? Just a quick question.
IOL power was done in the IOL Master 700, and we took an A constant of 5.5.
for these iris claw lenses.
Simple cannula, simple cannula.
As you know, these anterior chamber lenses are fixed anteriorly, so the
simple cannula.
The effective lens position varies accordingly. So the IOL power has to be much less than the regular one. Suppose it's 21, we need to make it to 18 or 17.5.
Now I'm going to wash the. छोड़ो. ठीक है.
Determine the TCL power and subtract thing.
Yes. Or the IMS 700, you can fix that iris claw. This thing is there. You can no, you can put the A constant.
I need air after this.
Yeah. Beautiful. Round pupil, very nice. Beautiful lens, well demonstrated,
and it will not move at all.
It will not move at all. Okay.
And this is the best lens for a VR surgeon and best lens for a corneal surgeon.
And the patient will have a vision from Chennai to Amritsar.
Yep. No, not that far.
Not that far.
So I can do a PI, but I think multiple. Just give me the air. I want to remove the air from behind.
Yes. I think it's a very good surgery. You put a suture for the main port. Yeah. Very good, sir. Give a big round of applause for Karanjit. Lovely demonstration, lovely invention, lovely innovation. I think it's really a multi-purpose lens, I would say. Very easy to use also. Even the retrofixated iris claw lens, as I was telling, when you have PCR, is very easy to use. Only thing is you have to make sure that the pupil is round, it's not distorted or anything, and making sure that the anterior vitreous is taken care. Now we go on to the next surgery by Naren Shetty. Okay, Naren Shetty from Bangalore, Naren Netralia.
Yeah, press it once.
Dr. Naren Shetty, good morning.
Hi, good morning, sir. Can you hear me? Am I audible?
Very much. You are audible. We are able
Okay,
to see you too.
fantastic. Hi, sir. Hi, sir.
We are able to see. Naren?
Welcome, Naren. I think we should give a big round of applause to Naren Shetty, the superstar from Bangalore, Narayan Netralia, the guy who is taking care of Rajkumar also, Puneet Rajkumar, and here he is going to demonstrate
microscope
an amazing surgery with the Centurion, with an VVT toric or VVT?
VVT toric, sir.
VVT
Yes.
toric. Callisto's on, no?
Yes, sir. Yes,
Okay,
sir.
Naren, can go.
Sir, good morning, everyone. On this onset, I'd like to thank Rajan sir and Sujatha ma'am for giving, and Mohan sir and Sujatha ma'am for giving me this opportunity. And so, if you see one of the things which I normally do is, you see my main incision. It looks almost like a premature entry, but I do it very, very short and very limble because I want to concentrate more on the SIA. So I want to induce as less astigmatism as possible. So in terms of the rexis, I think as you can see, the Callisto is a beautiful guiding system. So you can get an approximate similar size incision. So what you can do is you can use the overlay as a guidance, and then you can create the incision. So this is a step where you shouldn't hurry, take your time.
Can you quickly show that camera a little?
Yeah.
See the rexis there.
Yes, yes, yes.
Beautiful, beautifully done. Oh, lovely. Better than even the femtorexis. Give a big hand to Naren.
Can we turn off the overlay, please?
Yeah, please switch off the Callisto.
So one of the things, always remember, whenever you are trying to do a hydro, see, you might have a scenario like this where one side is clear, one side is more cortical cataract. Don't do hydro on the cortical side, always do on the more clear side.
What is the reason for that?
Sometimes the cleavage is much smoother on the other side. There might be resistance on the CC side, so the hydro might be a little more challenging.
No, I thought the capsulocortical additions will be more in that area, no?
Yes, sir.
Open up also.
Yes, sir. So what happens is, anyway, it'll open on when we do the hydro, sir. When it comes to the other side,
yes.
Anyway, it'll open up, sir.
Okay, fine.
But the initial push
That's
when you do,
go with the opposite one.
yeah, opposite, because the initial flow, it usually water flows in the least resistance place, so it will be much easier to flow like that. So right now I'm using the Centurion system. So the hydro is done always. Yeah, with the active sentry system. Basically the sensor.
About the active sentry?
Yes, sir. So basically the sensor, they brought it much closer. Obviously it makes more sense. They brought it to the handpiece itself, so that any fluctuation immediately picks up, and then it can compensate for the surge. That is why it so quickly it can compensate. So one more tip I would say is, before you start your phaco, always fill the chamber completely with viscoelastic and then begin. Okay. So usually I take my dialer, so that will act as my guidance. Now if you see my phaco tip, the irrigation port is half in, half out. Then you press 1. So you see the bubble is outside and not inside. Half the time what happens?
You're using a balance tip or a Kelman tip?
The balance tip, balance tip. So basically this will avoid the bubble going inside the chamber. Okay. And also what it does is, because when it goes inside, what we normally do is, we try to remove the bubble, eventually you remove the visco, which again reduces the protection. Okay. So we'll begin now. Sorry, I'm trying to be as slow as possible so that I can explain the things.
Yeah, better.
Ma'am, can you Nera Chudma, sorry. Nera Parangama, Nera Par Light
Modi. In Karnataka it's Nodi, in Delhi it's Modi.
That's a good one, sir. So this is a little bit on the softer side. So you can see is, once you've got a hold, okay, what is important is you take your dialer, do a quick movement towards the tip. Okay, see, actually if you see I have not gone sideways yet, the chop is already done. So then you move sideways. Okay, when you move sideways, you have to imagine as if you're trying to rotate the lens. Don't push it down. If you push it down, you break your hold. Okay. The easiest way to rotate this lens is always get into this groove and then rotate like this. Okay. The same thing you can repeat it.
Naren, I see that you are using only 22 millimeters of IOP.
Yes, sir. I use.
Come on. How is it possible? I tried. I was not able to do it. I was not able to do it. I found the chamber was a little
yes, sir.
shallowing and
so
what is the secret?
The
vacuum you are using very high.
The 700. So I'll come to the settings of exactly how I do it, sir.
Yes.
So basically one of the things now when we're doing this quadrant removal, so I'm just slowing down. So see, it's so quick because I want to slow it down. So what happens is, the rule is, whenever you're operating in high IOP, whenever you start taking your quadrant, plus 2 first, go to the periphery. Now, at this point, do not push the lens and press 3-2. This is extremely dangerous. Okay. Okay. So what you have to do is, being 2, just touch. See, the piece has already come. Then press 3-2 and then come to the center. So when you do this, the pieces come to you. But if you do the other way, you end up with a PCR.
That is, don't chase the nucleus.
Exactly. So then you know how quickly the pieces disappear.
Come on. Amazing. Oh, wow. Oh. What a lovely.
So,
simply, single-handed.
Yes.
I think you can do with the left hand also.
I normally try, sir, if it's sometimes in the left eye, just to maintain the position, I try to do it so that it's good to be ambidextrous as much as possible, so it keeps you in touch.
Sometimes you do with the leg also.
Sir is always, actually he's one of the wittiest man I know. Sir is always with witty lines. He'll always keep you happy. I think that's why his staff love him, because they never get bored in the hospital.
Bimanual.
Yes, sir. So bimanual, definitely it has a lot of advantages, because in one is no matter, especially subincisional, is so much more easier. In coaxial, usually anterior capsule polishing, if needed, let's say if you have a scenario where you have a little more smaller excess and you don't want to leave it like that, you want to polish your bag, then you have an option here. The
age of the surgeon prediction.
Newer surgeons use bimanual.
Right,
older
sir.
surgeons will use coaxial.
True, sir. True.
Yeah.
The other thing is also loading the lens. You can do it under irrigation with
Bimanual you are
bimanual.
using. Have you brought it or this?
Yes, I brought it, sir. So usually what I do is, sir, you see, this I created, sir, nothing much. I mean, this is pretty standard, sir, nothing too
Not
this one.
Not the Passamis.
No, sir. So you see the tip, sir. It's
Yeah.
rounded. What is? I mean, it's a little V-shaped. So it's much easier to enter the wounds. Otherwise, if it is rounded, little more challenging to enter the lens.
Dr. Naren?
Yes, sir.
For IA, you're using IOP of 60 and VAC of 250.
Yes, sir. Yes, sir.
How come you need a higher? I mean,
That is because the hole of the irrigation is very small, sir. In this, the irrigation
so you can't
cannula.
control the IOP during IA.
Yeah, so you cannot do that. Only thing is you can do is you can increase your size of your side port and then increase the size of your irrigation. Then you can actually operate at a much lower IOP.
So if you were using a coaxial, could you be able to control it?
Yeah, sir. If you're using coaxial, definitely you can do, sir. But you can't do all this, injecting under irrigation, which will prevent you from entering. I mean, putting more viscoelastic
Lens under irrigation.
under irrigation. So you see, sir. Then now it's under irrigation.
Yeah.
And now I enter here. Please rotate, please. So my assistant rotates it. So you see at all times the eye will be facing up. Please, the eye shouldn't move left, right whenever you are trying to inject. This much of control is impossible in any other scenario.
Very nice. So this is a VVT toric. We'll talk about it a little later.
Absolutely, sir.
And, yeah.
Yes.
Now, Naren.
Yes, sir.
I want your. What is the secret of your using only 22 millimeters? I want to. Last time also I asked you.
Yes, sir. Yes.
Also, your wound is a very shallow.
Absolutely, sir. And
Sometimes, especially when the patient is on Urimax or something like that.
yes, sir.
You
Yes,
can
sir.
end up in a iris prolapse.
Yes, sir. Yes, sir. Visco,
How do
please.
you manage that?
So it's all about, sir, is respecting the iris. The more we touch the iris, Visco, please. Visco.
Yeah.
Visco on the cornea, please.
Visco on the cornea, Raju. Yeah, it's okay now.
Okay, it's perfect, sir.
Sir, can you switch on the Callisto marker also?
It's on. Is it not visible?
Yeah, Callisto marker. Can you just
Visible here.
Maybe you can look in the small screen, sir. Maybe the small.
Now it's visible. Now it's visible. Wonderful.
Oh yes.
It's coming. Can you see
So-
that now?
Yeah.
The blue mark, 3 blue.
Yes, sir. We are able to
Yeah,
see.
we are able to see, sir, clearly.
So I'll tell you a small trick about toric lens. So usually, while I'm washing the lens, I mean, I would really suggest is whenever you're going behind the lens, always try to take the irrigation, not the aspiration. Irrigation will be like a gush, like taking a pipe and then washing off all the visco from behind, and then rotating. Now one more trick I can show is, now everyone says, okay, now you cannot rotate the lens anti-clockwise.
Anti-clockwise, yes.
Dialer, please. Just to show the thing, just a small trick of how you can do it. Hope it works now. So basically, what you have to do is go here, okay, and then rotate it like this. Go here, rotate it.
So I have.
So that it's all rotated as habit. See, it's rotating anti-clockwise very easily without any
Without
stress.
any problem.
So you go
So that is-
halfway on the haptic and then rotate it.
Yeah,
Something-
halfway. So yes, sir. So what happens is you're almost depressing the haptic, slightly pushing it this way, and when you push it back, it's already rotated. So it's a small trick. So we don't have to do anti-clockwise and then clockwise while you're doing your toric lenses. Doesn't matter where you placed, you can still rotate it back.
Wonderful.
It's just a
wonderful,
small tip.
Wonderful tip. Wonderful tip.
Now I'm calling.
So once you have done that, so what is very crucial whenever you are aligning a toric lens, it's not about these 3 lines. What has to be there is, don't worry about exactly centering to the central line, but it has to be centered to it should be parallel to the 3 lines. That is more important. Being parallel is more important. Sometimes because the limbus is not right, the orientation might not be good. So once you have done that, align please. Or wait, let me just try to see if visco is there in the endothelium. So I'm not sure okay, I think I've already removed the visco from the endothelium. So whenever I remove the visco, basically I take the irrigation from the side port, I bring it very close to the side port, turn the irrigation holes towards the endothelium, such that it washes the visco from here. So it will come out like a sheet. Sometimes when you just try to direct it in the center, it will not come out. But if you direct it near the side port, it will come out.
Dr. Naren, can you just repeat what was your infusion parameters when you injected the lens, please?
It's just at IOP at 60. 60. That's all, nothing else.
And a little bit about the lens also, because this is quite a new lens.
Oh yes.
Yeah,
Vivity, Vivity toric lens, yes.
Yeah.
Basically this
About
is
the concept of the lens.
Absolutely, sir. So I think this is the way I think most of the lens is going to, it's going to be the future lenses of all companies, because it's a non-diffractive one, so you don't see rings around, but if you slowly see a reflection, slight reflection you can see, that basically bends the light than splitting the light. We should that is the way most of the lenses will be there. So basically what it does is it can focus, you get a very good distance, very good intermediate, and you can treat it almost like a monofocal lens and do your workup. You can implant it even in all, I mean, we have implanted in RK patients, we have implanted in retina issue patients, diabetic retinopathy patients, and they do fantastic, okay. So the distance and intermediate is really good. The near, to some extent, obviously it's better than a monofocal. It's better than a monofocal.
Around 40
centimeters.
Absolutely. My patients are very happy, I would say.
Absolutely.
Very happy.
Yes.
More importantly, many of the golfers I'm doing Vivity.
Yes.
Very happy.
Yeah.
It is very fantastic.
So true.
No
sir.
glare halos, and the contrast vision is also pretty good.
So true.
So we'll talk about the Vivity. We'll talk about the IOP, how he is able to manage.
Yes, sir. Yes.
After Nivian's case now.
Yes, sir.
So let me introduce the. Let's give a big round of applause to Narayan.
Thank you, sir. Thank you, sir.
A wonderful demonstration.
I want to hear the noise from the auditorium, please.
Yay.
Yes. So we go on to the Talapati. The Talapati of Tamil Nadu. None other than Dr. Nivian Madhivanan, guy who is not only good in his clinical work but also surgical, very innovative, doing a lot of research as well, and he is going to demonstrate the phaco with the Galaxy Leo mission, which is really a fantastic mission from Appasamy, and the Swissfob lens, which is again something like a EDOF lens, which works very well for the intermediate as well. Over to Nivian. Nivian, thank you very much.
Thank you, sir. Can you hear me, Lalit?
Clearly, Nivian.
Good morning, Nivian. We're able to hear you, see you.
So, good morning, sir. It's a great honor to be here in Rajan Eye Care with one of its kind CME, the surgical strike, and all thanks to my ophthalmic parents, Dr. SUJATHA Mohan and Mohan Rajan, because of whom I'm here. So, here we're going to do NS 1 to 2 grade cataract using the Leo mission, as sir said, and planting the Swissfob Appasamy extended depth of focus lens. So already completed the rexis here. So just going to go into the clear corneal entry. So the first thing, the beauty of this machine is they have a patented handpiece design. So the 6 piezoelectric crystal is the lightest handpiece in the world, almost weighs just the weight of your pen. So the first, for any I think cataract, the good hydro, you can see the fluid wave going across. So the trick here again for the surgeons who are starting is, once you have the fluid wave, you can see that the second wave, you don't have to do more, because sometimes when you do more, you go into the substance and then the cortical fibers start loosening out. So once you have a good hydro dissection, you can actually stop at one wave. So now I'm going to show you the handpiece. So this is actually the handpiece that they've patented actually. It's an ultra light handpiece. Only when you feel it, you will know it just the weight as your pen actually.
Very nice rexes.
Thank you, ma'am.
Very good rexes. Thank you very much. Fantastic.
Continuous.
The rexes through side port, is it?
Yes, sir. Okay. I always prefer to do the chinna chopper. Small da. Okay.
1.5 kudma. You kondirika illandi engaldana?
Mungadna, sir.
What is the tip, ma? Can you talk about
the Leo machine? It's got an inbuilt camera here. So what I'm going to do differently is I'm actually going to demonstrate the stop and chop technique. So you have seen all the fast surgeons here doing direct chops. So I thought for the benefit of the audience here, I can show a stop and chop technique. So the whole technique is you start here
and go slowly and trench it.
Camera.
And also
focus
make
on
it
the machine for a minute. 1 minute, ma.
1.5 depth wider for the beginners.
Nivian, is this a peristaltic or Venturi machine?
It's a peristaltic. It's a peristaltic machine.
With active fluidics is there, no?
Yeah, they also, the advantages, you have dual thing. You can either use the active fluidics or the bottle height. So why I was telling is 1.5 width strength that we learn in the textbooks is, it is easier for your probe to go in as you go deeper, and then you reach the adequate depth required. So we learn all these things to get the glow before you go to the crack. So
you don't rotate it and crack trench again?
No, so that's why the secret is I start little superior. Most of them start from the center and go to the side.
Yes.
But I prefer to come back and then start the trench.
Okay.
So here I don't have to waste again rotating it. Go to the bottom of it and then initiate the crack. So once you have the adequate depth, you can see the split there.
What are the parameters you're using now after this?
Right now we are just 50 vacuum and 50 power.
Yeah.
So the advantage here is once you have a crack that is extended 3/4, you don't have to trench again. You can just crack it here.
Excellent.
So that was the advantage here.
Beautiful. Very
So
nice.
here now we have two hemispheres. So I'm going to the phaco 2 mode. So this seems power கம்மி பண்ணிருக்கேன். This seems to be a slightly softer cataract. So let me just see if I can get a purchase. And initially for the beginners I used to hold here. So then Rajan repeatedly saw my videos and said then you should have a good bury. So you should go into the core of the nucleus and then bury it and make sure your probe goes inside. Then you have a good hold. See now the nucleus is under your control. Then chop it. As I told you, it is a slightly softer cataract. So I'm just splitting it. இன்னும் கொஞ்சம் கம்மி பண்ணிருங்க.
Wonderful.
Micropulse, no?
Yeah.
Wonderful demonstration.
See, advantage of this Galaxy Leo machine is an occlusion micropulse. On occlusion, automatically the micropulse will start. That's a beautiful feature of this Ophthalmic machine, which is not available in other machines.
So I told you it's a slightly softer cataract and it is a myopic eye. So once you have the one quadrant, I think the rest of the things are easy.
You can see the fallibility, the chamber stability.
Vacuum கம்மி பண்ணிருங்க. Flow rate கம்மி.
So do you get occlusion sounds in this machine?
Yeah, I think, madam, every machine you'll get some kind of an occlusion sound, definitely.
Yeah, sound will be there.
Okay, now, Dr. Nivian, in myopic eyes, do you do anything differently with your cases, like, you know,
I think the bot
height,
yeah, exactly.
or anything you alter?
Exactly, Lalit. When I started the case, I made sure the bottle height is slightly lesser than what we keep normally.
Wonderful.
Because once you go inside, you can have this deepening of the antechamber, which you didn't see it happening here.
Yeah.
And sometimes with those high bottle heights, you can have the iris also becoming floppy.
Correct.
But the advantages, you have the space to work with, so you can actually bring the nucleus into the pupillary plane. And basically just slowing all the steps down. So as you can see, if you have all the machines, I think have a good chamber stability and good followability. So my trick here is to just stay in the center and let the pieces come to you. So you don't have to actually go behind the pieces. So now the phaco part is over.
So all the machines have become good. All the machines have become so good that the chamber stability is amazing.
Yeah.
But it is the man behind the machine who does the job. Wonderful job.
Wonderful job.
Wonderful job.
Irrigation வச்சிருவேன். So
Let's give a big round of applause to Nivian for wonderful surgery. Nice demonstration. Stop and chop. Everybody thinks the stop and chop is inferior. It is not inferior at all. Stop and chop is a fantastic technique of doing removal, and it works in all types of cataracts.
Yeah, it's a very controlled technique. Works
Very
in every
controlled
situation.
technique.
Works in every
And it can
situation.
be perfectly in the back, and you can see, if you go back and see your older patients which you have done about 15 years back with stop and chop, all the corneas are very clear, mainly because you are totally in the back. You have the control which is not there with the vertical chop or the horizontal chop.
And now we are going to implant the Ophthalmic Swiss probe lens, which is also an extended depth of focus lens. So basically, I think for all EDOF lenses, the principles are the same. It's a refractive anterior surface.
How different is this lens from in focus?
So again, in focus, on the cartridge cutting.
In focus is the EDOF lens. This is something like Huygens, no?
Yeah, something like Huygens. So it doesn't. It doesn't have no. It is an EDOF lens. EDOF lens doesn't have a ring. So the in focus has a ring. Here again, the higher order aberrations are there. So that gives the extended focus for intermediate vision.
No. What I am trying to say is, the EDOF lenses are, for example, the InFocus is an EDOF lens. Which the Swiss Fob, the Ions is not a EDOF lens.
So exactly,
the Ions is only there is a central spherical modification of the optic which is there. There is a slight change in the power in the center.
So as sir said, actually in focus what you see is central zone of 1.4, there is an add power that is given, that is 3.5.
3.5.
So there is a specific add. So when there is a specific add, you have to have a ring, and then it is basically for near vision. So the lens is good for distance and near and has some amount of intermediate. But whereas these lenses which are based on higher order operations, you cannot see a ring, they are based on the spherical, like how Narayan already said.
Yes.
So they give very good distance and intermediate vision, that is above 60 to 80 centimeters. So people who are doing computer, so it doesn't have a near vision add. So now I am going to do the bimanual IA.
Again, Nivian being an younger surgeon is doing bimanual.
And you can see the slight blood from the wound, so I always prefer a limbal incision than a clear corner.
Main incision.
No sir, side ports.
The side port is
I made 2 side ports.
Oh, side port is. Where is the main incision then?
The main
Just a
incision.
little closer to the main.
Very close to the main incision, no? That's what I thought.
Divian does things differently every time, sir. We learn something new
correct.
from him every time.
So here again cortical aspiration, I used to go in a very round fashion. So then only you can make sure that one fibers lead to the other. You don't have to do it haphazardly.
Yeah. What is important is you make sure, if you notice very carefully, is catching the anterior edge of the cortical fiber.
The anterior lip of the fibers.
Don't catch the posterior because you can catch the PC.
And then engage, then pull it to the center where it is
then
safe,
increase the vacuum.
and then increase the vacuum. So as sir said, everything is under your foot pedal control. And the beauty of bimanual nowadays is, actually I follow this rock and roll technique where all the bimanuals have an angulation. So it is how you use your wrist.
This is Ophthalmic bimanual?
I think so. I think this is Rajan's. So you don't have to change. You don't have to change your hand. So that is a myth again. So you don't have to change your hand. You can see the good depth here. As long as the PC is away, even the subincisional cortex can be removed without exchanging your hands.
Niveen, a very excellent demonstration, and you are going clockwise hours. That's an important message when you're doing a cortical aspiration.
Yes sir, I think one of your presentations you had explained about cortical aspiration and IOL implantation.
It's a beautiful rexus.
Saline
Fantastic. You're going to
so now
the lens under
irrigation.
Irrigation?
Yeah.
Okay, fine.
So this is the new C-tape cartridge that comes for the Swiss Fob lens.
Push type, no?
Yeah. So we are showing it for the first time, the cartridge actually, Napasamy. So Napasamy is all about inventions.
Beautiful.
And this is because it's a myopic eye. Dialer
is there.
Yeah. Dialer, yeah. Dialer irukka?
Normally the surgeons go for a toss. Here the lens is going for a toss.
Dialer especially in Mohan Rajan sir's OT, anything can happen in the IOLs. I think that's a long track history. Or dialer, the chopper kudunga.
I should have. Anyway, we are recording this. It's a very nice because you know my video on IOL acrobatics. This can be one of them.
Yeah. So here again, the whole key is to get the rexus so that there's a good overlap. As I told you already, this is a slightly myopic eye. So the IOL power is actually 14. And when you do it under saline, the only thing is make sure the chamber is always formed.
Yeah.
So when you get a collapse, I don't take the risk. I usually put in viscoelastics. The advantage is you don't have cortex to aspirate. So you don't have to actually go under the lens to aspirate. So you can see the lens well centered into the bag here. And you can see here there is no rings or anything here.
Just like a regular lens.
Yeah. So as Narayan said,
what is the cost of this lens, Swiss Fob?
I think they based it around 8,000 or 9,000 hydro. So
why you have called it Swiss Fob?
So
Made in Switzerland,
basically I think this particular EDOF lenses are going to change the unifocal practice because you are giving some added benefit to the patient. And here again do a good hydro.
Okay. That was a brilliant surgery by Nivian. Let's give a big round of applause.
Thank
What
you.
a lovely surgery, Nivian. We're so proud of you.
Thank you, sir.
We go on to the next guy, the king of Chhattisgarh, and none other than Saurabh Luthra, and he is probably the fourth or fifth time he's coming for the surgical strike here. Come all the way from Bilaspur, and he's going to demonstrate to us a phaco with a century on mission. With active sentry.
It's in my eye, yeah. It's in my eye, the mic.
Yes. Oh, to you, Saurabh.
Good morning, everyone.
No, mic is on. Wait, 1 minute.
We are not getting the microscope, please, sir, if that can.
Okay, ma'am.
Yeah, now we got it.
Wait.
Okay, ma'am.
Okay. Now,
Slightly focus, if you can just focus a little bit.
Focus down a little.
Yeah. Can you help, sir? I'll do.
Okay, Saurabh.
Okay. Carry to ma.
Saurabh.
Yes, sir.
Are you on? Is he audible?
Yeah, Dr. Saurabh is audible, but a little bit of focusing. I think we are slightly out of focus.
Focus down a little.
Okay, sir.
It's okay now? Is it better now?
No, sir, it's not clear. Maybe he has to zoom out a bit more.
So, I've done my rexis and
He is doing a superior, that is his...
Yeah, I'm sitting superiorly.
Incision. That's probably the reason why, because eye is a little tilted down.
Yeah, a little.
Yeah.
Sir, Mohan sir,
yes.
He has to focus more. It's not very clear.
Okay, sir. I'll wait.
Wait.
Yes, sir. Tell me how. Now,
Dr. Saurabh wears glasses, right? So I think he needs some adjustment on the microscope so that his view.
Raju, microscope is adjustment. Focusing. Devan, focusing. I think zoom is also very less. Yeah. Yeah. Focus down a little.
yeah, good for me. Is it all right?
Slightly better. I think in the Professor Venkatesh sir was telling you have to adjust in the camera.
So this is a problem with parfocality where the surgeon is seeing clearly, but the projection is little off. So this adjustment can be done in the camera. There is a horizontal button there which you adjust it to be.
Yes, ma'am.
How is it now?
Okay. We are in phaco 1, phaco 2.
How is it now?
We can go back to phaco 1.
A little more focus is needed, sir. To move it.
So I am going to follow what Nivian has just taught us. So I am also a compulsive stop and chop guy with the routine parameters. Won't imitate. Can I have the chopper here? Naren, because Naren showed some extreme parameters. I am also using the Centurion with the active sentry, wherein there is an extra sensor, of course, on the handpiece per se. It gives you a real-time adjustment of the IOP. So I am using a 50 IOP as of now, 40 IOPs. In the trench, I think it's 50. So look for this nice red glow as you keep going down. Rotate.
Is it okay for you guys?
Yes, it was 90% okay.
90% okay, fine.
Which is good.
10% also will make it alright. Vardhaman, welcome. Vardhaman. Yeah.
So as you know, you keep going down, be careful, reduce your power, control your footstep. You have this nice glow, try your attempt. So that's where I got my crack. And I'll just complete it, rotate it back to the normal original position.
Does the Kelman tip help your trenching? You prefer Kelman tip?
Kelman or the?
This is the balance tip.
Balance tip.
So this is a balance tip.
Yeah.
Balance tip.
So, yeah. So now the parameters again have changed. I have, of course, a little high on vacuum. It's a fairly soft cataract, grade 1 to grade 2.
So what is the vacuum you're using, about 400, 500?
550, sir, I think. We are touching, I mean, it's on the linear mode.
Yeah.
3 to 500.
Saurabh, you have kept the sleeve so close to the tip. Is it regularly you do that?
I'm sorry, sir. Can you come back?
The tip and the sleeve.
Yeah.
You have not.
No, sir. I guess. No, sir. I have a little space, but I think the scenario here, because so I do have a little space in between. This is little close, as you just mentioned. So the beauty of this machine is you really don't have to change the mode for the last piece also, because of the active sentry. You are really not much worried. Still, for the beginners, it is always better to shift to epinucleus. Can I have a little more? Yeah.
Go. Start.
Okay. So we don't have much of epinucleus, it's all cortex, so we might as well shift. There's a small piece which will come out. Can I have some visco?
Going to use coaxial or?
No, sir, I'm a coaxial, yes, a coaxial I somehow have been very comfortable.
Lovely surgery, Saurabh. Very nicely done.
Thank you, sir. Partially done.
Yeah. No. Still there.
Am I centered there?
No, not centered.
So,
Even I'm learning.
yeah. To the left, yes.
Better?
Yeah, better now. Better. Not clear. So you're using a straight tip?
Yes, sir. With not much fibers, but as Sujatha ma'am also showed, I usually attempt that forceful irrigation there with some no, give me a little hydro, and then can you just get the lens ready? Yeah. So that kind of clears off these small fibers with the
power wash.
Yes, sir. And the trick is you need to dimple this down the main incision so that that flows out. You need to give the space. Yeah. Okay, I still have a small. So I have a fairly round centralized axis as we want for any of these EDOFs or the multifocals or trifocals planned. Yeah. So this screw. Okay, can you screw it for me? Is this a 2.2 sleeve?
Yes, sir.
Yeah.
Okay.
Panikrama.
So you use the 2.2, is it?
Yes, sir.
2.2 and is injecting a VVT lens now, implanting a VVT lens. And we talked about the VVT, how good it is. So distance, intermediate, near is not all that good, but
sir, with the little adjustment, yeah. Thank you.
I make a little micro monovision.
That's what, sir. That's the trick there for to get it done. And I have so far not given glasses to any of my VVT patients.
Yeah.
Promise them that they might need it a little.
See, the advantage of the VVT is that the near point has receded from 35 centimeters to almost 50 centimeters now.
Almost to 45-50 centimeters.
Because many of them are using iPad, tablet, or even the laptops at that distance.
So, Mohan sir, one question here. Do you aim any emmetrope or any -0.5 in this lenses, sir?
So dominant eye to the emmetrope, and then maybe a 0.5 undercorrection on the other eye will solve the purpose there.
Manoj, what's the next case?
You can see this central dip. Sorry, not exactly a dip. It's just a point. It's just 1 microam raised bar in the 2.2 centered area. Is it visible?
Yes.
So that is what is creating the extended depth here. And these rings, if you call them a ring or so, it doesn't compromise the halo or glare to sir. So
it's wavefront, it shapes the wavefront.
Yes, sir. It kind of gives the similar vision as a trifocal, but without the compromise of the contrast or the brightness to the patient. So it's fairly doing well. Only thing is the Alcon needs to work a little on the price factor so that it can be easily brought down to much more usage.
What about how tolerant is it to decentration? Just
Frankly, I don't have that experience, but I'm sure because it's a little forgiving. You can see the central optic is quite big, so the decentration should not bother as much.
Okay, good.
And with this Centurion active sentry, there is this. If you can show the screen, let's go to the final parameters. I would want to just tell about this, ASM thing. Go to the CD. So in this particular case, the ASM is 0. ASM stands for active surge mitigations, as to how many times the active sentry came into play. So God is kind. In this particular patient, there was nothing that required an extra edge, but that's where you get to know. Yeah. Sister, chinna air bubble kodunga. One nimsha. Why kodunga? Why? It's a small. It's a little stuck in the axis. Yeah. Thank you.
Yeah. Okay, ma.
Thank you.
Go on to the femto now. I think we shall get. Where's the mic, please? That a lovely surgery demonstration by Saurabh Luthra.
Thank you so much.
We go on to the femto by Kumar Doctor.
Thank you.
Yes.
Yes, sir.
Requesting the audiovisual team at the operation theatre for the video output. Yeah, thank you. Hold on.
Yeah, you're on. No. Mike, Hello?
Yes, sir. Tell me, please.
Hello?
Yes, sir. We are
Able to see this?
We are in the femto theatre.
Femto theatre, able to see?
We are able to see you.
Kumar Doctor is there from Mumbai, and Kumar, she is not using a speculum for the liquid optic interface there.
Tell her not to squeeze the eye.
Kanna squeeze பண்ணாதீங்கம்மா. Kanna சுருக்காதீங்க, அப்படியே இருங்க.
Stop. Tell her to look at the light.
Light பாருங்க. இப்படி.
Okay, look in the light.
Light பாருங்கம்மா. Very good ma. So you putting that liquid optic interface there?
Yeah.
Yes. Then you are putting saline.
So what we have done is we fixed the liquid optic interface, and now I just have to lock it in. So once that's locked, I'm only going to do rhexis and fragmentation. I'm not doing incisions. This is a toric enhanced lens. The beauty here is what I'm going to show is the centration of the rhexis, which happens automatically. People think it's more marketing. According to me, no, it is science, and it does benefit the patient. So there is no doubt that it benefits, and now I'm hands-free. So we go to the next step. She's pressing a lot.
Yes.
Yeah. So we are scanning. I'm going to do a 5 millimeter rhexis followed by 6 fragmentation. So this is what we are planning in this. You can see that the NTA chamber is a little shallow. The iris is there. The pupil is not very well dilated.
Yes.
But we know that it's a little hard cataract. So let's see how the case goes. We'll try to dilate. I know that fragmentation will cause a little bit of miosis. No, that's okay.
Are you using the center skip?
Pupil scan. So I did a pupil scan and centered the rhexis. No, 4.7.
4.7 good enough, or you want to make it a little bigger?
You can make it 4.9.
4.9 you can make it, yes. See, the advantage of this is that you can enlarge the size of the rhexis. Kumar, go ahead.
And you can center it. So we've done that. Approve. And once this is all done, so you can see
It's
that
almost coming to 5.
5. Yes. Yes. So it does a rexis in 1.1 second. That's the beauty. 50 seconds for the fragmentation of 6 segments. And then we'll shift the patient to the other OT. Hopefully the pupil will help me, otherwise I'll have to prepare a Melvin ring. I'm going to sit superior. It's enhanced toric. And the insertion, the placement of the toric is 19 degrees. It's a little hyperopic eye, obviously, because you saw that the anterior chamber was shallow.
Yeah.
So accordingly, we'll have to be a little careful in this case. I'll use a good viscoelastic that keeps my chamber deep. We'll try to stain the CCC so that you know that it's completely free floating, and that's one advantage of doing a femto. The disadvantage may be that the cortical matter gets cut below the rexis of 300 microns. So when it's a small pupil, you have to actually go around to make sure that the cortex is held. And
fantastic. That's a beautiful demonstration, Kumar. So, you are able to see that? Hello? Hello?
Yes, sir. We can see, sir.
Yeah, we go on to the main theatre now. Sujatha will be demonstrating one phaco with lucidus lens, which is a EDOF lens, and
You can switch on the mic. So,
Dr. Sujatha Mohan, madam, we are able to see you.
yeah. So good morning once again. So this is a patient who has about a grade 2 nuclear sclerosis, and I'm going to put a lucidus lens. I'm again using the Stellaris Elite, and so here we go. The drops put. So what you should always do is just make sure that the patient doesn't have any pain, and தொடர்ந்து தெரியும் வலி இருக்காது, அசைய கூடாது, அப்படியே இருங்க, நேரே பாருங்க, நேரே பாருங்க, நேரே பாருங்க, நேரே பாருங்க. Please don't move, அசையாதீங்க. Okay, ஏன் அந்த இது இல்லையா? This side put. Okay. வேணாம், எனக்கு வேணாம். Retro elimination, please. So, okay. So making a guard 30 micron, and then entering the eye. Okay. Here light பார்க்கணும், light பாருங்க. மாதிரி பண்ணேன்னு. So I like to bend the 62 myself. Most of the times I do it myself. I use Utrata only when I have to deal with a mature cataract, or when the rexis is the resistance to the rexis is not there. Otherwise, I prefer to use just drag it around. For people who are finding it difficult in doing rexis, the beginners, just drag the rexis around. That's the easiest technique to do. Okay, so here, as you know, Dr. Naren Shetty demonstrated, now you see how mobile the nucleus has become. So that is one point to note. They go from the area where there is least fibrosis, so that you get a nice, good dissection.
So using a Stellaris Elite machine, okay, with an active fluidics. No?
Okay, off, ma. Okay. So first go inside and remove all the extra viscoelastic, and then you start trenching. Just a little bit in the center, not too much. quite a soft cataract, it's not very, is it in focus for you people?
Yes, ma'am, it's very clear, it's very clear.
Okay, okay.
So how is active fluidics working in a Venturi machine?
It's working it's very well.
Because I think the aspiration flow is dictated by the vacuum, so you really can't control the flow rate, right, ma'am? How are they doing it?
1 minute, I just.
No, actually, it's not
softer.
To a certain extent, only it is related to the flow rate. Okay, the active fluidics actually maintains the chamber very well and senses the pressure in the anterior chamber, which is again very important for us.
Sir, it maintains a stable intraocular pressure.
Yes.
Is that it?
Okay. Correct. No, I agree with you. It's partly related to the AFR also. So in Venturi, you don't have independent control of the AFR.
No, but there's another tube which is going into the bottle, which gives the pressure, and there is a sensor which senses the vacuum, and based on that, the amount of flow comes into the eye. So the infusion is based on exactly how much of vacuum that we are using. So that's the advantage. It's slightly different from Centurion. You can see there's a bottle. The infusion bottle is low, but it has got another tube which is connected to the main console, which gives that additional mechanism to pump in the fluid. So it's entirely dependent upon how much of vacuum we use, and see now actually there is, you can see that AC is shallowing because I have not put any infusion. Okay. Okay, now. See, I must confess that I have hardly used this machine couple of times. Though I am an ardent follower of Stellaris, a light I am using only now, but this, you see how with ease you can adapt to this machine. It's really fantastic.
In your experience, is there a marked difference between the regular Stellaris and this machine?
No, there is not much, but you see the advantages that we are using lower pressure. Even without our knowledge, you see that the pressure is low because the bottle height is low, and that's the greatest advantage. And the advantage that the vacuum is directly linked to the infusion is also probably a safety factor.
Okay, ma'am.
Illumination max, sir.
Illumination is 80, no? Illumination is 80. We are using a Leica microscope on this side.
Excellent view, sir.
Yeah.
But Lumaris is better any day. Lumira is better any day. You get a better red glow.
Even Leica is good. I'm sure Lalit will say that Luxor is good.
So what about the dilatation of the pupil, sir? Is it a little bit lesser?
Slightly less. You can see the iris. It's not something which is very much doable.
But it's not maintained well, madam.
Yeah. CP.
That shows again there is no turbulence in the anterior chamber in Stellaris machine. That's the advantage. Stability.
Lens போட போறேன் நேரா பாருங்க. See கூடாது. So again
this is a Lucidus lens which is going to demonstrate now. Lucidus, as you know, it's an extended depth of focus lens.
See, it's called as a pseudo non-diffractive beam. So the advantage is there is a continuous near to intermediate, and it is an EDOF lens. It's got a central 1 millimeter aspheric zone surrounded by 6 millimeters of refractive zone. So it's a combination of both, and the advantage again is there is no rings. There are no rings. That's not going to cause too much of problems during driving. And this, you can see there's a closed loop also. So the centration is very good.
Which company, madam?
This is by this. I forgot the name.
Swiss company.
No, there's a Med Innovations, no? That guy
Med
is...
Innovations, yeah.
Med Innovations, he's only
What's the name of
marketing.
the company, yeah? Kumar. Kumar has got one of
Sadio, correct. Sadio
Kumar
is
has
a...
got the largest experience of Lucidus in the entire country.
No,
Huge
Sadio...
number of lenses he has implanted.
Sadio is the name of that Swiss company and is marketed by Med Innovations. Saline on the cornea, please. The lens is a little bit large, so...
But T plus it, Kumar. T plus it.
Ma'am, when you go behind the lens, do you change any parameters, ma'am?
No, I don't actually. But I don't actually. But I think for beginners, I think it's better to be safer and probably use lower vacuum.
Ma'am, again for the IOL power, what did you choose, emmetropia or minus 0.25?
Other eye we do.
No. Based on the other eye reading, no, then we change if necessary. Otherwise, first eye we go emmetropic.
Meena, the first eye always emmetropic in all these EDOF lenses.
If you notice very carefully, you can see that central ring. Can you see that?
Similar to the
Saline on the
CT.
cornea.
Slight central ring is there, which is very subtle.
Yeah, there are, you can notice, it's a refractive lens, so you can notice very subtle lenses, but otherwise, it doesn't give much of glare and halos. That's advantage.
So you can get N8, ma'am, with this?
Yes, but you can get both eyes implanted, you can get N6.
Will you aim emmetrope or minus 0.5 something like that?
No, other eye we'll have to titrate.
We'll stop here, ma. We go on to Kumar Doctor. Kumar Doctor is a top guy in Bombay, as you all know, Dr. Eye Institute. He's the only guy with two doctors, Dr. Kumar Doctor. And he is going to demonstrate to us, a very innovative guy, and lot of new techniques he's got. He's going to demonstrate this femto, what he did now with the high-ans toric. The first time ever we're implanting an high-ans toric in the entire country. And we are launching this high-ans toric. As you know, high-ans is a very good lens, and the toric version is also coming. Yeah, Kumar, over to you.
At the onset, I would like to thank Xylocard. Thank Mohan Rajan and Sujatha for this great opportunity. This is my second time here. This is a real small pupil. You saw that when I was doing the femto, and I expect it to be remaining like this. So I've just put a little bit of tropicacin inside, and now I'm going to put a little bit of Xylocard inside and then dilate the pupil as much as it can. Hopefully it remains well dilated throughout and we have no issues here. Otherwise I might have to use a Maldivian ring.
So for small question, you have put tropicacil inside, sir?
Yeah, so that is that ready-made available from Entod. I think that's what they gave me.
Phenocaine, sir?
Phenocaine, yes. And this is Helon that I'm using inside the eye. You can see that the pupil dilated a bit. And let us see if it is a free-floating rexis. I've done a 6 fragmentation on the femto, and then I'm going ahead and making my main incision. Some people do make incisions on the femto itself. They do open, and they are pretty biplanar, so they do pretty well, rexis. So this is the rexis that was created. And don't forget that I have a 500 micron protection. So all we have to do is just pinch the rexis out. So that's the biggest advantage of having this. Now this is a hydrodissection cannula made by Katina. So it has its own advantages. It's not the Helon cannula that we all use. And it's a 26 gauge cannula. And now we do a hydrowave. The beauty in that is that the hydrowave itself will find that plane of 600 microns which is behind. You saw the bubbles coming out. And that is done. So I did get rotation. Tell the patient to keep looking into the light. Not to move the head. So we have already rotated the nucleus. You can see the 6 fragmentation there. Peko. So this is a sharp tip chopper made by me only and marketed by Epsilon. No financial interest. Same one Mohan Rajan uses. And now I'm using a Signature Pro machine. So let's see how this goes. So here the important thing is we have to be sure that the pupil remains dilated. In fact, I was thinking of using a dispersive viscoelastic, but at the end of it I think this will do well. So I'm just going ahead and just grooving a little bit. No, क्या है settings?
Sir,
No,
can you
group
explain
करो
the
group.
settings also, sir?
So I have a 500, no, group. I have 500 vacuum with a case at 300. I don't know how many of you know that Signature Pro has patented case. Case means when the vacuum drops from 500, it doesn't drop to 0, and that prevents the surge. So you see that I'm grooving this a little bit because it's a hard cataract, it's not a softie, and the pupil is very small. I want the pupil to remain dilated throughout the procedure, and that's going to make my life a little easy. So here I'm going ahead, I've got a little bit of grooving. Now we are going to bury the tip inside, hold the nucleus. Once I've held the nucleus, we are going to chop, and the chop will be in the same direction as what we had separated with the help of the femto. So again we'll go around, and you can see that I'm getting the same angle. So you can see that separation happening there, and that is in the same direction of the femto. So femto is proven that it reduces the amount of phaco energy. There is no dispute there. It is also proven that the centration of the IOL in terms of femto is far better than the manual rexes. There is nothing wrong, but it does give a little edge. So you can see that I am separating in the same plane that I had initially created with the femto. Saline on cornea, please.
So what is the smallest pupil size you have used a femto, sir?
I have done even a rexis of 3.2 millimeter, but you can do one thing is that put a Melugan ring, then do a femto, or put a Bhattacharya ring and then do a femto. You can still go ahead with it, and both ways it works quite well. I was thinking here I might need a Melugan ring if the pupil comes down in between, but we will see how it goes till the end of the procedure. Otherwise you have to use a dispersive viscoelastic which will hold on to the pupil, but hopefully I will get away with it. And you can see that I am holding now each part and then separating. This was the original, you can see the clean cut made by the femto. Sorry. So this is as far as the centration. If you don't see it well, please let me know. We can go ahead and do that.
Dr. Kumar, is there any change in technique in chopping when you use femto versus your regular?
Not really. The chopper is used in the same way. It helps you separate the groove which is already made by the femto.
Okay.
So that's the advantage. So now half the nucleus is out, and then the other quarter is out. The team here Mohan has created is unbelievable, phenomenally coordinated. The staff is so well trained, they don't need to be told anything. Hats off to Mohan Rajan and his team.
I can see on the screen, Kumar sir, that the vacuum goes really high, but the power use is just 10-20.
Yeah.
You've kept it till 80.
Correct.
But with the help of this femto breaking it up, so the actual power use is pretty less.
So it's a linear control of power, it's not panel. So we are using 10% of 80 adjustment, which is hardly anything.
True.
And we are far off from the endothelium, so that's one big advantage.
Only single attack.
Yeah, so now the last piece, that another trick I believe is that remove your other hand, that prevents a leak, that maintains your chamber, and the last piece, make your handpiece straight. Okay, better?
Yeah.
And that will help you to maintain it away from chamber collapse, etc. So that completes your case.
Excellent.
And you can see the pupil has come down a bit, epitrate.
So slight
dilatation of medicine.
Yeah, we'll focus.
Centration we have.
Sorry.
Center also.
Yes.
Okay.
Methyl. Yeah. So again we'll try to tell it to look into the light. Yeah. So again I'm trying to put drops inside by manual.
So one question to people who do femto cataract. Dr. Mohan?
Mohan sir, there is a question for you.
For me.
Yeah ma'am, please go ahead.
Yeah, so how do you counsel, sir? Give us some tips for us and to the audience. How do you counsel? Yes. What do you tell your patients, sir?
I tell my patients that if I do manual phaco in your type of cataract, it is 100% safe. But femto is 150% safe. Safety is first. Okay? You tell them the safety. Especially for brown cataracts, mature cataracts, posterior polar cataracts, all these complicated, complex situations. You tell them that safety is the thing, most of the patients will agree. I am doing almost 40% of my cases now femto. How about you, Naren?
Yes, sir. I think absolutely true. I think that is definitely a much superior procedure. But more importantly, I think in terms of if you think about practice-wise, a lot of patients come and ask for the laser or bladeless surgery. So then what happens is you're in trouble. You say that no, we don't do that, and you say that it's not superior, it's not a very superior procedure, and so on and so forth. But eventually, in the patient's mind, what they'll feel like maybe this hospital is not very advanced, they don't have the latest technique, that will come in their mind. So that is one of the things what we realized in the very beginning when we didn't take the bladeless procedure at that point, in the very early stage, that slowly we start losing the confidence of the patients that we're not very advanced in terms of technology. So that is something which is that we have to keep in mind, especially when you have a private practice.
Did your premium lenses improve with using this femto platform?
Oh yes, definitely. Actually, it makes life more easier. Especially, see now, it's a machine which brings down the gap between an amateur and a mature surgeon. The mature surgeon does not have to break their head in terms of central rexes, perfect, circular and everything. But in a femto, repeatedly you will always have a bang-on central and perfectly overlapping rexes. And that will give you very good outcomes, especially in these premium lenses like these trifocal lenses or toric lenses, if you're looking at those things, because overlapping is very crucial in those lenses. Definitely.
Dr. Naren, do you make your incisions with the femto or with in your femto cases?
I personally don't use the femto incisions. I mean, it is become much better because as you saw, sir, like in my incisions are extremely limble and extremely short, which is not possible in a femto, because if you go so limble in a femto, then it won't fire because of the vessels. So the dissection will become pretty challenging. Because I create such an incision, I don't do the incision part of it, so that I create a very short incision and create as less astigmatism as possible.
So I have finished my bimanual IA. One take-home message here is that your IA changes a bit because your cortex is cut below the CCC for 300 microns. And that's the reason why you will not have free-floating cortical fibrils, which you can hold in IA. So that's one additional step that you have to change in your technique. As far as the discussion was concerned, what to tell the patient, I tell the same thing, that your safety increases. Methyl. CMC. No, CMC. Methyl cellulose. Visco.
Sir, can you talk a little about the lens here?
So I'm using an enhanced toric. And sister, I have Y in that. You have loaded the lens? See the advantage working at one's place, your lens comes loaded. At my place, I have to load the lens. So I'll have to change my venue. When one is ready to employ me, I'll come here.
What one, sir? What do you have to say?
Because I cannot afford you. That's the problem. I can employ you.
Put me there.
I cannot afford you.
So we are going to be using an enhanced toric, sir.
So this is an EDOF lens. I can see the margin of the CCC. So we have to go below that and then align the toricity, and the pupil is slightly small. We had discussed this point and we did femto. Sometimes the pupil further comes down. T here, sister? No, T. That T.
Kumar.
Yes.
We should talk about the advantages of a high-arc lens.
Yes.
And how the toric is going to make a difference now.
So this Sinsky I don't want, sister. T. There must be a T there. Yeah. So the enhanced lens, the biggest advantage is that it gives you the intermediate beautifully with no glare and no halos. So I have just made sure that no sister, you have the T from my set. T. There will be a T. Yeah, one of them will be a T. T. No.
So, sir, with this enhance, can you promise your patient, or rather do you every time promise unilaterally or bilaterally is what you promise?
No, you have to do a bilateral eye-hands only.
Right.
And that will make sure, see now the lens is in the bag.
Yes.
And now we'll align the toricity, which is on the Callisto.
Yeah.
With 19 degrees. So you can see that it is, I use a Virion in my private.
Okay.
Are you want to put yellow dotted line or a blue line? Blue. Okay. So I use Virion in my private. So I was aligning it to the yellow dotted line. So now I've changed it to the blue line. We do about few degrees apart and then we do a bimanual IA, wash off the viscoelastic and make sure that when we do in toricity a bimanual IA, what I like to do is press the lens a little bit so that it doesn't rotate.
Yes, sir.
So that's the big advantage of doing this.
And maybe a 10-degree under correction, and then with the hydro it kind of rotated to
correct.
position. And then
So I'm pressing the IOL a bit.
Yeah.
And kept it 10 degrees off as rightly said, and then we will just align it. And sometimes we go behind the lens. No, don't have continuous.
Don't do it. Visco only.
I'm just removing viscoelastic from behind the IOL. So this aligns, and now we'll just align the lens. Hydro. Yeah.
So do you like to put an air bubble at the end of torics?
Not really, but here the AC is little shallow, as rightly even shown on the femto. So we may see how it goes, and if it aligns, then we may not put it. So right now I'm just hydrating the wound, making sure it's all there, and then making sure that it's aligned. And now we are just.
Does it have the 3 dots, sir? Can't
Yes,
see very
yes,
clearly.
yes. You won't be able to because it's behind the pupil, but I can see the dot because of the microscope.
I think we can.
So you can see the dot here and I can see the dot here.
Maybe a little fine focus will help them see, sir. Yeah, it's seen, sir. It's seen. Yeah.
So I'm rotating the lens a bit to align it to the blue line. One thing I miss in the Virion is, there is one more alignment that you have to check, which is missing here. So now I've seen that it's slightly off. So I'm going to rotate the lens a bit and now align it this way.
So when do you check slit lamp after surgery for the alignment?
No, we really don't.
Saline finish.
Saline finish.
After the speculum or immediately on third
Just
day?
give me IS system, irrigation dena. Yes, irrigation. Yes. So I can think you can now see, give me Sinsky hook. So now you can see that these are the dots.
So you're off this high.
No.
Can we have Kumar sir's?
So you can see the dots.
Yeah.
And now the blue line is aligned to the dots.
1 second, sir.
See the inferior dots?
Yeah.
I don't know whether you can all see.
Yes, we can see the dots.
Yeah.
Seen.
And occasionally the Callisto appears.
But the Callisto is not visible to us.
Oh.
They need to split screen it actually.
They have to show us in a different screen.
So now I'm just removing a little bit of cortex which is floating around.
Small fiber. To the cortex.
Oh yeah.
Sir, regarding the alignment, when do you cross check it, sir? After
If there is a problem we check, but see this pupil is not going to dilate even in the post-op.
Kumar, can you?
Yeah, done. Thank you.
Okay.
Excellent.
Thank you.
Can we go to Mohan Rajan sir's screen? And sir, can you talk a little about
the final cataract case? After that, we'll go on to the cornea the talc by Rajesh Fogla. Able to see that?
1 minute. Huh?
Yes, we are able to see, sir. Yeah.
I am going to show you the world's best injection system. That is the Nanex. You can see this is a multi-cert. You can see beautiful it is. This is an Nanex lens which can go through an 1.8 millimeter or sub 2 millimeter incision
I've already done the phaco. You can see how beautifully it is going. The ozone surface prevents the PCO. It's a hydrophobic acrylic lens.
Beautiful injection.
It's beautiful injection.
And there's an added advantage also, sir. They have a guard there. If you want to do a sub 2.2 also.
Yes.
You can, move the guard up and go directly in the bag.
This Nanex Hoya and the Vivinex we are using. Hats off to the Hoya guys for the
injecting system.
The injection system is probably the best, I would say.
That's true, sir.
Much better than the Clarion or anything else for that matter. But Clarion also is good.
So I heard that they are one of the smoothest surface of.
Fantastic. It's really fantastic lens.
And sir, to add on to this, the Vivinex system is even smoother because the lens is a little thin compared to Nanex. So it's even smoother. It's a beautiful injecting system.
Is it a hydrophobic or hydrophilic lens?
Hydrophobic lens. It's a hydrophobic lens.
You have both the, screw it up.
Biocompatibility is very good. The multi-cert is fantastic. And it's become a regular feature in our operation theatre of this Hoya lens now. We have the Hoya toric also, the Vivinex toric, which is also very good, very stable as well.
And all of this,
just to show you that, so that we come to the end of the cataract session, and now we'll have a small presentation in the.
So this was the only preloaded lens you showed us today, isn't it, sir?
Naren has done a photo. What case is it? Dark. Okay.
Dark, no.
Sorry for the.
No, let me. Correct. 2 minutes, I'll do the finish of presentation.
By the time it's getting ready over there, big thanks to the panelists of the cataract session, Professor Venkatesh, Dr. Srinivas G. Rao, Dr. Lalit, and Dr. Meena Lakshmipati. Thank you so much. You have honored us by being the panelists in this wonderful cataract session. May I call upon Professor Dr. Radhakrishnan to come forward and as a token of appreciation give a small memento and a shawl to the panelists, please.
Thank you, Ravi sir, from the OT.
Yeah, let them finish off the presentation there and then we'll go to our presentation. Ravi, you finish it off there.
So thank you.
That's the end of this case. Beautiful Nanex case.
Radhakrishnan sir, honor Professor Dr. Venkatesh, please.
Okay. ICV Kuduma. அப்படியே நல்லாச்சு.
அப்படியே back. Small memento from Rajan Aikar sir. Thank you so much. You honored us. Dr. Srinivas G. Rao. Lalit absconded, sir.
All the surgeons, please.
All the surgeons.
Come. Yeah, come.
And
get everything.
Meena Lakshmipati, please.
Sir, vaanga sir. Aarti, shawl and gifts ella konda kellathiyo.
Thank you so much. Dr. Meena Lakshmipati.
Ravi?
Yes, sir.
Ravi?
Yes, sir.
I need only 2 minutes of your time.
Please, sir.
Oh, 1 minute, ma. Yeah, Senthil, Naren. Yeah. 2 minutes of time. Here we have.
We want external camera from there.
Yeah, external camera of the theatre, please.
Yeah, please. External camera from the theatre.
We have the honor of having the president of Tamil Nadu Ophthalmic Association here, none other than Dr. R.K. Ramakrishnan, and he's been kind enough to come all the way from Tirunelveli and give a big round of applause for Dr. Ramakrishnan. And I request Sujatha to felicitate him. Yes.
The most sterile way
Good.
to felicitate.
Yes. Is a sterile shawl as well.
Unfolded.
Yeah. Yes. Yeah. Yes. So the first surgeon to be felicitated is Dr. Aditya Varman. Aditya Varman, I think you are doing better than your father. Yeah. Yeah. Give a big hand for Aditya. Wonderful surgery as usual. Signature Pro with high ans lens. Okay. The next one will be Dr. Naren Shetty. Where is Naren? Come on. Big round of applause for Dr. Naren Shetty. You're able to see that? Ravi?
Very much, sir, very much.
Give a big round of applause for Dr. Naren Shetty. Another wonderful surgery by Naren. And Dr. Saurabh Luthra. Yes, yeah. Saurabh Luthra, King of Chhattisgarh. Yes, yes.
Bilaspur ki Maharaj, sir.
Big round of applause for Dr. Nivian Madhivanan, our own boy. Nivian is always part of Rajan Aikar.
Thank you.
And Kiranjit Singh, where is he? Kiran, hi, big man. The big man from Amritsar. Genes cannot go wrong. Yes.
Thank you.
And Kiranjit has proved it today with the beautiful demonstration of that iris claw lens. And then of course, the great guy, the Bollywood actor. And you know, the other side of Kumar Doctor we saw yesterday. He's a beautiful photographer. You should see his photographs. A lovely photographer he is.
Nice photo.
Yes. Wait, my camera, my camera. Yes.
So everybody, I'd just like to take this opportunity to take 60 seconds. So it's a great honor and privilege for me to be announcing this for the first time, that we have got the patent for the CM T-Flex IOL. So my journey started here in ophthalmic career with Dr. Sujatha Mohan and Mohan Rajan. So they are like my ophthalmic parents. So no other bigger honor than actually releasing it. My first presentation was with Kumar Doctor Sir, who had a lot of questions to me which we worked on.
Yes.
So this is a very proud moment, and thank you each and every one of you for making it happen. We applied in 2019.
I used my first T-Flex last week.
Oh, very good.
And it was fantastic. I think the glue part is gone.
Glue part is
the
gone.
tucking part is gone.
Yeah. Hope Amar is, I think, listening online. You know that, no? It's online as well. I request President Dr. Ramakrishnan to say a few words.
Good morning and good afternoon, friends. Really, it's I'm really honored to be here at Rajan Aikar for this surgical strike 360 degrees. And seeing all the surgeries and arrangements, I am very, very happy. And I congratulate my dear friend Dr. Mohan Rajan, past president of Tamil Nadu Ophthalmic Association and also director of Mohan Aikar, Dr. Sujatha and also Dr. Ravishankar for wonderful arrangements. It's not that easy to arrange such a mega live surgery in a single day. In all specialities.
Thank you, sir.
Single specialty you can, but all specialities including oculoplasty, glaucoma, everything. So really, and also the topmost surgeons of our nation. I'm really very happy and congratulate. One thing, glaucoma you have not given much importance.
No, we are giving.
Yes,
Yes,
but only one surgery.
Yes. Sir, you are a role model and inspiration, motivation for all of us. I think we should all give a big round of applause for Dr. Ramakrishnan, the president, and we'll go on to the DALF by Dr. Rajesh Fogla. Over to Sujatha, please. Thank you, sir.
For the presentations, may I have the privilege to call upon the panelists for the cornea and refractive session, Professor Dr. Vasanta, Dr. Kalpana Suresh, Dr. Nishant Madhivanan, and we also request Dr. Meena Lakshmipati to join us for the cornea refractive session also. Thank you. Over to the corneal surgery over there by Dr. Rajesh Fogla. We request the external camera. Yes, we are able to see Dr. Sujatha Mohan. Over to you.
I think Dr. Rajesh Fogla needs no introduction. He's an international surgeon and probably one of the first pioneers in lamellar corneal surgery. And all of us, I think, indirectly or directly have been learning from him. His YouTube videos are fabulous. So whenever there is a problem, I go and look into his YouTube videos. And in my spare time, I think I see more of Rajesh Fogla than my husband. Because I keep looking at his videos.
That's a very aggressive
statement.
This patient is a 19-year-old patient with advanced keratoconus. Are you able to hear me?
You press it when I
Very
say
much. We're able to see you, we're able to hear you.
Okay, so this patient we are planning for DALC. I hope you showed the topography of this patient. Did you show the topography there? Doctor?
We require the external camera. We are able to see you.
Yes.
We are able to see the internal camera now.
Rajesh, your mic is on.
Yeah.
Yes,
Release.
Yeah, ready.
Yeah. So we are starting with the surgery. I have marked 8 millimeter and I am using a 7.75 suction trefine.
Good morning, ma'am.
Each
Dr.
quarter
Nishant here.
turn.
Good morning, Rajesh. So what are the patient details, sir? What patient are we operating?
This patient is a 19-year-old patient with advanced keratoconus. I think they would have showed you the photographs there. Do you have the photo of the pentacam photos of this patient? Dr. MRS? Dr. Ravishankar?
Yeah. Photo.
If you can put it in the side without disturbing the surgery.
Sorry, madam, we have not received the topo photograph. Sorry.
Okay.
Okay, fine.
So it's a keratoconus patient, non-hydrops is what I'm assuming.
No, it's a keratoconus patient.
But not no
hydrops. Extremely thin cornea, around somewhere around 260 or something.
Yeah.
So this is the vacuum trefine, Barron's vacuum trefine, and you made around 6 tons,
Yeah,
Dr.
it's
Fogler.
a Barron vacuum trefine that we are using to. It's a minute. Yeah, but the suction trefine is.
You didn't get
Give
a
the
suction,
regular
I think.
trefine. Yeah, I think the trefines are not cutting. Just take a regular 8 millimeter trefine or something.
No, 8 millimeter trefine.
Give the other one.
What happened to Barron?
Barron, they not got it in the past 3 years because of COVID. They ran out.
Release. Just leave it like.
How do you know the depth?
Each quarter turn will cut down a depth of 60 microns. So now it's touching the cornea. So I'll make 1, 2, 3, 4, 5. Press. Yeah, this has cut. I don't think we need the other trefine. So you can see that. No, we don't need.
I don't know. 5 means 300 micron. Huh?
Yeah, 300. So you can see that we got a nice. So this way you can plan whatever depth you want rather than just going manually by feel.
Dr. Fogler, did you center the cornea? Did you make a mark?
Yeah, we made the mark. If you see, these are the 4 marks that we made. It's kind of also you take into account the pupil and you try to include the entire cone crescent. Sharp, huh? So now before we do the air injection, we'll just do a little bit of debulking. As the left hand is lifting up the tissue, you see the whitening of the stroma. And with the blade, you are just cutting that white part. So you are not using the right hand in an active manner.
Dr. Fogler, your
Central depth of the cornea is 260.
before injecting.
Yeah, so I
you're
will not
doing
go to the
debulk.
center.
No, but you went, the periphery is a little thicker.
Thicker. So in the periphery, we go 80% of the peripheral thickness at the site of trephination. 15-degree knife. So now, since we have done only a partial thickness trephination, I want my needle or the cannula to go deeper. We will just, before we introduce, we will slightly deepen the groove here. So you can see that we made another plane.
That was a
And now we will go with
sideboard, blade
this
that
is a
you
5cc syringe with a 26 gauge needle. And you can see the bevel is, can I have another one? The bevel is facing. The bevel should be facing down, not up. Another 26 gauge.
26 kg needle put.
Needle
Dr.
holder.
Kogla, you have
Needle
your
holder.
fixation forceps usually, isn't it, for this?
Yeah, but I don't have my set of instruments. I am just using what Dr. Sujatha uses, so trying to recreate a real life situation. So we have 26 gauge needle. You can use a 30 gauge needle as well. And if the apex is very thin, the needle will go in the mid periphery.
You didn't bring your groove and that instrument.
Which one? Yeah. Change hands now, and then
You're injecting air with a 2 cc syringe, I suppose.
you can see that we got a paracentesis.
So this is the type 1 bubble.
This is the type 1 bubble, but I need to expand it more. But before I expand it, I'm going to do a paracentesis to reduce the counter pressure from the aqueous. Now put a cannula to it. The 5 cc syringe, put a cannula on it.
So you have your cannula usually for injecting the air, right?
Yeah,
sir?
he didn't bring it. He has not brought any of his
Okay.
his usual instruments, and he's
Yeah,
just
so I'm just trying to show you that you even without those instruments, you can still do a big bubble jalk. Now to enlarge the bubble, I'm going to again inject air. So I go back into the same track, and as I'm injecting air, you can see that the bubble has expanded.
And you're doing this not to prevent the rupture of the first bubble.
No, we want the bubble, we want the plane of separation to go wider.
Yeah,
marking pen.
you did the decompression to reduce
Yeah,
the
so
proper
there is,
pressure
so there
that
is
it
no
doesn't
spontaneous rupture, because sometimes the counter pressure from the aqueous increases the intra-bubble pressure, which can lead to spontaneous rupture. Now I'm going to do the brave slash, so I'm just going with a knife. And now you can see that that's the opening that we have made. Crescent. No, I don't need viscose. Saline.
Dr. Rajesh, do you put the small bubble to test the...
Your voice is not very clear. To speak up a little louder.
Do you put a small air bubble in the intraocular chamber to check if the...
Yeah, you can do the small bubble test when there is more of stromal emphysema and you're not able to be sure that your bubble is in the right place. So you can place a small bubble in the anterior chamber, which if the big bubble is there, it will be remaining in the periphery. And when you deflate, that bubble moves to the center. Yeah, we already deflated the bubble. Now I am just removing the lamellar plane of deflection.
You don't use high density viscoelastic. Some of them use it.
You can put in viscoelastic to push the layer back.
Okay.
So that, but again, the problem is that once you open up the stroma, all that viscoelastic comes into your surgical field, and then it makes it a little messy.
Okay. The only advantage is they say that it is a slow release of gas. So
yeah, you can put viscoelastic on top before you puncture.
Only at that area where you are puncturing it.
Just give any dialer. Huh?
Dr. Rajesh, would you tell us why you marked the area where you did the brave slash?
Yeah, that's because if you sometimes make your opening little smaller, you forget, you're not able to identify, because there are these kind of dark spaces in between the white area, so the opening can get lost.
Yeah.
So now what happens is here you can see where you have made the brave slash. And also
you have to dissect further, no?
Further, yes.
So from that point you start.
Correct. Scissors.
The panelists can be a little louder.
Be able to hear.
Yeah, because
No, only the person. So you don't inject. What I do is I inject viscoelastic to
you
separate.
can, but like I said, that if you inject viscoelastic, once you enlarge the opening, all the viscoelastic comes out.
Yeah.
Then again you have to wash out the viscoelastic.
Okay.
But yes, you can put a small bubble in the anterior chamber, inject viscoelastic, then the small bubble will move to the periphery. It tells you how much of viscoelastic you need to inject.
Okay, I was thinking of injecting viscoelastic between the posterior stroma, yeah, between the decimals and the posterior stroma.
Correct.
So that gives, I mean, that makes sure that we don't accidentally puncture the decimals.
Dr. Sujatha, can you tell us what scissors he is using right now?
What?
Scissors. What is he cutting?
He is using a blunt Vanna scissors. I think it is comes under the name of Fogler scissors.
No, I don't know whether this comes under, but this is a blunt tip scissors, so don't use don't use a sharp. And now you can see that here our dissection has not gone all the way to the periphery.
Okay.
So before you go ahead and
Yes.
you can always do a little bit of dissection to the edge of your trephination using the scissors or any blunt instrument, so that when you are excising your residual stroma, there is no vertical ledge in the periphery.
So Dr. Fogler, there is no need to introduce any iris spatula like instrument to see the separation, or would you directly go ahead?
You can, if you want, like you can see here, that there is some peripheral adhesions which are here, but you can always break them as you go along.
Only thing is, it's very important to keep the eye very soft, like what he has done. Because otherwise, even if you're using a blunt forceps, you can still puncture the periphery. And commonest area site of rupture is when you're dissecting in the periphery.
And the other thing is, I think continuously AC paracentesis should be done, so that the desmids fall back and doesn't.
So actually, you should keep on releasing the aqueous from the.
And also lid speculum, you should not keep your lid speculum too tight.
Okay, yeah. The other point that I did was...
you're doing all round. Normally we make that 4 quadrants and do it. No?
Yes, so we can make it, we can split it, it makes it easier. If you're a lazy surgeon, then you don't want to make the 4 quadrant. And always keep the eye soft and lift up the residual stroma, introduce your scissor. Watch what you're cutting, don't just blindly.
Beautiful. Fabulous.
Very nice.
The moment you said very nice, we ended up with a small. Small, yeah, that's okay. Give the air. That is for very nice.
I didn't know, sorry.
No issues.
No, this makes life more interesting now.
Yeah.
No, that's perfectly fine. You don't need to do anything. Just sing a song and continue with the surgery.
So what he has done is he's tamponaded it, but he's not injected too much to blot the perforation.
Yeah,
so just injected as little, but he did it so fast because he's done it multiple times.
So the last place he'll be dissecting is close to the area of perforation. So he go all round and probably on the other side as well. I have had couple of instances where some stromal tissue is left. We can even suture it. We sutured it and continued with the dissection. Always, it's always better to do a lamellar graft than a full thickness graft, and particularly this patient is very young. She's only 19, so it's better to avoid a full thickness graft.
What about the donor tissue, madam?
What about the donor tissue is 24 years old, but actually it doesn't matter because it's a lamellar surgery. But we have a 24-year-old cornea.
Oh, is it prepared already?
No, I haven't prepared.
Do you want him to prepare?
Yeah.
Okay, prepare print. What about that one you used, the DMEC?
Yeah, we can. That can also be used.
That one we can use.
Yeah, but that one I'll have to punch out the DM for the DMEC, and then we can use the remaining 8 millimeter.
Okay.
We can use it. We can get the tissue from there and. Pardon? Yeah, fine. Don't do.
He wants to.
So you're using the same tissue for 2 surgeries?
Yeah, that's what we are planning. We have enough tissues.
Okay,
but
good.
we are planning to use the same tissue. Heel punch.
Yeah, I'll punch. Yeah, you have the, in the same catena, you have the 7.75 punch. You had shown me, the white punch. Take that.
Barons to find 7.75. What is, this is 7.75, no? Okay.
Yeah.
Normally you keep the same size for
ectatic, yeah, same
okay.
size.
So in patients,
because you want to achieve some
Yeah,
flattening as well.
and also when there is a perforation, is always better to use the same size graft because the chances of a double anterior chamber is much less.
What is the size?
7.75. You punch pandriya?
No, I'll punch the demec tissue. So that should be fine. I'll do it 7.75 then. So you can get the demec tissue which is in the other OTA. Here only, no? Then it's fine.
The DMAC is safe.
Can be brought in here. So you can see the descendants is beautifully exposed, and you can see that air bubble in the anterior chamber.
You can see that when I'm manipulating, you are getting the fluid
Some amount of
that's...
aqueous is coming out through the area of perforation.
So you should always, the area of perforation is the last to be manipulated. You should always finish rest of the dissection and should not try to...
Over dissect in that area.
Yeah.
So
put a glue or something?
Not required. Air is the best thing. And once you put in your graft, it will anyway seal.
Yeah.
And since it's a superior perforation, if you are worried, you can leave a small... See, even this tissue that I have dissected, I can always put it over this side, you know.
Okay. But like he said, because it's a superior perforation, the air tamponade will be very good.
I can just leave this in the site of perforation, so that also prevents the air from
Okay.
leaking out.
Now,
Yeah.
for temporarily, okay.
Dr. Sujatha, what kind of block was given for this patient?
one,
Any mannitol was given?
We gave a medial canthal block and we gave 2 Diamox before surgery.
Dr. Meena madam, is mannitol required for all lamellar procedures or?
No, not really.
We've never given mannitol. Just wanted to know whether they have...
No, actually, Meena, a good question, because if I am doing it, I will give mannitol. I know when Rajesh Fogla is doing it, the chance of perforation is very less. So
very occasionally, yes ma'am, I've heard.
It's always better to be safe than sorry.
Because people do it under general anesthesia also, DALC.
Yeah.
So whether you're trying to emulate any of those low intraocular pressures.
See, the thing is, if the patient is a young patient, I would definitely operate under general anesthesia, but Rajesh said he is okay with doing under topical, under
Not
block,
topical.
under block. But in my personal preference is definitely general anesthesia for younger patients, particularly keratoconus patients, because the success rate is so good, we just cannot afford to go wrong.
Ma'am, has the patient undergone cross-linking? Just asking for any... As the patient, I know it's 276 might not have undergone cross-linking. Has this patient undergone cross?
No, she has not undergone.
Sujatha, what would you have done if the perforation had been in the center?
Same thing, ma'am. We'll just continue with this. Now the air bubble is there inside, no? So it'll tamponade. I have had even larger perforations where I have sutured, like I told you, I'll put a 10-0 nylon suture, continue with the dissection in the rest of the area, come to this place last.
How do you suture that area?
If there is a little bit of tissue left, no, then we can still suture it.
Any experience with putting fibrin glue in the site of perforation, Dr. Sujatha?
No, I have not done it.
But it's been described. People have tried putting a kind of a stromal patch. They put fibrin glue, then put a small piece of stroma just to tamponade that area.
The only problem sometimes being described is you can get double anterior chamber if you have a small perforation.
tissue we'll prepare.
So the best thing is to, if you're going to have a, this thing, have the same size
We'll
graft.
do it under the
So
microscope.
chances of double AC is very much reduced. So now what Dr. Rajesh is going to do is he's going to punch
The cable is
the
something
DMAC
is
graft
blocking.
so that we can use the other side
It can come.
for the DALC.
You want to show that also?
Yeah.
That should be fine. .75.
Okay, is it short? Yes.
Yeah. See.
Tooth.
So the DMAC has already been prepared and it is separated and it's kept there. So now he is going to punch the DMAC graft and use the other tissue for DALC.
You have a contact lens? I can then show you how to transfer the DMAC onto a contact lens and then punch it.
Yeah,
Then
contact
punch.
lens, can you BCL in that?
Open a BCL.
Open a BCL.
BCL.
Time.
Oh, the graft is still there, is it?
Yeah.
DMAC?
Yeah.
So you need to separate that and then go for the punch.
Yeah, it's separated.
Beautiful.
So this time he has done a different technique which I have not seen. Is that is he's injected the air bubble
Block, which was
from the trabecular meshwork, and then once the DM gets separated, then you just score around the corner and then pull it off. So that way, you get a. He says it's much easier because the air bubble is already separating it.
Where?
So he goes through the trabecular meshwork into the stroma, just below the descendants, and injects air. So that it gets just like doing a big bubble in the reverse.
So he calls it the fluid assisted.
Fluid assisted. Yeah,
Dismet
right.
stripping.
Yeah.
It's been described earlier as liquid bubble technique, but there they use a cannula instead of a needle.
Okay. BC Lundirtha. Where did you make the mark? You have already made the mark?
Yeah, the mark is already seen. In the reverse, you can
Okay.
see that F stamp.
Okay,
That's
okay.
from the stromal side.
All right.
What is the age of the donor of this
What happened?
tissue?
No BCL, eh?
24.
Even poi nee pippe eduthu nipo no ella scrap pani ready irukka
70.
22 or 24 somewhere around
No,
the
this
20s.
one for the DMAC, it's 76.
Okay, right. Oh, you use the 76.
DMAC.
Yeah,
So
DMAC was 76.
Dr.
This is the
Poplar
donor tissue
used
for
the
DMAC is 76.
Yeah. So he is using the
Remaining
rest of the
part.
cornea for
Come,
the
come.
DALC.
Contact lens, ma?
Doesn't matter what power, you give any contact lens.
You're opening it, okay. So he is just going to show how to transfer the DMAC graft onto the contact lens so that we can keep it aside and use the rest of the tissue for the DALC.
Bring it. This is tying. No, this is tying.
Doctor, why do you want to use the contact lens to keep that tissue?
Because you want to punch the donor tissue centrally. So we will leave fluid, saline.
A little bit of. Why don't you want to keep it in a petri dish?
Because I think it protects the
Okay.
tissue much better.
Okay.
So we will leave it here just for the time being, and in the meanwhile we can. So I can, because there I have made the F mark a little peripheral.
Yeah.
If I punch out that little peripheral, then the cornea for this will become little asymmetric. So now we can go and get a nice punch. So that's fine. So this tissue we can use for DALK. Now we will come back to
This one, can we load it and keep it in the syringe? No.
yeah, we can.
Okay.
The thickness 30, 50 micron, how much is it?
Only decimates more, about 20 microns or
30 microns?
20 microns.
Sure.
It's thinner than a contact lens. Yeah, okay.
Madam, usually a 24-year will screw
No,
up
this
on
is not
itself.
a 24. See, we had a 24-year-old.
Okay,
But
okay.
for Descemet stripping, it's better always to go for older grafts.
Exactly.
Because yeah, the additions are more with 24. So we have used a 76-year-old tissue.
Okay.
And the same, so this is going to be for DMEC. So the rest of it, this we don't want to waste it, so that's why we're using it for DALK.
How do you know which side it's up?
The stamp is there.
stamp.
You looking at the way it's curling,
Yeah.
it is stamped from the stromal side. So from the endothelial side, when you view it, it will be this one. You keep it. I'll use it. So when you punch it from the endothelial side, the F should look reverse.
Okay.
F, yes, got F, FOGLA for the. It should
Dr.
not be-
Sujatha, do
F
we
is
have a
for fun.
DMEC presentation today?
We don't have a presentation, but
Okay,
I'm
you
sure
could-
Rajesh, if he has got his computers,
That's okay.
if we have time, we'll make it.
So that your DMEC
Okay,
graft is
fantastic.
ready. Do you have a?
Okay.
I saw this, someone
What
was.
is the original size and how much is
9.5
Now
and
you
now
take
7.75.
Okay.
So that's fine. You have a cartridge
Amazing DMEC
onto which I
tissue, sir.
No,
can.
no, wait, not yet done. Is this,
DMEC injector do we have?
no, he has got that, usually the IOL injector,
Ah.
what Samar Pasakama use for. Naam என்ன யூஸ் பண்றோம் அதே தான் same thing, that's what I do.
Hey, I'll load it quickly here. Or if you want, we can keep it, restain it.
We just keep it like that,
Huh.
and then we'll start with the DALK, finish
Sure,
with DALK.
sure. Anyway, I just have to suture the DALK graft, so there's
That's
nothing.
all,
Yeah, so you can, if you want, yeah, you can go.
Wait, no, let him keep the graft on.
Yeah, that's
Sure.
all. Why the suturing only?
Because the patient, the block should not wear off while suturing, that's why.
It won't wear off, don't worry. No, here there's a hole, no? So it will go. Can you have a glass bowl or anything, any fluid, this thing where I can keep the tissue? This one? Saline? But nothing in it, yeah. Remove everything. Keep it separate. Fine. Don't put anything in that, otherwise.
Just close it and keep.
Close for
So, microscope please. This microscope.
Yeah, it's not. This one. Oh, it's. I need to turn little.
Wait.
Huh.
No.
Oh, it's gone completely. Huh?
This side.
Okay, fine, no problem. I'll shift my chair a little bit like that. Fine, tissue. Saline. Saline, this is air.
So the perforation is close to the area of 12 o'clock, no?
Yeah, so I will not put the
Yeah,
first suture there.
yeah.
I'll put the sutures like
Yeah.
this. So that-
Okay. So
many sutures you put?
16.
16.
So you would do interrupted everything, or you do a combination of interrupted with continuous?
Depends. I can do a combination of both work equally well, but if you put a combination of interrupted and continuous, you can manipulate the continuous suture at the end of surgery to try and get the round reflex. The only disadvantage of sometimes using the DMEC graft is that if it is DM is stripped and it's lying in solution for a long time, it can become a little swollen.
Okay.
So then you can try and once you punch your tissue, you can let it out in air itself to dehydrate so that it becomes thinner. The only disadvantage of dehydrating is sometimes the diameter may become smaller because it retracts. Then you will find that. Yeah.
Well, a second suture potom is very important. Okay.
Yeah.
Okay, then we'll switch
Maybe
over
at the end
to-
of surgery we can just.
Sure. Come back to you.
Sure.
Yes.
Thank you, Rajesh sir. Amazing, nice to see two actually grab the section of the DMEC tissue as well.
Okay.
Thank you, sir.
Okay, so we are going to the next case, pterygium to be done by Dr. Sanjeev SKR. I'm sure with and knowing SKR's surgical skills, it must genes cannot go wrong, like Mohan says. So we are just waiting to watch what Sanjeev does on the eye. So as much as I know how artistic SKR is, I'm sure he's also going to be even better.
Actually, we found it difficult to accommodate Sanjeev, not because of the lack of space, but lack of height in the operation theatre. We thought that because we were able to accommodate SKR, but he is taller than SKR, both physically as well as in profession. He is becoming a top class corneal surgeon. And over to Dr. Sanjeev, he is a debutant for us. And thank you very much. Looking forward to a longer association with you, Sanjeev. Pterygium with autograph. Sanjeev, all yours.
Thank you so much for that, this thing, sir, for the introduction. That just builds more pressure. But yeah, so I think today we're having a double pterygium. So I just marked before we started. So you've got to dry it up. So usually you look at the size of the double pterygium. You want to see how big it is, and you want to preserve as much conjunctiva as possible. I usually start my dissection from the side of where I've made the central mark, so that allows me to get a better sort of edge. You want to make sure your bed is as regular as possible in these cases, because you do not want to waste tissue because you don't have much of it anyways.
Sorry for the interruption.
Yes, sir.
For panelists, Nishant and other people, don't think that SKR is giving the dubbing. The same voice, the same modulation.
And the same pair of hands, the same pair of surgical hands also.
Absolutely. Really, give a big hand for Sanjeev. Fantastic. Great.
Hockey stick knife.
So you're going to do both the pterygiums, Sanjeev?
Yeah, but we'll do it one by one, because you want to know how much tissue you have after the first one. Because if you don't have, then you can always convert to a rotational autograft. But if you start dissecting both, then you will end up with no tissue, then it's hard. Then the next step is to go ahead and basically find the plane where the pterygial epithelial cells are. So this is it. So you can feel the knife sort of hitting, and then you can see the things folding over. So what this will then do is it will allow you to easily sort of peel off the pterygium from the surface. You can just sort of keep dissecting slowly back and back. And as you can see, it's now starting to come off.
What is that instrument you are holding?
Oh, this is a hockey stick knife, madam. It's the retina people know it very well. So yeah, the cornea people don't use it as much, but I love it. So you could use a crescent as well. You could use any sort of instrument you'd like, but this is probably, it gives you better control while dissecting.
Sanjeev, you
Yes, ma'am.
ever do an avulsion? Because sometimes when you do an avulsion, you get a very clean, smooth surface.
No, ma'am, because the reason being for that is that if you do that, and if you end up with these stromal fibers, they're very hard to clear, unless you have a diamond burr or something of that sort. The reason why also we do not do an avulsion is if the graft will tear. If you notice, I haven't actually cut the pterygial tissue. The reason is that I'm holding it like this, so that as I lift it up, it comes off like a tongue, and then I don't let go, so it won't retract under the conjunctival surface. Tissue, cotton bud, I'll show you. So in which case now I'm holding it like this. So I'm actually holding the conjunctival tissue. Then I can go in with a scissor and happily go in and sort of dissect out. The rest you can avulse. You can do something called a pterygial rhexis and all that. But yeah. And then you can pull and sort of, this will allow you to get as much tissue without having to have an assistant hold it up for you. You could use a rectus for this step as well, but this is probably the easier one.
Avulsion from the head is easier or from the neck?
Once I cut, I avulse.
Ah,
So
yes.
it goes from the base
To
towards,
the head.
Then you
Yeah.
get a nice smooth, clean, at least the epithelium, no? The closer to the pupil, it becomes very clean. Then the areas where there are a lot of stromal fibers and stromal incursion, then you can probably use a diamond burr.
You can use avulse the pterygium without cutting the conjunctiva. It's actually easier.
Maybe he has more adhesions there, ma'am. That's why he couldn't avulse it further.
Because if you avulse it from the conjunctival side, then you won't be able to get the tissue underneath. It will go back. It will retract the moment you cut it. Then you will be searching for it underneath and injure the rectus most likely.
You use a diamond burr or?
Ideally yes, but it's not available. So basically we can just go ahead and just use the hockey stick to.
Diamond dusted.
Yeah, the diamond dusted burr.
You
want that?
If it's available, yes sir.
Yeah.
It will be perfect. It will make this very easy to.
Burr.
But if you do this, it will pull. If you just peel off basically. You really don't have to bother too much about it. It's only for the initial dissection that you need the hockey stick. The rest is quite easy. The rest next is you debride the limbus. You want to take off all the dysplastic cells and then basic cautery.
Question apart from this, is this patient waiting for cataract surgery, Dr. Sujatha?
I think so. After a month we'll do.
Cotton.
I don't think
Cotton,
so. It
cotton.
doesn't.
Really?
No, I'm sorry, I don't.
Cotton.
Doctor, everybody is here. Aarti.
Cautery use பண்ணாம?
What is the age of the patient? Aarti.
There is case to 61. Age of the patient is 61.
For cataract. So there is an opening in the conjunctiva also, no?
Which one, sir?
No, you've gone underneath, no?
Yes, sir. We've taken off all the subconjunctival tissue and the degenerative. This is basically biosclera which we got.
So minimum cautery is the idea in pterygium surgery. You do not make it into an avascular bed, which
But
is
you would want to burn the limbus definitely though, because this is it. Perfect. Yeah, this is fine. This is fine. I think we've got the burr. So basically this part you just go ahead and rub over this area and smoothen it out. Saline.
Beautiful.
is that normal speed or is it fast?
I think it's a little slow, but yeah. So now you have basically a uniform cornea. So this then makes it quite okay. Caliper?
What was the amount of astigmatism did this patient have?
Let me check and come back, ma'am. What is the astigmatism the patient's got? Can you just check and tell me?
Now he's measuring the bed of the sclera for.
Can you be a little louder, the panelists, no?
Yes, sir, yes. So
Yes, Meena.
what I was saying is he is measuring the bed of the
Sclera, yeah.
sclera with the help of a calipers, correct?
Correct,
Dr.
ma'am,
Sanjay?
correct, ma'am.
So
the-
you're going ahead with
the first graph, correct. I want to see how much
pterygium
tissue.
excision and grafting. What we normally see is when both the sides are removed and then the harvest is done. You're showing us something different.
No, because if you did that, and for example, you had a bigger graft on one side,
Yes.
and if you're left with no tissue, then you'll be stuck because you won't be able to make your, you shouldn't actually be harvesting too much tissue as well. So then in that case, you can actually do a rotational autograft for the other pterygium instead of having to do a conjunctival autograft. Cautery.
The site of harvesting is superior or superior-temporal.
This is a little superior-temporal, ma'am. Cotton bud.
To get a thin graft, are you planning to inject some saline in subconjunctivally? Are you going to go
I'll
ahead?
show you that.
Yeah.
Yeah. So basically, I do not inject saline and whatnot. The reason being that if you by mistake inject it into the wrong plane,
It
and
goes subtapered.
Yeah, and then you'll have a very thick sort of graft. So
The reason I'm saying this is there are many surgeons who actually advocate injecting saline,
Mhm.
but I don't think that's also wrong. But
It's not wrong. It's not wrong.
But
It's
just
absolutely
showing
not
you-
wrong.
Just telling that this is also another technique.
No, absolutely. But the thing is that if it goes, like you said, if it goes into the tenon space, then you basically end up with a sort of a very thick graft, which is not cosmetically very appealing.
So one of the clue here is seeing the blade of the knife very clearly. When you're very thin, you know
Yeah.
that the blade is very clearly visible. You know that
Yeah.
you are absolutely below the conjunctiva. Maybe a few fibers, you can't actually avoid
Get
the
over,
few
yeah.
fibers, but
patient
as
here.
thin as possible.
Sanjeev, I found that you didn't measure the graft. Did you measure?
Oh, I did, sir. Yeah.
Huh? Okay.
Yeah. You definitely do it.
Slightly bigger than the whatever you want.
Yes, sir. And sometimes I actually use a trypan blue on the area so that we know exactly the point of cut. And I think it's little safer to use a non-tooth forceps for the graft so that we don't like puncture the graft.
You can use either because it really doesn't matter.
The problem with the non-tooth forceps, it will keep slipping. So you use a tooth forceps gently, I think.
I usually prefer to inject little bit of xylocaine.
Madam, little louder, madam. Vasanta, madam.
Can you hear me now?
Yes, ma'am.
I used to inject little bit of xylocaine under the conjunctiva.
Yeah, that's what.
Yeah, ma'am. That's the thing. So the other way to do it, what I did was basically use the cautery, because the cautery will never burn tenons. So if you use the cautery, you will get the site of entry for your dissection, and then after that it makes it cotton bud. It makes it easy for you to find the plane.
With the cautery you make an entry, is it?
Not an entry, it's just a single burn.
Single burn, okay.
And that single burn will basically be the point where you can cut and then you. So basically now you see tenons here. There's no conjunctiva left. So you basically got a clean graft. This means.
So you have harvested a conjunctival graft and not a conjunctival limbal graft.
Not a limbal graft. Yes, you
So
can't.
you leave the limbus.
You can't do it for a biheaded pterygium.
For a primary pterygium, we do not actually advocate a limbal autograft, but just generally a conjunctival autograft.
Yeah.
So where the bed is very dry like this, he's placing the thick part of the fibrin glue.
Which one? That's okay. This is, anyway, the glue will stop it. It's on the edge.
Can we have little more focus, sir?
Oh, sure. This fine?
Yeah, focus down.
McPherson?
Yeah, that's fine.
They're not able to. Yeah. One second.
So now he slides the graft into the place for the glue. Perfect.
McPherson?
How do you make sure that which is on top, which is on bottom? Yeah.
We took, yes, we didn't let the grafts flip. So basically, you make sure that it's.
No, it's fine.
Apologize for the blood though.
Yeah, no problem. People just use the blood to fix the graft. Autologous.
Autologous serum, yeah. You can do that, so you can do that as well, but it's. The rate of detachment is a lot higher. The graft takes a little longer to clear up.
Oh.
So it's already stuck.
The blue is better.
Blue is ideal, sir. No, you can use sutures, of course.
So when you use sutures, absorbable
just
sutures
flattening
like 80 vicryl can be used.
Yes.
And if you use 10-0 nylon, make sure you leave the ends long.
Correct.
So that they lie abutting the conjunctiva and do not trim the ends of the 10-0 nylon. So it's not like you cannot do pterygium surgery without glue. You can use 80 nylon, 80 vicryl or 10-0 nylon.
Because there are two sides, no sir? There are two pterygia. It's biheaded.
So the second one also will take.
No, because if you take limbus, then one graft will have limbus, one graft will not. So it's. Yeah.
Do you keep a sponge or something for the cornea not to dry up?
You can keep a sponge, you can keep you can put visco there as well if you'd like. This is the line. You want to? I can finish up. Not too.
Okay.
Yeah, sure.
What do you say?
You want to finish it off? It takes 5 minutes. We'll do it faster without the talking.
Finished up. He's doing the other one also.
Thank you, sir. Is it the same technique, Sanjeev?
It's pretty much the same, sir, nothing different, but this one doesn't have any fibrovascular tissue, as you can see here. It's quite okay. So this one will be relatively easier, I suppose.
So this also you put a graft?
Which one, sir? Yes, definitely, sir.
Site will be adjoining the previous
Graft, yes, sir. Because the grafts are split vertically, so you just basically use either side to harvest.
The area is very large. You take the inferior graft as well?
No, sir. In that case, you have to do what's called a rotational autograft. You have to sort of spare the tissue here, rotate it 360, and then use that to cover up the area. The problem with the rotational autograft is it won't be cosmetically appealing. It will not be great, but it will spare you the time of having to go after tissue everywhere, superior, inferior.
You should not forget to look at the fellow eye.
Absolutely.
The fellow eye is normally you can use the graft.
Graft from there as well.
Okay.
Yes.
Why didn't you take the inferior graft?
Because it's very cumbersome to do that, to go after it from, it's not particularly ergonomic to try and harvest an inferior graft. And second thing is, it's not needed. Most of the time you will have enough tissue. Conjunctiva is quite big, so.
Yeah. Inferior graft
Diamond.
I take in eyes which
Scissor?
are prone to glaucoma or the glaucoma just exactly take from.
Okay.
So you don't want to discuss the inferior graft.
Good idea.
Diamond bar?
Sometimes most of the time people forget to take a look at the
Is
fellow eye.
Rajesh, is he audible?
Diamond bar.
Whatever Rajesh is telling, is it audible? There?
No, Doctor.
Rajesh is telling that inferior graft you will take for patients who require glaucoma surgery later.
Yes, sir.
Yeah.
So in what I do is for all primary pterygiums I take only inferior graft because I do not know in future which of these patients will need glaucoma surgery.
Anything special technique you use, Meena, or the same?
The same, sir. You can take a medium-sized graft from the inferior conjunctiva, and cosmetically, and doing cataract surgery in them is also better, sir. Otherwise, you will have a scar in the superior part. So I now routinely for the last 8 years, I am only doing inferior grafting.
Okay. Sanjeev, I just want to ask you a question. Now, you're going to take another graft from the superior.
Correct, sir.
Okay.
Correct.
And you're going to leave that, it's going to be a bare sclera there, no?
No, sir. There's tenon underneath. You've taken only the conjunctiva. So the conjunctiva will grow back. Either ways, we will still close that area.
How do you close?
With glue, sir.
With glue, okay.
Just
stretch the...
Dr. Mohan,
Yes,
can you hear me?
Yes, ma'am.
Dr. Danda once said conjunctiva is a shameless tissue. It will grow however much you cut.
Ah.
That doesn't mean you leave it open all
Yes,
the time.
also I think it's very stretchable.
Yes.
It's very loose and stretchable.
Actually, it's important that we cover the bare area, whatever we
Yeah,
do,
yeah.
pull it forward and cover.
Otherwise, your patient will end up with irritation, number one. Most importantly, they'll end up with a Tenon's granuloma.
Tenon's granuloma.
Yeah, which is quite hard to treat, and then you'll have to bring them back to the OT to dissect again.
Just for theoretically, I mean, for sometimes large double pterygiums, do you prefer AMT, half AMT and half graft?
If it's a pseudo-pterygium, yes. If it's like post-chemical burns, yes, it's worthwhile. It's worth doing a AMT.
One of our PGs did a thesis with...
Little louder, madam.
One of our PGs did a thesis on this pterygium with conjunctival autograft and amniotic membrane graft. And there is a slight advantage
Okay.
when we use amniotic membrane.
Yeah, we'll come back here. We'll come back to Sanjeev. But let's give a big round of applause to Sanjeev for a wonderful demonstration. Pterygium is not an easy surgery, and he has shown it how beautifully.
Great life surgery, Sanjeev.
Fantastic.
Thank you.
And over to Rajesh Kokla again. He's completed the DALC.
So he has put 12 interrupted and 12, am I right? 12 16 8 interrupted and 16 continuous. You have to see the graft, it looks fabulous. Can you show the, we have the astigmatic keratotomy keratometer. So he is going to show you how beautiful the graft looks. How minimal, with very minimal astigmatism. Saline ponno.
No, it's okay.
I don't know whether you're able to see the ring. Yes, yes. Very nice.
Yes.
Beautiful.
I think it's a faster suturing.
Excellent. So we're going to leave behind us maybe half the
Thank you for
anterior chamber
the
with air
textbook
bubble.
suturing, sir. Thank you, Rajesh Fogla, sir.
Thank you.
Amazing.
Thank you.
And I think for every corneal surgeon to see a clear DM after the dark is actually one of sight to see.
So
Thank
he
you,
has
sir.
removed about half the air bubble. We're going to keep a little bit just to dampen out the break in the superior portion. Otherwise, the graft looks fabulous.
Antibiotic drops.
So we'll
dilating
move on
factor.
to the final portion of Sanjeev's surgery.
Yeah.
Done.
We'll show Sanjeev's, we are alternating between Rajesh and Sanjeev, and the two top corneal surgeons here, and you can see the graft. Yeah.
Most welcome. I will.
Even for the temporal, temporal one,
you want me to roll?
temporal pterygium, he has put the graft, and he's just
You want
putting
to
the glue for
viscon,
the conjunctiva, the area of the autograft.
You want something else?
No, just some antibiotic drops.
Antibiotic.
Yes.
He's just waiting.
Yeah. Friends, let us put our hands together for Dr. Rajesh Fogla for the wonderful demonstration. But stay back, because he's going to come back with the DMEC now, very soon. DMEC surgery, and one more round of applause to Dr. Sanjeev. Okay. Yeah. Yes, ma'am.
Sir, if it is done on the other head, can we go to the next theatre?
Yeah. Next. Wait.
Paucity of time, already 12:30.
Yeah. Ravishankar, we are doing that. Don't worry.
Thank you.
Vardhaman's ready, yeah? Rajesh, just thanks a lot. Wait. Sanjeev, just wait for some time. Very good, very well done. We are going to start the RIL by Dr. Vardhaman, followed by case by Preeti Naveen, and then all will show only about 5 minutes of the surgeries. RIL, Amma. Pratibha, RIL.
We need the RIL camera, sir. RIL theatre camera, please.
RIL patient, sir.
No power, na?
Minus in 4.5, lens age 37.
So the next case is we have a RIL lens. The patient's age is 37 years and his power is minus 7.75 with 4.75 cylinder at 10-degree axis. So I think there's going to be a toric RIL, madam.
His sphere is 8.5 and preoperative cylinder is 4.5. And we are going to place this lens at 0 and 80 degrees. So the placement will be the same, but the lens itself contains at 4.5 at 10 degrees. So Dr. Vardhaman Kankaria from Pune is going to do this. He is a very famous refractive surgeon. From his hospital is known as Asian Eye Hospital, am I right?
Asian Eye Hospital.
Yeah, okay, right. And he has the unique distinction of being trained by one of the top people, Palikaris himself, in refractive surgery. So he's a big person to be to reckon with. Though he looks very humble, he knows a lot. He has a lot of publications. He's really fantastic. Let's watch him now.
Welcome, Dr. Vardhaman.
Next இதுதான் DMEC. ஆமா.
Ma'am, we are not able to see the operating microscope.
Thank you, Dr. Sujatha ma'am and Dr. Rajan sir, for the kind invitation and all the hospitality. It is always a pleasure to come back to surgical strike. And Chennai is always special. It is like a home ground because I was trained in Chennai at Shankar Nethralaya and all my teachers and friends are from here. I have also spent some time with Dr. SKR sir. So always a pleasure to come back to Chennai. So what we are going to do here is a phakic intraocular lens implant. This is RIL by Appasamy. I think phakic implants have actually gathered a lot of acceptance over the years.
It's called refractive implantable lens, no?
This is called as RIL, which is the refractive implantable lens. As you know now, there are a variety of options which are available for the phakic lenses today. But when it comes to affordable, easy to implant solution, definitely RIL is one of the preferred choices. Usually you would choose a phakic implant when the corneal lasers are not possible. For example, if your ametropia is beyond the treatable range of laser, which is beyond -8 or -9 diopters, or if your cornea is not up to the mark because of either having very thin cornea, keratoconus suspect, or in patients who have a very significant dry eye profile. So in these cases, we always choose phakic lenses. So I'm going to say temporally, this lens has what is called as a smart toric profile. So that does mean that we are not supposed to rotate this lens. We are going to implant it at 0 and 80 degrees. And with the help of Callisto, we will be able to do it. 63 is my opinion, yeah. 0, yeah.
Hi Vardhaman, Nishant here. Welcome.
Hi Nishant.
Yeah, so that, as you said, one of the main advantages placing it at 0, 180.
Nishant, I want to say a few words about Dr. Vardhaman Kankaria.
Yes, sir.
He is one of the most dynamic young ophthalmologists of the country. And he is going to be is already the future, and he is going to actually go places. Asian Eye Hospital is one of the top eye hospitals in the entire Maharashtra. And his father Prakash Kankaria is also very, very close friend of ours. And Vardhaman is probably the 4th time he is coming here for the surgical strikes.
Yes.
Yeah. Thank you, Vardhaman.
I have visited almost every time, sir. Thank you for your kind invitation. So friends, I am going to do what I call as the angle incisions.
So can we have the microscope?
So are you getting the microscope view, Nishant?
Not yet.
Okay. Can we please get the microscope view?
Wait, 1 minute.
Yeah. Can I get the retro illumination? Can I get the retro profile, please?
Retro, you can just...
Yeah, super. Now I think under retro you can probably see it much better.
Okay, Vardhaman.
Yeah, I think you can start. We are able to...
You can see it?
Yeah.
Is it seen there? Nishant?
Sure, super.
Now it has gone, sir. We are focusing it on the computer which is there. We are not getting it through. Yes, sir, we are able to see.
Now it's seen, no?
Yes, now it is seen. But the fine focus, Vardhaman, can you just have a...
Fine focus?
Fine focus, okay.
You tell me where it is focused for you. Is that okay?
A little more. Little more. Yeah, I think perfect.
Okay.
Thank you. You can start.
Alright, so we'll be starting the procedure now. So I'm going to start with what is called as angled incisions. So basically this is what I prefer. I go slightly towards the angles. That makes it easy for me to tuck the lenses in. This is the first side port that I have created. Now I'm going to create the second side port. This will be also slightly towards the angles.
Okay, Vardhaman, I just want to ask you one question. Some of the surgeons put the right side port all the way down. Do you do that?
So I go slightly down, sir. So I do it still angled, but I'm not going all the way down.
No, what I'm trying to,
I tilt it, I angulate my incisions slightly towards...
What I do is, Vardhaman, I put it closer to the haptic.
Yeah.
It is up, right up.
No, not I have done. Wherever he is sitting is up, no.
Okay, if then.
Down.
Okay. All right.
So I am
down.
using the Ocalan now. So basically that's it just for, okay, we are using Visco already. Take. I usually prefer to use Ocalan. So we are going to create a 2.8 incisions as against the other forms of phakic lenses where a 3.2 is required. Can I get the Callisto overlay, please?
Patient is blocked or is it under
No, it's under topical anesthesia.
Topical, yeah.
So,
yes.
So we are going to create an incision at 0,180. Yeah, we can take it off the Callisto. So it is important that you don't overload your anterior chamber with the viscoelastics. You should still see some streaks of visco so that whenever you are actually implanting the lens, you don't have any counter pressure. Yeah, I'll load the lens. So now I'm going to show you how the lens is loaded. This actually one of the advantages of the RIL is that the loading is very easy. So for especially beginning phakic IOL surgeons, maybe this is one of the good lenses that you can begin with, because loading is similar to a cataract IOL. So your intraocular lens.
What is the thickness of this lens, Rajma?
So basically, so thickness is going to change according to your refractive error actually, but what is constant is the diameter of the hole. So that is 340 micron in this case. And there are two more holes. One of them is the orientation hole. So these two holes are close to 500 microns. So.
No, the reason why I asked the question is this: these hydrophilic lenses like this RIL and the IPCL.
Yeah.
Are they thicker than the ICLs?
Yeah, they are slightly thicker, sir. Yeah.
Does it have any disadvantage?
So they are definitely slightly thicker than the ICLs.
Yeah.
Which is both advantage and disadvantage because your maneuvering becomes easier.
Over a period of time, these lenses become a little bit thicker.
Yeah.
Like 0.1 micron.
Vardhaman, you have
Over a
folded
period
the
of
lens inward or outward? I
So-
saw you tucking in and.
Yeah, so basically the lenses are folded in such a way that the haptics go down and the optic is actually upwards. It's like a U shape. And now I'm going to get this into the injector system.
Why is it come main?
Huh? The injector is showing, no?
So
The regular injector, is it? Yes, regular injector.
1 second. Yeah, we'll have to wait. This is, okay. Just remove it again. Excuse me, boss. Yeah. Just open it again. Give me another. Open it again. Just load it and give it to me. So till that time we'll probably discuss about the lens. So this surgery has been around for a very long time. Actually the phakic lenses have been around for almost 30 years now. And especially about the other more affordable lenses, they have been also around for last 6 to 7 years. I've had opportunity to use almost every kind of phakic lenses, including the Star ICL, RIL, and the other two lenses which are in the affordable range. I've been fairly happy with all of them, but when it comes to the affordable range of phakic lenses, RIL has been one of my top choices. The turnaround time is also pretty good compared to the other ones. So typically they would get you a lens within the next 3 to 4 days time, and some manufacturers actually take longer time than that as well. The surgery is easy to master because for anybody who is doing cataracts for a long time, it is very easy for them to actually get around and start doing phakic lenses.
The only thing is you have to be conscious of the fact that you should not touch the anterior capsule.
Absolutely, sir. As you said, it is very crucial that all your movements have to be parallel to the iris. You should always keep in mind that you have a phakic lens inside. And once you have that in mind, it becomes very easy for you to actually get around it. So we are going to go to the eye now, now that the lens is loaded. So this is a very easy to inject kind of system. As you can see, you have taken it to the tip, is it?
No, I'm not taking it.
It was at the tip. Just load it again, yeah. Look straight. Nere parango. So for the phakic lenses, this is the only system that they come with for the RIL. It was at the tip side.
No problem.
Just keep it there only, yeah. So the range that it treats is about from -1 to -24 diopters, and you can also customize it. It can also treat up to +1 to +10 diopters on hyperopic side, but you have to make sure that if you are planning a hyperopic side RIL, then you have to have at least 3 millimeters of anterior chamber depth. As against that, if you are actually planning a myopic side of RIL, you can still get away with a 2.8 millimeter. The one that will have the central hole will always be the myopic. The hyperopic will typically not have the central hole because your refractive basically correction is going to happen in the as far as the convexity of the lens is concerned with the hyperopic lenses. When it comes to astigmatism, you can treat up to 6 diopters currently, and this patient has 8.5 with 4.5 diopters of astigmatism, 8.5 diopters of myopia.
What is the issue with the loading there?
No, basically the injector, which was the sponge plunger, was slightly defective, so we are just reloading it. That's okay. Is it at the tip? Yeah, I'll see it. Yeah.
It's okay now?
Yeah, take it. Yeah. So we will be injecting the lens now. As you can see, the lens is going to be injected through a 2.8 millimeter incision. You have to be always aware that you have a crystalline lens.
Going inside, it's not a wound assisted, no?
So, no, it is almost like a wound assisted.
Okay.
And now the lens is okay. Okay, no problem. Can I have the visco? So the lens is now implanted in the anterior chamber. These two things that you see, which are like slits, are the locations for your astigmatic corrections, so that you have to align at 0 and 180 degrees. Can I have the Callisto, please? Yeah.
Okay.
Yeah.
Ready for it.
So now I'm going ahead. First I'm going to tuck in the distal ones. So this is tucked in completely. And now I'm going to go and I'm going to tuck in the trailing ones.
You made it look so simple, Vardhaman. Amazing, amazing tucking in.
So now as you see on the Callisto, it is now well aligned. It's, yeah. Keep this please.
Okay, that's fine.
So, yes. I'm going to very gently, slightly rotate this lens very slightly on this side.
Can we inject this lens under irrigation?
Sir, hydroimplantation is possible. So basically, especially if you have a spherical lens and especially with the other forms of ICL, which are thinner, I have done hydroimplantations also. But of course, for hydroimplantation, I think you have to be reasonably experienced because for hydroimplantation, your movement has to be very crisp. You have to be away from the endothelium all the time. I usually use the bimanual irrigation aspiration. Can I have? Yeah.
Yeah, that's fine, no?
So, yes, good.
Can we switch over?
So, yes, sir, absolutely. So, I'm going to remove this viscoelastic. It is very crucial to remove entirety because you should not have any viscoelastic trap behind. Yeah. One of the advantages of having a central hole is that you can actually have the viscoelastic escaping very easily. And also the halos are actually pretty less with the 340 microns of this size of the central hole.
The hyalon is what do you use or what?
So, sir, I use usually HPMC, but there has been also studies where they have used a cohesive viscoelastic because
comes out very fast, no?
Comes out very fast, but you should always avoid the dispersive viscoelastic. So that is very crucial.
Viscode you should.
Viscode you should avoid, yeah. Perfect. Okay, so I think after that we are going to just close the incisions.
Beautiful. I think it's a beautiful demonstration.
Thank you.
And I think Vardhaman's demonstration very good, but I think we have to give full marks to Appasamy Associates.
Yes.
For bringing this technology and the quality technology for us at very affordable prices, and is really hats off to you, and everything is available. You take it, the multifocal toric, the external EDOF lenses and the RAL lenses, everything is available at Appasamy. The machines are available. There is a 360-degree coverage. Over to Rajesh Fogla. A big round of applause to Vardhaman, please.
Thank you.
I want a bigger noise.
Thank you, sir.
Rajesh Fogla for the DMEC. From DALC to DMEC, he has come now.
Okay, this patient had a failed DMEC, and so we have already stripped the Descemet's membrane, and we are waiting for Dr. Rajesh to load this. He has already stripped it from the donor, as you saw it previously, and now he is going to load it into the cartridge. What we are using here is just an IOL cartridge for injecting.
No,
so that's what he is going to use.
It's better to avoid.
There are of course special cartridges available. Now he has loaded it.
You want a
and
viscoelastic.
the most important thing is
Yeah, come out.
you can talk.
Well done, Vardhaman.
Yes, thank you, sir. Thank you very much.
Yeah, give her no. In the no.
Sujatha? Dr. Sujatha, can you hear me?
Yes, ma'am.
I don't do this refractive lens implantation, but I just have a doubt. When you are injecting, why not inject the 6 o'clock portion of the haptic directly under the iris? What will happen?
It won't come, madam. It won't come. If you inject, it's very thin. The haptics are very thin. So you will have to. Except this biotech lenses, all of them are very thin haptics. 1 minute.
Vardhaman, switch on.
Keep watching.
Is Vardhaman audible there, ma'am?
No, sir.
I keep one syringe with saline and air.
Hello.
We are able to hear.
Hi, Nishant. Am I audible now?
Yes, Vardhaman.
Yeah. So I think it was a very pertinent question. So I think one of the other reason that we don't actually implant it, because you can touch the lens also. So it is better to be always parallel to the iris. Yeah. Thanks. Sure. Thank you.
Okay. Thank you very much, Vardhaman, and we go on to.
Thank you.
Rajesh again.
Tooth forceps.
Microscope view, please. Microscope view, okay. Yes.
Irrigate, sister.
So just keep irrigating so that, yeah.
So Dr. Fogla has already stripped the Descemet's membrane.
Saline.
Irrigate.
No, the incision is already big. He's looking up. No, not soft. He's looking up all the time. Could you keep it?
Clear Good. So now the tissue has been injected.
Suturing.
As you can see.
Tying, normal ties. Yeah, if she's not familiar, then no. Irrigate, sister. Give me the saline. Yeah.
Okay, you can talk.
Yeah, so now we have got the graft into the eye. So the chamber is very shallow, so we are just going to deepen the chamber to allow the graft to...
Dr. Rajesh, are you able to hear? Hello?
Yes, madam, we are able to hear, Rajesh sir. We are able to see the scroll being unrolled.
Yeah, so I'm just trying to center it. The graft seems to be already in the right orientation. And this sometimes, even if you are not able to see the F, by looking at the edges, you can see that the edges are curling towards me. I'm going to just shallow the chamber a bit, center the graft a bit further.
So the maneuverability is more easier with the shallow.
Yeah, but if you see the F, I think it's looking reverse, right?
Yes.
Yeah, so we'll have to flip the graft. So you can do that, and flipping the graft, you can just
Is there any way of making sure when we inject, we are injecting in the right way? So
no, you have to make sure that your chamber is not very tight, because if it's already full, you cannot inject more fluid. And you can see, and you make sure that it's not attached anywhere, and then you direct your fluid towards the iris. You see that?
Yeah.
And once you have done that, then you can shallow the chamber so that it doesn't really go back again into the same configuration.
Okay, fantastic.
Sister, irrigate the cornea. There is blood on the cornea.
There is a very nice video by Dr. Peter Wellman, which shows how to unfold the different types of DMEC. Beautiful. So this, what is this technique called, Rajesh? You hold it and just tap.
No, that's the Dirisamer technique. So once you have done this, you can fixate here and you can tap on this to open up the graft. Again, tapping in the periphery to center the graft. So, and now here you can see that the superior part which is there, you can tap in the periphery, or you can get. We can put air itself, no problem.
It's great.
So once it's done, it's fairly central, covering the pupillary area. And just give me saline first. So before you put in your air cannula inside, just make sure that you put a little bit of fluid to push the iris back. And then go with your cannula into the eye, but go below the, and put an air bubble. And you can see your F stamp there. You see that?
Yes, yes, yes.
So it's in the right orientation.
Can you put the F stamp there?
Yes, it's quite.
Yeah, irrigate the cornea, sister.
Dr. Rajesh, you didn't mark on the epithelial side, you were able to...
Yeah, I didn't remove the epithelium on the patient, but centration is fairly, from the limbus if you see, is equidistant, and it's also well centered over the pupil. So, and you can see the F stamp, so that tells you that it's the right orientation, and I think that's good enough.
You don't overfill.
We will fill, but right now I'm allowing time for the aqueous to seep out. Otherwise what happens is, you have aqueous in the anterior chamber, you cannot do a fill. So now what is happening, you see the air bubble itself is expanding. That's because the aqueous is seeping out. And your original suture that you place is also a little tight. So that causes dimpling of the cornea. So what I'm going to do is, I'm going to revise this suture. So I'm just going to cut this suture and then reapply the tying. So thereby I don't have to make another pass with my needle. So I'm just going to fill the chamber. Irrigate. And now you can tie it with the right tension rather than because if it is more tight, then it tends to cause the dimpling of the cornea at that point. Induces
Initially you make it tight so that you can flatten the anterior.
That's in a soft eye. Anyway, the suture will be a little tight.
Yeah, okay.
Dr. Rajesh, one question. When you post a case for lamellar keratoplasty and endothelial keratoplasty, which one will you do first and how do you actually perform in your theatre?
You can do whichever. You can do the DMEC first and keep the tissue and come back and do the DALK later. I usually, if it is not scheduled on the same day, I put the tissue in a fresh bottle of cortisol and I can use it within 24 to 48 hours.
And when you take it out, you stain again?
No, for DALK you don't need. No? For DMEC I'm saying, yeah.
So DMEC grafts you can't keep it because there are a lot of eye banks which are willing to...
Yeah, but then we have tried putting it into an injector and then keeping it.
It doesn't work, is it?
No, it works, but then you don't know about the viability of the cells, and unlike a DALK where you have the host endothelium that's healthy.
Fantastic.
Here, if you're not sure, then contact lens you want to put, or you want to put contact lens you want to put, or fine? Okay. Okay. Sure.
Drops patch.
So what is that side port suture that we are seeing there, Dr. Fogler?
What is that?
There is one other side port suture that was
Yeah,
done now.
that was the previous surgery done by Dr. Sujatha. So that's it, first incision.
Okay.
That's the suture over there.
I did a temporal incision, so he went superior. Rob's patch now. Yes. Next patient here.
Thank you, Rajesh sir.
Thank you.
Wonderful, wonderful sir.
Thank you, sister. Thanks.
I should thank Dr. Rajesh Fogla for coming all the way from Hyderabad and demonstrating two fantastic surgeries. He's he's a master of lamellar surgery. I'm really honored to have him here.
Thank you, Sujatha. Thank you for the kind invitation.
Sujatha madam, what is the next case, madam? MR sir?
Sir, on the blue sheet. Mic is not on.
Welcome Dr. Preeti Naveen, we are able to see you, you are very audible, over to you.
Am I audible?
Yes,
Very
Dr.
much
Preeti.
audible.
Thank you, thank you. So we're going to be doing a CARES today, and it's a 16-year-old patient, and his uncorrected visual acuity is 612, and best corrected with plus 1.5 spherical and minus 5 cylinder at 140 is improving to 66 parts. And CARES, as you all know, is an acronym for corneal allogenic intrastromal ring segments, and it's been around since 2015. It's a brainchild of Dr. Susan Jacob, my mentor, and thanks for the opportunity to be performing the live surgery today. And so we'll be passing a femto pocket here to insert the CARES segment inside. So the CARES segment which we have taken now is we're using a tunnel width of around 4.6 and a 7.2 diameter here, and which is standardized in most of our cases. And we have trifines of different sizes, and we have the 6.5 and 8, which is which gives us a tissue of around 0.75, and we'll be using that trifine today because the cylinder is a little on the higher side, minus 5. Use 2 incisions. And
Thank you, Dr. Preeti. Can we have the topography because someone was standing there? Okay, yeah, thank you. Okay, so you're planning one segment.
Yes, Nishant. We're planning one segment, and it's an inferotemporal decentered cone. So we'll be
Okay,
planning
yeah,
a
we can see
single.
the diagram as
we'll be
well.
planning a single segment there.
Okay.
And so I'll be using a 210 incision superiorly for me. So I'll be using my left to push it in. And so basically with CARES, what happens is we'll have to plan according to the steep area. So if you're able to see there, so we plan to cover the entire steep portion of the cornea there.
Okay.
And depending on that, we mark our clock hours of the segment which we plan to put it in. So we have a specialized customized marker for this, just to mark the clock hours, so that it's much easier for us, so that we don't have to, once you push the segment inside, you don't have to. Yes, ma'am. So I think they're going to start the laser part, Nishant. So once it's done, while I'm doing it, we'll just talk.
Sure. Yes, we can see Dr. Sujatha Mohan, madam.
Okay, நேரே பார்த்துக்கோமா. Normally I would like to mark the center. So mark பண்றதுக்கு இருக்கா? Pen இருக்கா? Marking pen இருக்கா? கிழிச்சு கொடு. இவ்வளவு பெருசு இது கொடு. So this is just gives us an approximate idea about the center once you have done the applanation. So on.
Okay, ma'am. Insert position. Section on, ma'am.
Section on பண்ணிட்டியா?
On, ma'am.
Insert பண்ணி செக்ஷன் ஆனுங்கற ஓகே கீழ இருக்கு. Now we are centering it to கீழ. You see the center இந்த பக்கமா இருக்கு. கீழ வரணும். அதே நான் கேட்டேன்ல. ஓகே. கரெக்ட். சரி. Okay, shall we start? Okay. நேரா பாருங்க. So what you need to do is we have to make an incision on this side. Preeti, you have to make an incision with a knife on this side, so that you can insert from there. You have to start inserting from there and come here. Yeah, that's what. It's not down, it's like this. Yeah. You're putting only inferior, no? That's perfect. If you want, you can make one more incision on this side. Okay, now we'll take a. Everything is perfect.
Have you made the pocket full 360 degrees, ma'am?
No, we have made at what angle we have made? 270, yeah? 210 degrees we have made, Nishant.
Okay,
so now
ma'am.
she has to insert it through the 210 degrees because she's going to put only an inferior case. The superior portion she's not doing anything because this is a decentered cone, no? So she just wants to, just like putting single intacs, she's going to do like that.
Sure.
So if she finds it difficult to manipulate, you can open it with a side port knife from the other side. But I think she can manage with this.
Sure. So basically the femto has done it fully, but what she is going to do is only inferior.
Absolutely, correct, you're right. Because that's how the design is, that's how it works.
Dr. Preeti, what instrument do you use to open up these channels?
So it's the same the pocket creator which we use for the intacts only, Nishant, to begin with. And then it's a Y rod which we have just bent according to the corneal curvature. It's now it's available as a cornea set from Epsilon. Care set from Epsilon if you ask for it. Increase the magnification, no?
No, it will be appropriate. Dr.
Preeti, you have already prepared the tissue, right?
I have prepared the tissue, Nishant.
Left hand or right hand? Yes.
One second.
Preeti, when did you actually prepare the tissue? And
I just did it 5 minutes back, ma'am, because we prefer not to do it earlier on, because if it gets too dehydrated, then it's tough for me to, it starts getting too brittle. And I don't know if they can see the segment. Are you able to see the?
So you have that patented one with Joja or something? You have a patented your own style of making this tissue, isn't it?
Yes, ma'am. So
center it a little bit. They're not able to see.
Are you able to see?
Can we have it a little more in the center and?
Yeah, 1 second. No.
And focus it.
Focus is not there, madam.
Yeah, 1 second.
Okay.
Is it better?
Yeah.
Yeah. இதான் நம்ம கட் பண்ணி வெச்சது. So when you prepare the tissue, we usually mount the eye on an artificial chamber, and we peel off the epithelium and the endothelium. We don't want any epithelial migration in there because of the segment. Konja saline poduma. I'm just putting a little saline onto the cornea. So this is a Y rod which is just bent according to the shape over here. So if it gets too, so I have two tissues prepared, so we just try to push it in, and you'll have to hold on to this because sometimes it gets too slimy, it just slips out. So the thicker side is the Bowman side which we're trying to push in. It's too slimy.
Sinski hook use put. It comes out very well with Sinski hook.
The other segment will come up.
Have you tried Sinski hook? It comes out very well with that.
I think it's too much, it's too moist.
Is it normally so thick, the care?
It got hydrated much, Preeti?
I think because of the saline here, ma'am. 1 second. Mop panuma enakku priya.
Yeah, the correct. What the previous one was correct. Now it's ulta.
This is too hydrated.
Just
You are
keep
going to use two tissues or
pushing.
Ma'am?
No,
that-
tissue.
Okay, you can try the other one, right?
Which one, ma'am? I can't hear you.
No,
she
there
said-
is another tissue there.
Yeah,
Can
I'll
you try
probably
that?
try that if this is not going in.
Now use a Sinski hook. It holds on to the tissue.
No, give me the other tissue.
Don't keep the cornea dry. Keep pushing. That's right. That's all. Yes. Fantastic. Very good.
Perfect.
Excellent.
Perfect, Dr. Shah.
Excellent. Excellent.
So, and then you just iron out the segment inside once you pushed it in.
Yeah.
So now you've probably seen how you would struggle a little if the tissue is overhydrated because it becomes too slimy for us to push it in, and this dehydration will actually help to push it in more like an intact segment. So sorry about the delay, guys. You want to take any questions?
Will there be any
Yeah, Nisha?
rejection?
So rejection is very minimal, Nishan, because the amount of tissue we're implanting is very, very minimal here. It's just a 0.75. So, and we're removing the epithelium and the endothelium. It's only the stroma. So, we haven't had any cases with rejection episode until now.
That's because the keratocytes in the donated tissue will
I don't
will
see
be
here.
Can you hear me now?
Ma'am, yes, ma'am.
Because the keratocytes in the donor tissue will die, and the those from the recipient tissue will go inside. That's why no rejection.
Yes, ma'am.
Preeti, how much of astigmatism as low or as high have you corrected?
Ma'am, as low we have taken up to 2 cylinders also, ma'am, 1.2, 1.5 and 2 cylinder, but we use a thinner segment, not as thick as this. It would just be a 0.5 segment which we will use in those thin cases, ma'am. So this is, since it's a 5, so maximum we've corrected up to 6 to 7 also, ma'am. So like I said, the amount of astigmatism correction again depends on the corneal biomechanics, and we have had up to 2 to 3 diopter reduction in the astigmatism post surgery, ma'am.
And here I suppose the thickness of the cornea doesn't really matter pre-operatively because...
so we are placing it at a much higher level, like at a 50% depth, unlike intacts which is at a deeper level, which is at an 80% depth. Here our tunnel is at a 50% depth, ma'am. So the key to it is just make your segment right before the surgery, not allow it to dehydrate too much, because again, like I told you, it becomes very brittle, and otherwise...
you want to say?
Okay, ready?
Thank you, Dr. Preeti. Amazing, sir.
Preeti, I think it should give a big round of applause to Dr. Preeti. You able to hear me in theatre 1, please?
Yes, we are able to hear you, sir.
Yeah, we are moving on to the squint by none other than the topmost strabismologist of the country. We are very fortunate to have Dr. Ramesh Kokinya here, coming all the way from Elli Prasad Eye Institute, Hyderabad, and he is going to demonstrate to us an MR resection and LR resection. And assisting him is the head of pediatric ophthalmology of Rajan Eye Care, Dr. Suraj Naik. Over to Ramesh, please.
May I call upon the panelists for
Thank you so much.
session.
Mic is okay, right?
Kavita Kalevani, Dr. Suraj Naik, and Dr. Shruti Nishant. Please come forward. The panelists for the cornea refractive, please stay back. We need to honor you. You can sit down.
Yeah.
Once this is over, we'll
Just give us 2 minutes.
Yeah, no worries, no worries. So, for you, standing for a long time may be difficult. I can stand and make the height higher.
No, sir. I think you are comfortable, we are okay.
I am comfortable.
Good afternoon, sir. Good afternoon, Dr. Ramesh. I'm Dr. Shruti here.
Hi, Dr. Shruti.
How are you, sir?
Thank you.
Good to have you here, sir. So, can you explain a little bit about the case, sir?
Yeah, this is a patient with exotropia of 40 for distance, 45 for near. You can also see in the photograph there is some ptosis is there in the right eye. The patient had childhood ptosis, and in the photographs it looks like there is some adduction limitation. We checked it, everything is okay. This is a case of intermittent exotropia with congenital ptosis in the right eye and a very
I just need 1 minute. I will give the presentations there.
It's already there coming?
Yeah, no problem.
Okay.
We'll keep on saying this. Sorry, actually explaining that.
No, because the camera will be there.
Okay, sure.
But just 1 minute.
Sure, no worries.
Hey, come on.
Shruti, you can hear me well, right?
Yes.
Okay.
And we can also see the slides, sir.
Okay.
Pictures.
Sure. Just they've asked me to wait for a minute. I'm just waiting. So generally, for a squint surgery, I use brimonidine eye drops. So that's what I do. Okay, they have connect.
Dr. Mohan Rajan, you are not audible, please. The audiovisual team from the theatre, kindly have the audiovisual system done over there. Output from the AV.
Hello?
Able to hear you, sir?
Yeah, we are felicitating Dr. Rajesh Fogla for excellent DALC and DMAX surgery. Give a big round of applause for him. And Vardhaman Kankaria for the lovely RIL implantation. Coming all the way from Pune. And of course, our own Sanjeev SKR for the really fantastic pterygium surgery. Yes. Preeti will do it later. Yeah. Thank you very much. Over to Dr. Ramesh Kokinya.
Quickly, we'll honor the cornea panelists over here. May I call Dr. Ramakrishnan, President TNOA, to come forward and honor the panelists of the cornea session. Professor Dr. Vasanta, please come forward. Dr. Ramakrishnan, sir, please come forward.
Camera. Okay. I usually keep it straight. So what I do is I stand.
Dr. Kalpana Suresh, please.
This is pretty easy for me to operate like that. Height will be there. Table height will be somewhere here. That's where I operate. For me, it's pretty quick. That's my usual thing. This is not. That's why I have to bend. If I sit, no, I have to
And
bend.
Dr. Nishant Madhivanan, please come forward.
Yeah.
Your photographer is ready.
Hello?
Yes, sir. Over to
Ravi, over to Dr. Ramesh.
Yes, over to
Yeah,
Dr.
Ramesh,
Kunya.
sorry for the interruption. All yours. Please.
No issues. We are going to start the case now. I was just briefing, it is 40 to 45 prism diopters of intermittent exotropia with additional ptosis the child has. He is an adult now, 17-year-old boy. So we are going to do lateral rectus resection and medial rectus resection. One of the things I just wanted to tell everybody is that we have put 1 drop of brimonidine. It makes the vasculature very, avascular. It can be used in pterygium surgery, it can be used in trabeculectomy surgery, any ocular surface surgery. That's one modification I do it. So let's start with the fornix based lateral rectus resection as well as medial rectus resection. So as I go along, if there are any questions, please free to ask. I use this Moody's forceps and I don't measure, I just go to the lower edge of the lateral rectus and make an incision. This is the lower edge of the
Yes.
lateral rectus.
Dr. Ramesh, could you tell a little bit about
Microscope,
the patient positioning?
it's
How do
possible
you
to keep the
position
microscope
your
there?
patient and do you sit superiorly?
Shruti, you have to be a little bit louder. I am not able to hear your.
Can you zoom it up
So,
here?
I was asking whether you position the patient in a specific way, like putting a towel roll or something to make the
One
chin
more.
up.
One more.
I usually have something rolled up on the shoulder. I want the head down. I don't want that head to be up. That's the only thing. Can I get the small hook?
No,
This
we are
one.
just trying to position the camera.
Okay.
To zoom it up for the people, for the benefit of the delegates.
Okay, please do that. So, if I have to switch to the microscope, I can do that.
Okay, doesn't matter, you just keep going.
Can you do this?
I think.
Is it okay? Or we can use microscope as well, no issues.
can use microscope?
Yes. If there is a,
That'll be the best.
if the visibility is not good, we can use microscope.
Yeah,
no
I think
issues.
so.
We can view it.
Huh?
We can view it, sir. Now.
Okay, we can do it. Okay, fine.
So, are you using the loop right now, sir?
Yeah, I'm
It is in the
using-
loop, yeah.
Okay. So, many surgeons prefer the loop and some like me prefer to do it under microscope. So, I think there are...
now it's
very
better, now it's
different-
better.
Yes, now we are able to see it clearly.
Yes.
Okay, can I get the hook, please? Hook. Yeah, perfect.
Yes.
So this is the
This is a
hooking
phonics
of the
base means the
phonics.
Marshall Parks incision, huh?
Yes.
What is it?
Yeah,
Marshall
it's
Parks.
Marshall Parks. I don't measure it, but it just at the lower edge of the lateral rectus. That makes things easier. Can I get the scissor, please? So I make one small nick on the upper edge of the lateral rectus. You can see. That's the buttonhole there. One more hook, sister. So now the lateral rectus is there. But always in a phonics, what you have to do is you have to do this pole test. We call it as pole test. Both the poles has to be there. This is the way to do it. See this?
Yeah.
Pole test on both sides. Once it is negative, then can you hold this, both of this?
Yes.
Directly we can go for suturing. Can I get the suture?
No, wait.
So this is what I was saying. The brimonidine effect is pretty good. It will not bleed or anything. So what I use, the passing this is very important. You see this? I go for partial thickness and again I come out and again one more partial thickness. Okay, this is
Double end.
fine. This is double end, right? That's fine. Okay.
Double end.
So, for the
I
benefit of
usually
the
put
viewers,
double end. That's
this-
okay.
The 60 vicryl, sir.
This is the 60 vicryl
Yeah.
we are using, and since it is cut, we have to use it 2 times. So
The same suture you go on either side, is it?
yeah, I
Or
usually
you-
take the same suture on either side
yeah, on
because
either
you
side.
don't have to cut it.
Correct, okay.
That's what I generally do it. But anyway, there are 100 ways of doing strabismus surgery. So this way I have to take it complete. You can see here, this has to be full thickness. Okay, can I get the other part suture? Suture. So without cutting, I use the other end and then cut it. So that's
Then you cut it, okay.
Yes, that's the advantage
So
with
you
that.
lock it on both sides.
Correct.
Okay.
I take the
And you cut the thing.
Exactly.
Okay.
Lock it on both sides and take it. So that way there is no sag or anything of the central muscle fiber. So here I am using the same thing, but I am locking it again here. This double step is not required if you use the thing, but double end switches.
Why do you require this one?
Because we are
Because single one I am using, right? That's why it is required. Otherwise, it's not good enough to stabilize the muscle. We want to anchor it completely, and we want to secure it completely. So we will do the same thing for the medial rectus. At that time I can show it. How do I use the single uncut suture? Scissor please.
A beautiful 3-point fixation, sir.
This is the 3-point exactly,
Yes.
Shruti. Can I get the Moody's forceps? So this is for all of you, and this is Moody's forceps. I use it. We don't have to use any kind of fixation
Modi?
suture. Modi or Moody.
Or moody.
So both sides I want one more Moody. This again rectangle I want to create this so that your muscle is straight. There is no kind of any kind of sagging or anything. So I will just show you right now, since I have disinserted the muscles. This is one crucial instrument for me. See this? This is disinserted, and now I use this. Can I get the small hook please? Yeah. This is teaser hook we call it as. So and
The loop
one
you are
more.
able to get enough magnification.
Yes, this is 4.5. I need one more retractor. It must be there somewhere. Yeah, this one. I use, this is called Barbie. Barbie is a pet dog of Dr. Helveston. He has kept this name to this. This is called Barbie's retractor. Once I get this, you can see this nice rectangular area. This is where I fixate it. Can I get the thing?
We are not able to see.
Yeah,
the,
because glove, your hand is coming the way.
Yes, the hand is.
Whose hand? My hand is.
No, some green color.
Ah, yeah.
Yes, now
Now
it's
it should be
clear.
okay.
Now.
We are planning 8 millimeter, sister. Can you give me 8 millimeter?
So when we have to go really posterior, like 10 millimeters or so, what would you prefer for the exposure, sir?
Yeah, see this. This is 8 millimeter.
Yeah.
If you want more, I can get this with the exposure almost 8 millimeter or so. It's very much possible with the same thing. Can I get a small hook? Just for everybody's thing, you have to pass this. Can you see some indentation there? This is possible in cases with aberrant innervations.
Oh.
This patient may be having some aberrant innervation. And with this you can see this is the inferior oblique here down. So,
okay.
I want this is very crucial in this technique. We want this, can you see this? This area has to be dried, and then I use 3-point fixation. 1, 2 and 3. 1, 2, 3 there. And I want the suture to be loaded, or I can load it. Needle holder. So I usually use a locking one because that makes it much more. I'll show you what is locking and what is non-locking.
This Modi's forceps, you have put it at the insertion, huh?
Yes,
Okay.
exactly at the insertion, so
you
that
can retract it.
I can retract it.
Very nice.
Okay. Sponge, can you dry that? Okay.
Is it visible?
Could we zoom up, please? We are not able to see the needle passing. Yeah, this is the most important part. So if we could have a better view of it.
Zoom பண்ணுப்பா.
One thing I can do is I can use the microscope, as I said.
You want to use the microscope light?
We can use it,
Yes,
no
yes.
problem
This
at
view
all.
is better.
Okay.
Better,
view is
now
better.
better.
We can use for medial actors, okay?
We'll use for medial access.
So could you explain to us about the scleral bites?
Yeah, can you see the needle here? So you cannot be, you cannot be going down like cataract surgery when you take a suture. You have to be flat. Flat means completely flat. So see this, I am never going like this. My direction is always flat.
Parallel to the
Parallel to the sclera. Okay. See this. See the needle. See the needle. See the needle. Once I am reached that point, my direction changes. And then push with this. So holding of sclera, the needle is very, very, very important in my opinion. Yeah, remove it please. And once it is there, you can dry it, sister. This 3-point fixation comes here, and you are done with the recession with this.
This thing is it?
Yeah, just one, or maybe just for your luck, have one more. That's it. And then I cut this a little bit closer because any kind of foreign body, the size should be very less because it can lead to granulation tissue. Sometimes it's possible, not in all cases. And one thing is important is after the surgery, just make sure that sclera, this is anchored very nicely. See this, pass once like this and pass once like this, so that on the table make sure that everything is okay. Don't wait for the next day.
So good
And
afternoon, sir.
generally,
Kavita sir, sorry to
yes, Kavita.
Kavita, be a little louder, Kavita.
Kavita from SN, sir.
Yeah, I know Kavita, yes.
So yeah, your way of taking the bites, so I want everyone to see that this is called cross-sword technique that he's used, which is really ideal because it keeps the muscle spread out, but the suture comes closer together so that you get a nice approximation when you tie.
Correct.
So this is the ideal way to do a recession.
Correct. Generally, I suture this. I don't suture this. I just glue it like this. Here I am going to suture it. So generally, I put a glue. I don't put conjunctival.
We can do glue.
If it is there, I can use it.
Yeah.
Okay, keep it ready. I will do the middle rectus and come back. Then we can use it.
So lateral rectus is over.
Lateral rectus is over. We will do the medial rectus now.
So conjunctiva, you normally use
Pardon?
8-0 vicryl, sir. If you are suturing it, it is 8-0 vicryl, right?
Yeah.
So nowadays everyone
So
switching
can you
to
come this
glue.
side?
That suture on the sclera, Ramesh.
Yeah.
I saw that you went parallel to the limbus.
Correct.
Am I right?
Yes.
But when I have done a lot of squints and I will
You used to go
do radial.
Correct. This is like I said 3 point. 1, 2, 3. I just join 3 points so that muscle is spread nicely.
Beautiful. Yeah.
Otherwise, it can come if you go radially. This can come, but there could be a central sag.
Central sag.
Doesn't matter if you do that technique because in your hand that much works. If I change technique
Center
today,
sag, sometimes I put a center suture also.
yes,
Yes.
that is not required in this technique.
Okay.
That's the only advantage.
Beautiful. Very nice.
Okay, I'll use the
Suraj, you
glue
want to
later.
say anything?
Sir, Doctor, we want to reiterate that sometimes you can have a very shallow or very thin scleral bite. So what would we do then? So there are a few things we can do. What I generally do is you can either remove it and take another deeper bite, because it is not advisable to increase the depth of the bite as you go along the bite, because it is a little dangerous. So either you just continue with it, finish
Okay.
it, and
Change
you
it, no?
realize it is
Change
very
it.
thin. What you can do is do another anchoring at the stump. That is called chickening. You are worried,
What I
you are
have to
chickening
do?
about it.
Remove it. Keep it
They're
here.
not hearing us. Huh? So you can do that. You can take another bite at the stump. So this will stay, but there is an anchoring in the stump as well. So that you can do if you have a very thin scleral bite.
Sir, Dr. Ramesh, do you have any, how do you prefer to, what cases do you prefer to do topical strabismus surgeries? Your experience in that?
Shruti, I could not hear you. Somewhere there is a problem. I think.
Can you hear me now?
Yeah, I'm hearing you, but it's not clear. Now I can hear you.
Okay. So my question was, what is your experience with strabismus surgery under topical anesthesia, and when would you prefer it?
Yeah, I do it in patients who are cooperative. How do you know the patients are cooperative? Just do a kind of, Q-tip test in the clinic. If they are okay, not squeezing their eyes too much, if they are 25 plus or so, then we can do this. And I use lignocaine ointment. Okay, he has some pain. This is almost like this is almost like a topical.
This patient is a little uncomfortable.
What is the most important thing is don't put pressure on the muscle. That's the only thing which is a kind of painful thing for the patient. So without causing much traction on the muscle, conjunctiva is never painful.
This is a resection you are doing.
I am doing a resection. Scissor system.
So you are taking the suture at that point of
Yes, where I have to do the resection.
Absolutely.
Yeah. Yeah. Yeah, there is some pain.
Another thing you can do to know whether a patient will cooperate for topical is you can do an FDT in OPD.
FDT also you can do, no?
Yeah.
If you do FDT in OPD, you can kind of judge how much cooperative, how much pain tolerance they might have.
Correct.
So
That's
a small
right.
indication.
முடிஞ்சு போச்சுங்க தம்பி
We are almost done.
இதெல்லாம் கார்டு கொஞ்சம் போடு மேல Yeah.
Scissor, please. So what we can do is instead of doing a resection, we can do a plication. So by cutting these things, the traction on the muscle will be much lesser. In resection, this is required.
In recession, while doing your recession, I observed that you were not doing much of this dissection.
Yeah.
No, I don't.
You got separated like that.
I don't do much kind of dissection around the muscle. You can see again I'll do a pole test here. This is the superior border and this is the inferior border. So without much traction we have the muscle here.
Now how do I was also noticing that you are just you open the conjunctiva and just you separate it.
Just on the muscle edge
What about
and
the muscle
Tinan's capsule, all that I used to do it in 2004-5. Not required. Like
Not
textbook
required.
says that you need only the muscle. That's not required.
Okay.
So it's not really
required, okay.
required actually.
So we used to use a cotton bud and
I know. We used to clean with the cotton bud so that you know that pink muscle tissue is there. Not required.
Not required.
Yeah. Can you hold this gently? Change your hand. Change your hand.
Berma.
Change your hand. This here and that is
Shall we
here.
go to the vitrectomy and come back here?
Yeah.
Okay. Huh? 3 minutes.
Yeah.
Okay, can you give me that other needle holder, sister? It's there on the other thing. Yeah. No, there is one more locking. Yeah. This is not cut, no suture. Yeah. Yeah. So give me 5 millimeter, sister.
So what are the precautions you would like to take to prevent suture granulomas or tenon cysts forming in the postoperative period?
Precautions in the sense, one is don't have longer suture. Don't leave longer suture. Second precaution, I would say, tenon cyst, close the conjunctiva properly. And when you have a thick tenon, especially in a child, take a deeper bite. The central
layers.
Close it on layers. 99% I won't do it.
Okay.
I just cut the tenons and leave it if it is protruding. Otherwise, I don't really do any kind of layered suturing, Shruti.
Okay.
And as you can see here, I am going to lock the one end. And I am going to start with the other side without cutting the suture.
This you are putting the suture at how many millimeters from the
5.5 millimeter from the insertion.
Okay,
That's,
then you cut.
Yes, and you can see.
During secondary surgery.
So this is a double arm spatulated 60
Yes,
Vicryl,
double arm.
which has
The
not been cut. Yes.
Earlier when I did recession, that was cut.
Yes.
This I am showing without cutting. How do we do it? Because for me this is time saving. That's why I do it here. So we change our plan here. We are going to do a plication in this case because both are effective. You don't have to worry with the effectiveness of the surgery. Both are quite effective. So
what about the measurements in plication and
we have to do a little bit more. When I say little bit more, maybe 0.5 more. Leave this.
The plication means how exactly you do it, Ramesh?
Yeah, this is edge.
Yeah.
I am coming back to the muscle insertion here from one end.
Could we have a better view? Yes.
Yeah, I think so.
yeah,
Now it's okay?
No. Actually, I think.
Now it's okay?
Yes, this is better.
Okay. See, what I am going to take is, I am going to take 2 sutures, Shruti. One I have already taken. Hold this.
Can we have it a little bit more in focus? It's a little blurry for us.
Okay.
Fine focus.
Sir, you will insert it in
No, actually, Ramesh,
Yeah.
correct me if I'm wrong.
Yes.
You have taken a suture at the 5.5 level.
Correct.
Then you have taken the same suture, you're bringing it to the insertion. And then
so that it's like a belt buckle.
Yes.
I want
you
a
are folding that muscle underneath.
fold the muscle by 3 millimeter on both sides. That's what I am doing. Yes.
That will not form something because the muscle becomes very thick in that area, no?
Yeah, that is one of the concern.
Yes.
I'll show you. It causes little bit of swelling, but it goes in 10 to 15 days.
Yeah, he's doing the plication.
We are almost done. In another 2 minutes, we'll be done with this surgery.
2 minutes.
So you take a central bite as well, Dr. Ramesh?
I don't take central. I combine both of this. And then if there is a slack in the edge, I'll take one more.
Okay.
So what you have to do is remove this hook, okay? And this knot I want you to hold in a knot holding forceps. Almost done, Babu. Knot holding the center there I can see. No, that's not the one. Next to that there is a, yes, that's the one.
Non-tooth.
Yes.
Hold
Just
the center.
hold the center, Suraj.
Yes.
Perfect.
I'm holding properly.
No, you have to hold it a little bit. You have myopia?
Yes, sir.
Okay, that's why you have to come closer. Okay, that's fine. Just hold on there. Don't worry.
I'll check. And
Yeah. Now pull it up, directly up. The not holding suture, leave it, pull it up. Yes. Can you see that folding of the muscle there?
Yes.
That is where plication is happening. Now I'll do one check. Scissor.
Now where do you cut now? Because you have got the...
Yeah, I'm cutting here. I'll show you.
Should it
Almost done.
Because you have the suture there, no?
Yes.
When you cut the suture, how do you make sure that you don't
Now
cut the suture?
I'm going to take two sutures. Give me the cut suture, sister. Can you see here, all of you, can you see the fold of the muscle? It is folded on to here. I have folded from here. Only thing is, I can see some opening on this edge, right? I need to close this.
So we can't see clearly, sir.
Okay.
Oh.
Okay, we'll shift.
How do you prefer
Suraj.
folding?
Normally the fold is seen outside or fold gets
Fold is seen inside.
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 Underneath.
But the elevation is seen.
Yes,
Can you
bump
see
is
us?
seen, yeah.
Yes.
Okay.
So can we do the folding beneath the muscle rather than up the muscle?
Here he's doing the suturing with the left hand. Can't believe it.
We can't
Fantastic.
even make out.
Yeah, but you have to be ambidextrous.
Yes.
That will make your life easier. Not a must, but everything make your life easier. Hold this. I'm just putting one side suture here. That's it.
Sir, do
And
you prefer folding the muscle up beneath, or beneath we can go and fold the muscle, sir? Like when the folding
I
happens,
didn't get the question.
sir, when the folding happens,
Yes.
the bulge is up and we can put the bulge down also.
Bulge is usually up because it's difficult to undermine the bulge. Yeah.
If we prefer to undermine the bulge, so will it work better in plication?
Not really. Not really.
Difficulty in bulging and all.
Not really. You see, bulging, what you are seeing is, I'll show you. I'll remove this and I'll show you. Forceps system.
See, the advantages of plication over resection, which has been conventionally being done till now, is that
See this? Can you see the
you don't
fold
insert the
here?
muscle.
Yeah. That's folded there. This fold, what you are saying is put it inside. Doesn't matter. Elevation will be there anyways.
Anyway.
This I have made it from here. I have put it here. One edge suture I have taken, which I usually no. And patients usually will complain for few
Basically,
days.
from the 5.5, you brought it to the insertion
Yes.
and folded it.
Folded it. Yeah.
That's all. That's
Instead of cutting the tissue, I am keeping the tissue and folding it.
Folding it.
Just like this.
Yeah, it's snail curved.
So the advantage
Correct.
being it is reversible and there is zero
Yeah.
chance of losing a muscle. So these
Yeah.
are the two advantages.
Losing the muscle. Can I put the glue? That's it.
I think we should give a big round of applause to Ramesh.
Thank you.
What a lovely way, elegant, simple, elegant way of demonstrating a lovely squint surgery. We'll go on to the vitreous surgery now.
Thank you so
We are.
much, Dr.
Thank
Ramesh.
you. I
Absolutely
don't,
bloodless surgery that we saw.
I don't suture this conjunctiva on the medial side. Forceps. I just glue the other side. You can see here. This is the glue. This is the other one. I want the, yeah. This one first. Yeah.
Thank you so much. May I call upon Dr. Kanmani, Professor Dr. Kanmani, to come forward and present the shawl and memento to Dr. Kavita Kalaivani and Dr. Shruti Nishant. Thanks for honoring us for being panelists for the squint session. Please come forward.
Yeah, you can start, sir. Introduce Dr. Dhanashree, please.
Sir, please come forward.
Ravi.
Good afternoon, Dr. Ravi. Can you hear us from OT2?
Yeah, I'm calling the panelists for the retina session. Dr. Manoj, over to you. Just give me a minute. Just a minute. Thank you, Dr. Kavita Kalaivani and Dr. Shruti Nishant.
Okay. Get the panelists fast and we'll start. Dhanashree has been waiting for quite some time.
Thank you, Dr. Shruti Nishant. Thank you so much. May I call upon the panelists for the vitreoretina session, Dr. Kasinathan, Dr. Supriya Dabir Gautam, Dr. Neha Perekha, and Dr. Aarti.
So we have here with us Dr. Dhanashri Ratra, an internationally acclaimed vitreoretina surgeon, and she is going to demonstrate us on a case of diabetic vitreous hemorrhage along with tractional retinal detachment using a 23 gauge Alcon Constellation vitrectomy system. Over to you, Dr. Dhanashri.
Okay.
This is not the first time Dhanashri has come to Rajan Eye Care. I think in 2013, I don't know whether Dhanashri will remember, she was here for the TNOA conference. She demonstrated a lovely surgery with the Stellaris PC at that time.
Yeah. Hello, good afternoon everyone, and it's a privilege and an honor to be here in the Rajan Eye Care and operating this case, and I especially I want to mention Shashwanti, who is really my favorite, and I'm very happy to be here. Only thing is I'm missing her, that she is not here along with her dad and mom. Yeah. So
Yeah, she's online listening.
okay. So hi Shashwanti, and this is for you, Shashwanti. So this I'm operating on a vitreous hemorrhage case, and I'm using a 23 gauge Alcon system here. Now why 23 gauge, you will ask me, because the whole world is using 25 gauge and even 27 gauge, but I will tell you why I prefer 23 gauge. So right now I am doing only anterior vitrectomy, and I always do this anterior vitrectomy before putting the biome, because after you put the biome you will not be able to see this anterior area very well. So my technique is that I keep this light pipe horizontal, and I keep the cutter below the level of the light pipe, and in the light reflected from the cutter you can very well see this anterior portion. You can focus the microscope a little bit lower in the posterior lens surface. All right.
I request Dr. Prashant Baunkule, please come forward and occupy the panelist dais, please.
And can you put the biome, sister? So, 1 minute.
Which one is a high risk proliferative diabetic retinopathy with vitreous hemorrhage and subhilar hemorrhage?
Preoperative
okay. Where is the SDI?
2 days before we have given anti-VEGF.
Okay.
And she is using a ReSight system on a Zeiss microscope for the wide angle visualization. Is it clear there?
Can you put the microscope this side?
So Manoj, is it a knife or a laser PDR?
Yes sir, laser PDRs.
It's a laser PDR. Okay.
Yes sir. Yeah.
Okay.
Welcome Prashant.
Hi sir, thank you.
Welcome, and you are all in single piece after Patna.
Just following your footsteps.
Well, I am in multi-piece now.
Sister, can you focus slightly?
Okay, Kasi, welcome.
Kasi,
Supriya.
Yes, thank you.
Aarti, thank you very much.
All right.
Neha.
Thank you, sir. So if you can see here, there is some vitreous hemorrhage, mostly in the posterior area. You can see one proliferation which is arising from the disc, and there is a subhyaloid hemorrhage. You can see this is the area where you have the posterior vitreous detachment is present, and this area there is no PVD here. So it is always important to note the vitreoretinal relationship, how the vitreous is, and in which area it is detached, which area it is not detached.
Usually in your vitrectomies, how many days prior to surgery do you give the anti-VEGF?
The preference of anti-VEGF, madam. How many days before you like to give?
Yeah. So generally it is given about 3 to 5 days before the surgery. So 3 to 5 days before is the ideal time to give. So you will have the adequate effect of the anti-VEGF too. And
the importance is to get a fitness for the surgery first before injecting anti-VEGF. So that
one must inform the patient that they should not go away, because if they take the anti-VEGF and go away, and sometimes when they come back after a month or two, you might have some problems because of the fibrous proliferation. So the first thing is to make an opening in the posterior hyaloid and then remove the subhyaloid hemorrhage. So once you remove the subhyaloid hemorrhage, you can see the retinal details. So I hope they are visible here.
It's visible, madam.
Okay, fine. Right, fantastic.
Madam is using a suction of 300 with a cut rate of 10,000 and a IOP of 30 millimeter of mercury.
Yeah. So this 23 gauge MIVS system, 23 gauge, that is why the suction is 300. But if you are using 25 gauge or 27, then you need to have a higher suction. So 23 gauge is, I like 23 gauge because it has got the benefits of both the worlds, so as to say, that it has got the benefits of 20 gauge as well as the MIVS. So it is faster as compared to the 25 and 27 gauge, and it is also safer like the 25 and 27 gauge. So this bridges the, both the systems quite well.
And one more major advantage of 23 is it can be reused many times compared to 25 and 27.
Yes, it's absolutely, yeah. And also easy to manipulate, they are not flexible like the 25 and 27.
Is there any particular condition wherein you will use only 25 gauge and not 23 gauge? Absolute indication.
Generally it is preferred for simple cases like macular hole or retinal membrane removal. Yeah, so in such situations you can easily use only 25 gauge, or sometimes where you have to do only simple vitrectomy, then 25 or 27 gauge is fine.
Is there some active ooze on the posterior pole there?
Little louder.
Can you be little louder, Dr. Supriya?
Is there an active ooze on the posterior pole? Is the NVD bleeding red?
No, this is just the subhyaloid heme only which is coming. There is no active bleeding as of now. Okay. So this is the proliferation, this is the prolif which is now separate, but it's not oozing. This is the subhyaloid heme which is accumulated, which is getting released.
Even for bad diabetics you can use 25 gauge because it's a thin instrument. You can go underneath the membranes, find a proper cleavage plane and do it, as Dr. Mohan Rajan was asking.
Yes.
So there are
with the cutter itself we can go around and remove all the membranes.
Yes, the cutter is a multitasking instrument.
Absolutely, absolutely, yes.
Nowadays we rarely use scissors and other instruments. The cutter does all the job.
And soon Alcon is going to stop marketing 23 gauge instruments in India now. It's only be 25, 26, 27 gauge available.
Manoj, you are giving me a shock here.
Yes, sir. You give Alcon is giving shock to everyone, not me.
Every 2-3 years Alcon will give shocks like this. Don't worry about it.
But Alcon has promised, like if you buy 125 gauge, 227 will be free to you. Only to Dr. Kasinathan.
I think we have to stop more 23 now.
So there are some point attachments here. As you can see, there is one area where is some point attachment. Can you focus a little bit, sister? Saline, saline visco. Some saline visco.
So the suction part of it, even with 23 gauge, if you are working on an attached retina, you can go with 500 suctioner. So the surgery will be fast.
Yes, sir. Yes, sir. Correct.
Detached retina, you have to reduce the suction.
Yes, sir. Agree with you, sir.
So there is this prolif and one more prolif along the inferior or superior arc, superior arc.
Yeah, there were two prolifs, two attachments, one superior and one inferior, and one at the disc. So otherwise this is a good case because there is not many attachments, not much of proliferation, and only some vitreous hemorrhage. So such cases are actually ideal for either 25 or 27 gauge because the manipulation required is less.
So I think Dr. Prashant is with us, who has totally shifted to 3D vitrectomy surgeries. Can you enumerate some of the advantages, sir? Dr. Prashant?
See, the thing is, 3D surgery is now, unless you try it and sit on a Mercedes-Benz driveway, you will...
Little louder, Prashant.
Okay. It's a thing which is irreplaceable in our setting. Frankly speaking, the advantages which it offers in the form of magnification, the field of view and the depth is unparalleled. You get 40% more magnification. So what Dr. You can see at this point of time, Dhanashri is seeing, I will be seeing more than 40%, 140% the size of the image without compromising on depth. So it's unparalleled, and for us in our theatre, 99% of the surgeries are done on 3D system, be it a cataract, be it a glaucoma, be it a squint.
Beautiful, very nice.
Dr. Prasad, what does that 1% case fall into?
When the theater is occupied and we have a big list. So we have two theaters, one where there is an analog microscope and the third is where we have an Ingenuity with a 3D system, and it since last 4 years. I think in one of the last few cases, what I showed, I think in RIC or where did I share? Now I do even the ROP surgeries on it. See, for a vitreoretinal surgeon, doing an ROP surgery is the pinnacle. You know, it is supposed to be the most toughest.
Yeah.
But now I did share those videos with everyone, and last 2 years I've been doing even ROP surgeries on it thing. And when I show those videos, I think I'm going to show it during our 3D show.
Yes.
Where you will appreciate the amount of the depth and the field which it offers over the such a small eye.
Very good, Prashant. That's a very good. I think it's a very great leap forward as far as the surgery is concerned.
Of course.
And she has completed the surgery almost.
Yeah.
And we're doing some laser, no?
Yes, we'll do some laser now. So I agree with Prashant that definitely a 3D vitrectomy system, 3D visualization is definitely better. It gives you an edge to your surgery, and it is most important is that it's so much of magnification and good image, so that it gives, and also the heads up, which is very much comfortable for you to operate. But there is a steep learning curve, so I think initially people have to be a little bit patient till they master the technique, because you are always used to looking into the microscope and operate, and then suddenly you have to look up and then operate, so that a little bit hand-eye coordination and all, initially there might be difficulty, but once you get over that, it's not difficult at all.
Exactly. Ma'am, I would differ from you, Dhanashri, over the period, about your comment on steep learning curve.
Okay.
Rather for us, it was a single theater where we had about 4 or 5 vitreous surgeries. And the second day onwards, we were as comfortable. Though at the back of mind, you are conscious that you are doing a 3D system for another 100 cases. But after that, it's not. When I move from one theater to other, I don't bother whether which case is placed in 3D versus no.
Yes. Prashant, we'll come back to the vitrectomy. That's a beautiful surgery demonstrated by Dr. Dhanashri. Let's give a big round of applause. We are going to the glaucoma surgery by Dr. Vijaya to Theatre 1.
I request the panelists for the retina session to stay back there. We'll come back to you. I may call upon the panelists for the glaucoma session to join the panelists table, please. Dr. Ramakrishna.
Thank you. Thanks, Mohan.
Dr. Neetu Mohan and Dr. Archana Nivash.
Okay, now we are going to say a little bit about this case. Dr. Srimati. Yeah. First finish the case.
Next case is left eye trabeculectomy. This case is both eye POAG, left eye cataract surgery done 5 years back. He came with the presenting IOP of 20 millimeters mercury, and the fundus finding is left eye 0.9 with inferior and superior notching. Now he is on 2 anti-glaucoma medications at brinzolamide and timolol.
So we have Dr. Vijaya, the senior most glaucomatologist in the country, I would say, not by age, by knowledge, and we are very, very happy to have her once again to demonstrate a clean case of trabeculectomy. Over to Vijaya.
Thank you. Hello everyone. This is a pseudophakic eye, and he is around 68-year-old. Looks like had cataract surgery, probably small incision. You can see the scarring here. So I am just saying which quadrant I choose now. So there's 12 o'clock because there is scarring. I am just using nasal to it, superior nasal. So the plan is to, with the phonics based, using the mitomycin, see usually 0.4 for 1 minute is what I am planning to use. So conjunctiva here seems to be fairly mobile, so we should be able to do a good trabeculectomy. Here is the phonics based flap.
Dr. Vijaya, Dr. R.K. is
good morning.
Good morning.
I didn't know that you are watching me.
I am here only, yeah.
Thank you. Any comments are welcome, sir.
Okay. Little bit more about the case. Is secondary glaucoma or primary?
Other eye is phakic, and other eye also has changes with the very thin corneas.
Okay.
Even though the baseline pressure is only 20, corneal thickness is less than 500 microns. Both eyes this shows significant damage.
Oh, great.
So to me it looks like probably small incision, and that
Already patient is on any medication?
two drops. Katri?
What is the plan now with your?
Plan is to trap with MMC. So in such a situation you have both options. You can do the AGV or do the trap with MMC. So conjunctiva is fairly mobile. I think as you were one of your which one? This one, and
Straight down.
Good morning, madam. Dr.
Yeah, me too. How are you? I can recognize your voice.
Madam, do you place a corneal traction or a superior rectus?
Here I was planning for a corneal traction, but sometimes if you are going away from the conventional site, I feel comfortable with the superior rectus, and rectus is away from the site of the trabeculectomy. Even if there is any conjunctival tear, it's not going to interfere with your trabeculectomy. You can see it is nasal to the superior rectus. Maitu?
Yeah, one more practical question. Such cases, it's where you repeat the already cataract has been done, now the second surgery. Will you do anything extra? First one, whether you will stop the anti-glaucoma before surgery?
Oh, it's possible, but it is a service patient, so even maintaining the glaucoma medication probably will be hard for them.
Okay.
And so when the disc is quite pale and advanced cupping.
Okay.
So, and even with the so-called low 20 pressures, disc has got, can you measure 1 minute please? Damage is quite significant.
Number of sponges put inside.
No, I think I depend.
About a video yesterday.
Yeah, my technique is I make 3 pieces, fairly large. I hold them all together. I never leave them. So yeah, here I think you know how many you gave? 10. So he knows.
10 is
too much. Yeah, I know.
2 or 3 is more than.
Yeah, usually I give it 3. It's okay, doesn't matter. I hold all. Here I have to count because they're small.
Will you give a pre-op steroids?
Yeah, he has counted. I expected. Yeah.
We cut 10. So from that we know how many we have removed. Balance is there, no? So with that we count.
No, I will give you 10 back to you. Don't worry. Otherwise, we will not go home today.
Where is the last punch, after doing the trap?
And there are people who thread them in a suture.
Yeah.
And then they put it in here. And
sometimes we can
1 minute
use this blue also, tryptophan blue also. You can stain.
வாங்க நீங்க எதுல போடட்டும் நான் அந்த பவுல்ல கொடுங்க பவுல் கொடுங்க
எண்ணிட்டு போடுங்க
எவ்வளவு வந்ததுமா should be there கவுண்ட் பண்ணுங்க எவ்வளவு இருக்கு 10? Sure? Okay, give me cartridge again to me. Irrigate.
Will you give any pre-op steroids?
Here I think the congestion and no allergy. Cartridge varle konja press பண்ணுங்க. இல்ல press the. Oh, okay.
Yeah. Straight down.
Okay. So again, there are a lot of ways of irrigating. Many people take measure 20 ml 3 times they do it. I believe in using forceful with the cannula. Many people take out the cannula and irrigate the site. I think a forceful with the cannula irrigation will remove the residual mitomycin C better way. Poduma.
Vijay, one more thing. In such cases, we used to give subconjunctival mitomycin in such case where the chance of failure is more. What is
instead of the
sponge. Yeah, instead of sponge.
Instead of sponge. Yeah. Okay, that's the other way of doing it. So sometimes when something is working well for you, I think you don't deviate from that much.
Okay, yeah.
This is called the 300 depth knife.
Oh, yeah.
Usually I use the 500 for adults. So I may deepen it little bit before. Can you just retract?
This makes our job very easy.
Yeah. So the 500 one is a really nice one for the trap. 300 is what we use it for the children, for the juvenile, where the and also thin.
Yes.
Can you map here, wherever I show. So the key for making a good trabeculectomy is visualize before you dissect. Have good assistant like who is assisting me here. She is extremely good.
Very good.
Very anticipates.
Yeah.
And she is mopping here. ஒன்றும் இல்லை ஆச்சு ஒரு 10 நிமிஷம் பரவாயில்ல நீங்க கை எடுத்துடுங்க நீங்க கை எடுத்துடுங்க அவ்வளவுதான். So what is the end point? You dissect the surgical limbus.
left side தான்
இங்க மாப் பண்ணுங்க அப்படியே இங்க பின்னல் வாங்க காட்டி வெச்சுக்கோங்க. So the moment you see the surgical limbus clearly, that is the end point. So you can see the gray line here. So that is the junction. மாப் பண்ணுங்கம்மா. Just 1 drop saline. Irrigate? No. This is the intrascleral vessels. So they okay, I think 1 minute. Sometimes difficult to characterize them. Yeah. And when you do congenital glaucoma, these intrascleral vessels are very important landmark. The reason is just anterior to it will be the Schlemm's canal location. Entry and intracameral pallor. Yeah. Okay. Mop. So I am entering anteriorly using the crescent. Okay.
Surgery. இந்த கான்செப்ட் இருக்காங்க இங்க வருது சர்ஜரி எனக்கு பாத்துட்டு இருக்காங்க.
Are you able to see the screen?
Yes.
Okay.
Yes, fine.
I'm just entering.
Nice flap.
Yeah. So what I usually do is, I usually tend to constrict the people with intracameral pylo. So that kind of gives you a good iridectomy, just sufficient enough. So after entry, you make the punch. So stop at the posterior limit. So iridectomy is recommended. Can you hold this, ma? You said he is a myope, no, Sujatha? But file didn't say anything. Eye is soft. Leave it. Okay. Because I became little softer.
Beautiful, very nice. Excellent, ideal PI she has made.
Give me the 10-1 nylon.
How many punches do you take? That's all.
Why it allow, that's it. That's more good enough.
Okay, sometimes there's be a valve effect, so you have to make sure. That
Make sure it is it is enough for the. I tend to take the.
Concentration, please.
You're going to put a releasable suture again?
Yeah.
Are you going to put releasable suture?
Yes, yes.
Center.
Whatever, Nimisha, I will just fix the.
One releasable and two fixed on either side.
Yeah, I think I'm sure you also must be doing the same.
Yeah. And also we normally used to take a corneal bite first.
First one, huh?
Yeah, two.
Yeah, he is softer. 1 minute. Let me put the. No, I will inject the saline. Just let me take this bite.
Do you always suture under saline, madam? At least in pseudophakic eyes for beginners, maybe air bubble will be
Yes.
a good idea.
Yeah. And pre-placed releasable is a better option.
Yeah.
So that you don't. I tend to take the pre-placed for the high-risk patients like vitrectomized eyes, high myopes, where you expect lot of hypotony. I didn't expect hypotony here. For some reason, his saline.
Have they given any mannitol for this case? Any mannitol they have given? Mannitol.
I couldn't follow, RK.
No, mannitol, whether they have given any mannitol?
No. He's a very Dimox. He's very thin individual. Probably has and he has very thin corneas as well.
Maybe, yeah.
So 4th rows. My the cutting ಇದು వెచ్చుకోంగ. Can you give me the other forceps? You have any other? Another forceps ಕೊಡುಂಗ.
This is 10-1 nylon, no?
10-1 nylon.
So
Got.
4 rows with the slip knot.
Saline. When I looked at the file, the first doubt I had was whether he has cut. Any pseudo exfoliation, because it's very characteristic. Such a advanced glaucoma following the cataract surgery and also thin corneas. Sure. So I take 2 by 2 pierce her skin close to the base.
Lot of iris atrophic patches also.
Yeah.
Probably secondary glaucoma.
That may be related to the cataract surgery as well.
Larsha. Come. Dhanashree and Preeti, please come first. Give a big hand for, you able to see me, Ravi? Ravi?
Yeah.
Yes, sir.
Ramesh Kakune has got a flight to catch, a wonderful squint surgery. Give him a big round of applause, coming all the way from LA, despite the fact that he had a very important meeting today in LA Prasad, but he was so much of love and affection for us. Thank you very much, Ramesh. Thank you so much.
Take care.
Of course, Dhanashree, who can match her? The best teacher in the world. The best teacher, everybody. Best teacher and a great motivator, great mentor and a super surgeon.
Thank you so much.
What a lovely surgery Dhanashree did today. Preeti is like my own daughter. Preeti grew up literally in Rajan Eye Care and we are the main source of inspiration for us, for her, and she worked in Rajan Eye Care for some time before she went to Shankar Netralaya, did a cornea fellowship. Now she is with Amar and very happy that Preeti did a wonderful job. So proud of you, Preeti. Thank you very much.
Are we going back to the trap theatre,
yeah.
sir?
Yes, yes.
Please, switch on to the trabeculectomy theatre, please.
Wonderful.
Thank you.
Yes, yeah.
Back to Vijaya here.
Yeah,
No, yeah. Senthil, just wait பண்ணுங்க. Okay, Vijaya can,
yeah, I just took the two base sutures close to the base.
Two base sutures or one releasable suture? Okay.
Yeah. And close the conjunctiva. Conjunctival technique closure varies from person to person. The key is to have a watertight closure.
Yeah.
Sponge கொடுங்கம்மா.
Yeah. We'll come back here?
Yeah.
Or it's okay? We'll go to OT2. Which one?
Will you bury the knot?
Yeah, I don't tend to bury.
No, sometimes
Because sometimes, I mean, you cut the suture well, should be fine. So, what I do is I just pull this conjunctiva and create a tight flap over the.
2 minutes, please. We'll do it. Already wait. Yeah. We go to the second theatre, wherein Manoj has already done the vitrectomy. He's going to show us only the ERM peeling there. Go to theatre 2 and come back to the. Thank you very much, Vijaya. Give a big round of applause to Dr. Vijaya, please.
Thank you.
I call upon Professor Dr. Radhakrishnan to come forward and honor the panelists of the glaucoma session.
15 minutes.
Professor Dr. Radhakrishnan, sir.
Hey, he's here, yeah.
Yeah, I'm sitting here with along with Rajan.
I know, sir. Please come forward, sir. I would like you to honor the panelists.
Yes. Make it fast. Make it fast.
Dr. Ramakrishnan, sir, please come forward, sir. Thanks for honoring us to being the panelist for the glaucoma session, sir. President TNOA, thank you so much, sir.
Give a big round of applause to the President of TNOA as well as our teacher, Dr. Radhakrishnan, sir.
Dr. SUJATHA Mohan, please.
Ravi.
Yes, sir.
Yeah, vitrectomy is going on. Manoj is going to show.
Yeah, the panelists are ready here for the vitrectomy.
Yes. Ask them to stay back here.
Dr. Archana Nivash, please come forward. Professor Dr. Radhakrishnan, honor Dr. Archana Nivash, please. Thank you so much. Thank you.
Okay, ma.
Yes, sir. Thank you so much.
Thank you. Manoj is doing this. As you know, Manoj Khatri is head of the vitreoretinal surgery in Rajan Eye Care, and he is demonstrating a vitrectomy. A patient who has got an ERM, epiretinal membrane, and he's already done the vitrectomy. He's also done the PVD induction as well, and now he's going to do a ERM peeling. Over to Manoj.
Thank you so very much, sir.
25 or 23? 25 gauge he is doing.
Good afternoon once again, everyone. We are using a Alcon constellation system platform of for this patient using a 25 gauge vitrectomy system. As you can see, there is a cellophane maculopathy type of a ERM, epiretinal membrane, and this patient didn't require much of a vitrectomy because the partial PVD induction was already there. So what we have done right now is stain the epiretinal membrane with Oki Blue. It's a dye by Oro Blue, Oro Lab company. We stay there for some time. The dye has to stay for some time to get a good staining, and sometimes in epiretinal membrane the staining doesn't come so well. So we might have to restain it couple of times. So that is it. And the plan here is to get an ERM along with an ILM.
So ERM with ILM.
Yes, sir. That is a plan. The only thing different what we are going to do right now here today is first time in India we are going to use a special forceps for ERM peeling. It's called as a shark skin forceps made by Alcon, patented by Alcon. I'm just going to show you the advantage.
What is the advantage of that?
Yeah, I'm just going to show you to you. So I take the forceps in my hand. So just stay there for some time. As you can see here, still the staining is not very good. Is the visualization clear there?
Yeah, it's a little, can you zoom up and focus down a little?
1 second, sir.
Yes.
Now it is better?
Yeah, it's good.
Better.
You can withdraw the endo illuminator so that we have a better bigger.
No, 1 second, sir. I'm just seeing the stain there.
Okay, fine.
It's not stained that well because the cellophane maculopathy.
Prashant, you should have brought the ingenuity when you came here.
Sir, I am not a Superman like Dr. Mohan Rajan.
For the next Retina 360, we'll have a 3D view, sir.
No, we are getting the RTO system very soon.
That's from the
It needs little bit of staining. It's not stained that well. That is very typical of this cellophane type of a maculopathy. It doesn't stain that well.
Now, use a Trypan blue or use a brilliant blue?
So what's your
Brilliant.
opinion on staining under air?
We do it sometimes, but most often or not, you can just leave the stain for some time.
So for ERM, it's Trypan blue is much better than.
Yeah, it is there, but I normally prefer just a single stain, sir.
Yeah, air means one.
For the sake of the audience, what is the difference between Trypan blue and brilliant blue?
One is a vital dye, another one is a non-vital.
Non-vital.
Yeah.
So for ERM, we usually prefer a Trypan blue under the air because Trypan blue sometimes can stain the posterior capsule as well.
Yeah.
Whereas with the brilliant blue, you can do it under the saline itself. That's for the ILM.
Okay.
So the stain is slightly better now. Still, it is not 100% complete.
Anybody using Indocyan green?
Not at all, sir.
Not at all, okay.
It's toxic to the retina, so normally don't do it nowadays.
I think you have to remove the dye a little bit more.
1 second, sir. That's what I'm doing it. Just a dye, small dye wash out. Stain pretty all right.
Sometimes there can be a little bit of vitreous schisis in the posterior pole, so the dye doesn't take some.
Correct. It's already there.
So you prefer removing ILM in all ERM cases?
Preferably yes, if you can get it. Preferably yes.
So I would prefer to remove the ILM because ILM is a substrate for the ERM to grow. So any ERM you are going to do, I would prefer to remove the ILM as well. Dr. Prashant?
I am a very strong advocate of it since 2010 once I saw a card. So be it even in a case of cases of detachment, be it a diabetic macular edema, what Dr. Dhanashree did,
So
I would
here
prefer to do even in that case.
Okay, here we have the new forceps. I don't know whether it is visible or not. It's called as a shark skin forceps.
Shark?
Yeah. So the tooths are like that shark tooth. So the tip has serrated edges. It's supposed to be non-traumatic for retina. So you can even go and touch the retina. That's what they are saying.
Let's try it.
So there is a small edge which is available here. Can you see that it has come out?
Yeah, beautifully.
So just peel along the edge and just take it out.
Can you pull the endo illuminator a little up? Yes.
Is it seen, sir?
Yeah, now better.
Yeah.
Even the ILM has come out with that.
How do you know the ILM has come out?
You see the ILM stain is the blue stain.
Oh.
Blue stain tissue is the ILM there.
So ERM comes in bits and pieces, whereas ILM comes as a sheet usually.
Yeah. Just like a Rexis.
Yes. Once you start peeling, then you will see the staining, just like the capsular Rexis.
Yes, sir.
Once you make a nick and you start peeling, then you will see the staining is quite good enough.
Yes.
Is it okay, Manoj?
Yes, sir, we can start.
Fine?
Yeah. So
Manoj,
this
you
is
are using the same lens 120 or 90D for the macula?
no macular lens.
Macular lens.
Macular lens. Always use macular lens. Don't use contact lens that often because ReSight gives you a good enough view.
Yeah.
So
Ravishankar?
Yes, sir. Tell me, sir.
You can call the oculoplasty people, panelists inside onto the dais, and we go on to the final case, oculoplasty by none other than Dr. Sindil Nathan. He's going to demonstrate the entropion surgery.
You can stay here for 1 second, sir.
1 second, yes, 1 second.
Mohan, I am sitting here only, don't worry.
Okay, sir, thank you, sir.
So this is the beauty of this forceps. With one single peel, you can take up both ERM and ILM.
Now you can see the sheet like a membrane, so that's the ILM which is coming up like a sheet.
Yes, sir. So normally I do reverse peeling, so that means you look for an ILM, you don't look for ERM to start peeling.
Yeah.
So with that one single stroke you can get both of them out.
So we are now coming to the last, probably the last of the entire.
Recording.
So this is a patient who has an entropion, involutional entropion.
We can't hear you, the audiovisual team there. Theater.
Okay, so
Can you hear now?
can you hear?
Yes.
Yeah, actually what we are going to do is we are going to do a lower eyelid involutional entropion correction. This patient, and the recording podunga, this patient has got a lower eyelid involutional entropion, and the procedure which we are going to do is we are going to do a lid tightening with a lateral tarsal strip with everting sutures. So as you can see in the recording there, I have marked the lateral canthotomy incision. Oh, 1 minute ma.
Dr. Pratibha, join Dr. Radhakrishnan, please.
Yeah, I'm sitting here, no problem.
Ravi?
Yes, sir.
After we finish Sandil's case,
Yes, sir.
you can honor the panelists. We are vitreoretinal panelists as well as
We
ophthalmic.
have the injection, eccentric injection left and idea video left, sir.
Paginax injection.
Yeah, I'm sorry, Paginax injection and idea video. We want the video panelists to be there.
Yeah, let them be there. Let them be there. Okay, Sandil, look, all yours. Sandil, go ahead. So what we are going to do is we are going to do a lateral tarsal strip with everting sutures for a patient with low eyelid involutional entropion. Live putkonga ipo. So what I'm going to do first is going to do a lateral canthotomy, and then followed by lateral cantholysis, which I've already done. So what I've done is I've made a canthotomy incision here.
Oh, why?
So that's the lateral canthotomy because we're going to do a lateral tarsal strip, sir.
Oh, because
so for that first we do a canthotomy incision, which comes like this. You make a straight incision in the lateral canthus.
Yes.
And then you do a lateral cantholysis. So lateral cantholysis will free the lower eyelid. So what you do is you go vertically like this. You able to see that? And you make a cut here. So you do a canthotomy and cantholysis so that you actually get a free lower eyelid. And so the idea of doing this is once you do a canthotomy cantholysis, you can see the lateral orbital rim here. So this is the lateral orbital rim. Can you see it? So this is the lateral. Who is in the panel? Pratibha?
Yes, sir, we are very much here.
Yeah, please. This is the lateral orbital rim, and the first step starts with creation of the lateral tarsal strip. So now I have a free lower eyelid. Do you remember? You're able to see that clearly, Pratibha,
Yes,
and other
we
people?
can see very clearly.
Action, sir. So what I'm going to do is I'm going to do a grey line incision. So I'm going to make an incision in the grey line and split the lid into two. The anterior lamella having the skin and the muzzle, and the posterior lamella having the tarsal plate and the conch. So you can see I made a lateral tarsal, I made a grey line incision. Tooth force puchukonga and cautery kuttaranga. Puchi vechkonga innoru kaila.
Beautiful, sir. I saw three.
I saw Santosh Hanavar there. Santosh Hanavar.
Presently is not in the hall, sir.
Okay.
He'll be coming back.
Sendil, sir, I saw three markings in the lower lid.
Yeah, that is the site of the everting suture.
Okay.
So I'm going to put.
Pre-planned it earlier.
Yeah, I just put some dots so that you can see where I'm going to take the everting sutures.
Sir, do you do in all your cases of lateral tarsal strip?
Yeah, one of the main reasons for the entropion is low eyelid laxicity. So you have to usually correct the laxicity as well. So a lateral tarsal strip usually is a very important procedure which you have to combine. But if it's going to be a very temporary procedure, or if a patient is very invalid and you need some sort of temporary procedure, just doing everting suture will work out as a short-term solution. And now you can see, can you see the zoom? I have I've cut the lid into two. Can you see it? The anterior lamella and the posterior one. The anterior one has got the skin and the muzzle. The posterior one has got the tarsal plate along with the conch. So now I'm going to form the lateral tarsal strip. For this I will be taking off the skin of the lid margin here. This I will remove, and then I'll make an incision, I'll make a cut below so that I get the tarsal strip. So you can see this is the tarsal strip. Can you see this one?
Is it clear?
Yes, sir, it is seen very clearly.
This is the lateral tarsal strip. Important thing is you have to take off the conjunctiva from the posterior margin of the tarsal strip, otherwise we get a conjunctival cyst there. So use a 15 blade and denude the conjunctiva from the tarsal strip like this. So you just remove all the conj from the tarsal strip because this is going to be buried under the bone. So once you have done it, the tarsal strip is ready. Now before I tighten the lid, I will take the everting sutures. So we use 40 or 50 chromic catgut. So that will, we will be taking the everting sutures from the lower eyelid fornix and we will come out through the skin just below the lash line. So we will do it in 2 positions which I have marked before.
What is the name of this surgery? Why is
this is not Weiss, sir. This is called a lateral tarsal strip with everting sutures. Everting sutures, yeah.
Okay. There is a name. I thought there was a name.
So this is the chromic catgut everting suture. So what I will do is mele parunga sir. So I'll ask the patient to look up, go into the lower eyelid conjunctival fornix, and then come out just below the lash line, 2 or 3 millimeters below the lash line, like that. Can you see it?
Yes, sir.
Yes.
So we don't have a double arm, so the other end we will thread it through a superrectus needle.
What suture are you using, sir?
Using 40 chromic catgut.
Okay.
So similarly we will take one just next adjoining the previous one, and this has to be angled in such a way that it comes out below the lash line. So once we take 2 bites, you can see now this is the everting suture. So this is the first everting suture. So I'll take one more bite like that, bulldog clamp and cut. So you can see this is the first everting suture. So if you see the pathology of the lower eyelid katma, pathology of the lower eyelid entropion, you have an overriding of the pre-septal over the pre-tarsal orbicularis. So this everting suture will create a scar between the pre-tarsal and the pre-septal orbicularis, and it will help in the recurrence, preventing the recurrence of the entropion. So the second everting suture is coming now. So go into the fornix and then come out just underneath the lash line.
So for the sake of the postgraduate, Senthil.
Yes, sir.
I think for the postgraduates, they will understand that when there is a loose papers, you put a small strip, 2 strips. Same thing like that when the orbicularis and the anterior and the posterior is sliding one over the other.
Exactly.
You're just putting 2 strips.
Exactly,
like,
sir.
2 papers.
With the sutures. You're creating a strip with the suture.
So into the fornix and then just outside below the lash line. So now we have our 2 everting sutures ready. So what we will do is now we will just keep it ready. We will not tighten it now. Bulldog clamp cut. So now we have got we've got the 2 everting sutures. So now I will do the lateral tarsal strip. The strip is already ready, so all we need to do is we need to anchor the lateral tarsal strip to the lateral orbital wall periosteum. So this is a very important step. So for this we use 40 proline double arm suture. So you can see this is other input. So you can see this is the 40 proline which I use. So it comes on almost like a half circle needle. You can see the half circle needle, half circle needle. So what you have to do is, this is the most important step of the surgery. So you have to take a bite in the lateral orbital wall periosteum. So if you can see, I'm going on the inner aspect of the lateral orbital wall, palpating the periosteum and coming out. So can you see this now?
Yes.
Yes.
So you can see this is the periosteal bite. Can you see it, Dr. Pratibha?
Yes, sir, we can see it very clearly.
Yeah, so this is the one.
And
so once, so
once we take this periosteal bite correctly and anchor the lid there, we will feel that the lid is very taut and nice.
exactly, yeah.
So that is how we know that we have
Can
to
the
take.
proline sutures cause some granuloma or something?
Proline usually does not, sir. You have to be careful so that it does not rub the globe. So you have to be careful when you cut it. You should not have 2 long ends. And so this is the first bite, and you're going to take the second bite now. Before that, we just see what will be the contour once we tighten it. Just see the height. So I think I'm happy with this. So the second arm comes here, and this will go just above the first one. So again, you palpate the lateral orbital wall and take a bite of the periosteum. So you palpate there and then come out like that. So what you do is you have 2 bites now, and so you have 2 bites now, and then I will show you the technique called the Lester loop, which is invented by my teacher Dr. Rajan Sampath, and what this is called as the Lester loop technique. So what we do is, now you can see we have a loop here. Can you the loop coming?
Yeah.
Can you see this loop here?
Yes, sir.
So this loop will actually trap the lateral tarsal strip like that.
Oh.
And then we take a bite here. So this actually prevents the strip from slipping. It traps the loop. So you have additional protection. So you see the loop is there, and now we take a bite here. So you can see the loop actually having one more wall of protection.
Yes.
To prevent the strip, to anchor the strip. So this technique is called the Lester loop technique.
Beautiful. Okay, we will come back to you,
yes, sir.
in a minute.
Yeah.
Okay.
You can finish it.
We go have the final procedure of the day. Been very successful day and very.
I call upon Professor Dr. Ramakrishnan sir, please come forward and honor the
wait.
panelists of
1 minute, Ravi. 1 minute, Ravi. 1 minute, Ravi.
Sir, then the panelists need to catch the flight, sir. I'm sorry. I apologize.
Oh.
I apologize, sir. Sorry. Please come forward, Dr. Ramakrishnan sir. Honor the panelists of the VR session as well as the oculoplasty session, sir.
Yeah.
Quickly, please come forward, sir. Yeah.
Ravi, can you make it fast?
Yes, sir. Yes, sir. Yes, sir. Yeah.
All the 4 you call together. That's all. All the 4
Delegates, after this we just have the final injection and a video on the ILIA, and then we break for lunch. Thank you so much. We apologize for the delay. Thank you. Dr. Neha Pereka, please. Thank you for coming all the way from Kurnool, Andhra Pradesh and being a panelist. Thank you.
Thank you, Neha.
Dr. Supriya Dabir Gautam, please come forward.
Thank you, Supriya.
Dr. Aarti, please come forward. Professor Dr. Radhakrishnan sir, please come forward. Dr. Pratibha, thank you for being the panelist for the oculoplasty session. Please come forward.
That you can finish, na? Side by side you can give, Ravi.
Sir.
Please.
We are done. So just 30 seconds, sir. Start counting, sir. Yeah, Dr. Pratibha, come forward, please.
Start counting. 10 seconds over.
And I'm done, sir. You have 18 more seconds. Carry on, sir.
Manoj will show the Paginax. Yeah. Change, please.
Good afternoon once again, everyone. Here we have a patient.
The microscope camera, please. Yeah, yes. Thank you.
Here we have a young patient, 38-year-old male with a myopic recurrent CNVM, choroidal neovascular membrane. That's the reason we have chosen brolucizumab over any other anti-VEGF. The injection procedure-wise, everything remains the same. The only thing is, don't likely to make a conjunctiva and sclera opening at the same site. So just slightly retract the conjunctiva and go
in angled manner.
Yeah, angled manner, or also the direction of the needle should be towards the optic nerve. Keep talking to the patient. Take the confidence. Inject the drug slowly. And when you want to withdraw the needle from the eye, be there for some time.
and withdraw it very gently and slowly, and keep it pressed for some time so that the vitreous wick is not there. So the brolucizumab has many advantages here over regular other anti-VEGFs. The one is duration of the drug available, and also less number of injections and more intense response. So it scores over other anti-VEGF agents.
I think, yeah, we have got a huge experience with Paganax, very good results with Paganax. We'll discuss about that during the lunch break.
During the lunch break.
Okay? I'm sure Prashant and Kasi and other people also have. Over to Sandil for the final remarks.
What we are doing is we are finding the everting filter.
Well done.
So we just have after this we just have the ILIA video, sir, just 1 minute video.
You can show it there.
Finishes. Yeah. After Sandil finishes it, then we break for lunch.
So now you can see we are trying the final everting sutures on the lid side, the chromic catgut sutures which we had taken in the first. That's the everting suture. So we have corrected both the lid laxicity and we have caused a scar between the pre-tarsal and the pre-septal orbicularis oculi. Tooth forceps.
Vijayava. Yeah, I asked her to wait.
Yeah. So now you can see we almost come to the end of the procedure. So that's the everting suture which has been tied.
Don't you think it's a little tight there?
It has to be tight, sir. So it has to be tight because it will stretch and the lid will loosen up. So we have to leave it a little bit tight.
Yes. We're coming in 2 minutes.
So you can see now this is the end of the procedure. You can see the everting sutures there.
See that?
Beautiful demonstration, sir.
Beautiful. Give a big hand for Sandil.
Thank you, sir.
Lovely. Grand finale.
Lateral strip is one of the beautiful and simple procedures which can be done both for ectropion and entropion, which involves horizontal lid laxity. But only thing is this everting sutures we don't do regularly for all patients. You do it in all cases, sir?
Everting sutures as a primary procedure for entropion, I do it mostly in all cases. I do it.
Okay.
Yeah, Sindhil, as you read, the entropion, the same procedure can be done for the entropion as well as ectropion, but when the orbicularis, the antelamella and the postlamella is weak, you get an ectropion. So you don't need these sutures in ectropion.
Correct.
Thank you, Sandil. We'll close it.
Thank you, Ravi. Thank you.
We have a small presentation ceremony, Ravishankar, felicitating Dr. Vijaya.
Yes, sir. Okay, sir.
And Dr. Manoj and Sandil also. Yeah. You're able to see me? Angeya? 1 minute ILIA video.
Thank you, Bayer. The ILIA injection. Thanks for supporting us for this surgical strike conference.
At Bayer, the year 2020 started off with a commitment to help thousands of WAMD, PCB, DME patients in India as we introduced the ILIA for You pilot program in February 2020 involving 60 centers. We planned to further extend this program to centers across the country within the year based on the response and feasibility of our pilot program.
I went without the shirt.
However, the progress came to a grinding halt as the world was hit with the devastating effects of COVID-19. The widespread effects of this virus caused the country to stand still, hampering our expansion plans for ILIA for You program. The unprecedented times came with its challenges, but we took it in our stride and endeavored to overcome the challenges and emerge successful in delivering our program. Approximately 6,800 plus doses were given to over 5,100 plus enrolled patients, with more than 50% patients returning for the third to fifth injection. Overwhelmed by the positive response and patient compliance, we just couldn't wait any longer to introduce ILIA for You program in centers across country. We are proud to announce that thousands of WAMD, PCB, DME patients can now benefit from this program as we make ILIA more affordable. With this vision in mind, We are providing 5 injections at the cost of 2 injections to help patients get affordable treatment in these testing times. So effective price to the patient will be less than 23k per injection, which is lesser than some of the available anti-VEGFs. We welcome you all to ILEA for You program.
Thank you so much. And
Okay, you able to see us?
yes, sir. Yeah.
We have the grand finale here of felicitating the one and the only Dr. Vijaya, L. Vijaya, the glaucoma, and the L. Vijaya is a fantastic glaucoma surgeon, fantastic clinician, above all, the greatest human being on this earth. I think we should all give a big round of applause for Dr. Vijaya.
Thank you,
Amazing.
Dr. Vijaya. You were awesome during the surgery. Thank you so much.
Both LG and LV are really inspirational for us. And Manoj, please come here. Yeah. Give the thing, I will give it. Doesn't know. Manoj Khatri. I'm very proud of Manoj because he was a DNB student with us, and now he is a really top class vitreoretinal surgeon, and beautiful demonstration. And of course Sendil, our oculoplastic head, and he is doing very well in his practice as well, and wonderful results with Sendil in his oculoplasty work. I'm very happy. Thank you very much.
Thank you so much.
We'll adjourn for lunch now.
Thanks, sir. Thanks,
Yeah.
sir. And post lunch, we have the masterclass 3D surgery show from Dr. Santosh Honawar and Dr. Prashant Baunkule. Please don't miss it. The lunch is served in the next hall called the Sapphire Hall. Please have your lunch and join back. It's going to be a 45-minute session. After that, we conclude the program. Please join us. It's going to be a wonderful 3D surgery show. Thank you.